Hello? Hello! Hi Rika, good morning, good evening, good afternoon, and welcome to another study stream! Yay! Honestly, not as excited for this one because my last two finals, which is going to be today and tomorrow, are basically about subjects I am really not that passionate about. Yay! So we'll get started in just a little bit. Let me readdress this really quick. So just to let you know, today we're going to go over like applied anatomy. So pretty much like our anatomy and motion, and kind of going over some of the muscle structures like we would in gross anatomy. And then we'll be going over pathophysiology, so we'll be analyzing about like disorders and diseases and all that other cool stuff, I guess, for like the lungs and the reproductive organs. How's the exam on Sunday though? Oh my gosh. Okay, so I had to explain it. So for that one, that was for my gross anatomy course, and there's like two sections that are there. So we have the cadaver portion, and we're supposed to have a dry lab. A dry lab is supposed to mean not wet, like you would in cadaver, but the dry lab is normally supposed to be a model, but because we're hybrid students, they do everything online, so we use this program. I was just so upset because the program is so picky. So for the quote-unquote dry lab portion, I could have got 100. I'm not one of those people who are like, oh, Tippa, you got a good grade, shouldn't you be happy? I'm like, yeah, but my GPA. I mean, not that I should really worry. So the program oh my goodness, to stay in the program you need to be above a 2.7 GPA. So that's really that's super easy, you know. I think, what is it, to graduate high school you need higher than like a 2.1, right? Like, you have to be really failing high school. If I mean, don't let anyone pass high school. anyway, so yeah, so that's just like slightly below a B average overall, and I promise you I'm not going to try to get there. But with these two courses I'm about to study, I don't know. Hi Sierra, hi, welcome. Actually, speaking of welcomes and all that, oh wait, but let me finish my story before I say my hellos. So basically after that, what had happened was, for the wet lab, I think I did pretty good. Oh, I got my grade. What do you mean I think? I got it. I actually ended up getting an A, so I'm actually super excited because I'm not gonna lie to you, that test was really hard. It wasn't about the information we learned this section, which sounds weird. He's like, oh, who cares about the organs and the reproductive organs and like all your insides and the intestines? Whatever. You know what? You're gonna learn more about the leg and do more with the leg, and that's what I want you to know about. And I'm like, sir, why did I spend like 5 hours in the cadaver lab looking at all these? I didn't necessarily look at the stuff that I needed to look at apparently for him. But either way, I got an A. That's fine. I'm done with the class. I passed the class with a 90%, which is great for my GPA. I just recently finished another course yesterday, and I finished that with an 88, so that's sad. That's sad for my GPA because I'm trying to keep a scholarship, but my scholarship dreams are over. I do not care about the scholarship anymore. I care about passing the classes. For the scholarship, by the way, I had to maintain 2 A's and 2 B's this semester. There's no way in these upcoming 2 courses I'm about to get A's in them. Is basically what I'm trying to say politely. So my scholarship dreams, gone. Those 2 other classes, done. So right now I have a final today at 7 and I have another final tomorrow at 7. Today is the one we're going to be studying first, which is again the applied anatomy. And the second one is going to be the pathophysiology. So yeah. I'm a little nervous, honestly, because this course, I don't know if you guys remember me telling you vaguely in like one of the streams where I'm like, oh, I need to really study for this, but my professor gave us a guide and he said, hey, finish it. We finished it, and he's like, hey, even though I didn't give a deadline, you guys waited too long, even though it's a week and a half before finals, I'm not going to give you the answer. Well, turns out today at midnight he put an announcement up, and he's like, actually I went over the study guide, so if I didn't write anything, like, you just have to copy and paste that from your book. All right, good luck everyone, you're gonna do great. And I'm like, sir, I'm in an abusive relationship with you. First you tell me I waited too long, then you said you're not gonna do it, and now you do it randomly on the last day. I hate it. I hate it. So we'll see what he wrote. I kind of copy and pasted it in there, and it's kind of a combination of notes that I did in class with a few classmates, whoever else did the actual study guide, and then whatever the heck he wrote. So wow. Oh, it's 7 p.m. 7 p.m. So like I said, my program's hybrid, so 7 p.m. is just to adjust for anyone who might be working today. And a lot of us normally work day jobs and they get out, you know, like 5 or 6. So 7 is that like leeway, if that makes sense. But yeah. I feel like I was gonna say something else. Well, nope, I don't remember. Either way, there's a billion things I would like to do other than study, but I have to study for this because Levi, thank you so very much for the follow. Welcome to the Cup Club. Welcome. Other than being in that quote-unquote abusive relationship with my professor, I also don't have the best grade right now. I think I have a 77 in the class, and I really want to go off strong with a B. I don't know how this is going to affect it, but even if I could get to a 79.5, I'll be super happy with it. The reason why I'm doing more poorly in this class is because I actually bombed the last exam. I was really upset. Everyone did really poor on this exam, but I bombed it. Like, oh my gosh. And so my A that I had brought me down to a C, and I asked my professor, I'm like, Professor, is there anything I could do to bring my grade up? And he said, oh, just do the practicals and we'll see. I was so mad because the lecture and the practicals are basically 1-to-1, but I think he wrote the exam in such a weird way, and a lot of other of our classmates were also agreeing that he must have wrote this like last minute because the formatting wasn't the same and I was asking such weird questions. But yeah, I'm so sorry. That's me rambling. I'm just trying to say, like, look, I got a 98% on that practical. What do you mean I got an F on the written? Ah! I'm sorry, I didn't mean to scream. But Jaden, mommy, thank you so very much for the follows. Welcome to the Cup Club. Welcome. I'm so sorry, this is like your first impressions of me. A, I'm studying, B, I'm ranting, and C, I'm screaming. I'm so sorry. But thank you. I appreciate you all following. Thank you, and all of you cubs being here. Working a busy day job and then going to write an applied anatomy test? Honestly. I don't envy that. I don't. I don't at all either. Hopefully I'm waiting to hear back from this new job that I applied for, so it's a little bit better for my schedule and my wallet. We'll see. Can you take the time machine and redo? I wish. I tried to explain it to him. We had a meeting and we went over the exam, but he was like, yeah, you just pick like everything opposite. So you're saying I have understanding of it? Yeah, but not quite. So I'm not gonna adjust your grade or anything. Okay, fine. No worries, to be honest, I feel your pain in college. Let's go! College cups, college cups, college cups! Here, I'll get started. Let me say my hello. So I feel so rude. One moment. Robo, hi, welcome though. Sunny, hi as well. Is it Tipanya time or Pathophysiology time? It is both, actually. Hi Atomic, hi, welcome. Hi Rip as well. Me and Rip were just playing Fortnite together a little bit before stream, so please do give her your support. It was her birthday a few days ago, and later this week we're gonna, play Fortnite. So, play Fortnite. I mean, I guess we'll play Fortnite. That's also her birthday collab, so yeah, please give her a follow. Thank you. And VTuber, VTubers are us! I'm honored! Thank you so very much for the follow. Welcome to the Cup Club. Welcome. And Dice, I'm so sorry. I'm so sorry. My pronunciation is so bad for a lot of things. Thank you so much for the host, by the way. I appreciate ya. I tried to raid, but I glitched out, so host it is. Do not worry about it. I appreciate you either way. Welcome, and welcome, hosters, raiders. Wait. Oh no, thank you for the head pats. Wait. Let me cough up my lungs really quick. One moment. Yay. Okay. Hi, welcome hosters, welcome raiders. My name is Tipanya. I'm a bearcat VTuber. I do the gal and then yes. It's very nice to meet you. Host links? Let's go! Pakyu, thank you so very much for the follow as well. Welcome to the Cup Club. Welcome. That says sus instead of us? Oh, VTubers are sus? Oh, either way, nice to meet you. Nice to meet you. But no worries. Today we're gonna be doing a study stream. I'm just gonna catch up with chat really quick. Glasses! I'm gonna catch up with chat really quick and then we'll get into it, okay? I don't know if I could wear glasses. I would switch over to glasses, but I only updated tracking for one model. That's the only reason why I haven't switched over. Would you still love me even if I don't have updated tracking? Is that a thing? Anyway, I'm so sorry. I keep meaning to go through. I'm so sorry. Atomic, hi, welcome. Riv, hi, welcome. My hi, welcome. Besties, hi, besties. Hi, Seer again. Welcome. Hi, Lim. Ooga booga. What page are we on? Ooga booga. I haven't started studying, so no worries. We're on page 0, but technically we're on page 27 of my study guide. But who's really counting? Welcome. Oh, your browser history. Hi, welcome. I appreciate you for stopping by. Thank you for the kind message. I appreciate you. Thank you. Bear says, bite him? I will. I'm so ready to. If I don't get a good grade on this exam, and again, please hear me out. I'm not one of those people I didn't get 100 on this. I don't care. If I get an A or B, I don't care. But if I get a C in this, it's just gonna not be too well because these are the foundation or the baby courses. So why am I getting a C in a baby course when I'm gonna have harder courses that I might need that buffer for? So I'm really gonna try my best on this, so please forgive me. Okay. We're gonna be studying together and learning as it goes, so yeah. But yeah, BKM, hi, welcome. Thank you, by the way, for the head pats. I appreciate you. Welcome. And OMG, hi, welcome back. I hope you're having a great day or night so far. I am. Oh wait, they're sussy? I know, just a little. Oh yeah, I'm not us, I'm sus. Just a humble Twitch mod? Either way, a pleasure to meet you. Thank you for joining the Cup Club chat. I appreciate ya. I promise I'm not sus by any means. I am the most unsus bearcat there is. Ever. Anyway, oh no! Lynn! Hi! Thank you for a tier 1 sub for 6 whole hecking months. Half a year. Here to support our hardworking bearcat. Thank you. I appreciate it. Thank you. Wow. I'm gonna work hard. What was I doing though? I was gonna study. No, I was gonna put glasses. You know, I actually haven't tried the new iPhone tracking with the new model. So I guess I'm gonna disappear for a Ooh, I'm only left with my hands. I'm so sorry. I just want to try this out because I'm curious. But it's okay if it doesn't happen. I will just refund you the points. Wow. Shira, hi, welcome. Here, one moment. Baba. No, it's too weird. I can't do it. It's too weird. Because look. Hold on. Wait, I lost myself. I found myself. I'm too big. I don't have the face shapes here, so I just look like I'm speaking like ang. My mouth is not that big when I speak, I promise. But this is not it, Chief. I will put glasses or I'll refund you. I promise. I know sis when I see it. I mod for some sussy bakas. I promise I'm not one. I promise. But one moment, switching back. Ah, so jarring. So spooky. And any moment. Do. Da. Alright, let me switch myself over here. I'm so big, I'm so sorry. Is this normal height or do my hands look too big? Heck, am I covering chat too much? I never know with this. Heck. I think this is... Oh, okay. Anyway. This is fine. It's whatever. I have big hands. It's the better to hold, my dear. Anyway, let me take a quick sip of water really quick, and then we'll get started for this applied anatomy business, okay? We don't have that much to go over. Let's see, 27... We got like 20 pages. That's like baby. Especially with our previous, what do you call it? Our previous study stream where we spent like 4 hours going God knows what. Oh my goodness, I don't remember. The tip grip? Exactly! I have the hand grip of like a 10-year-old, unfortunately, but it's the size that counts, question mark? Ooh. Hi pals, hi, welcome. Let me give you a shout out while I go drink some ice, cold, refreshing water. I also have some coffee, but I was waiting for it to cool off, so... Wamp. Alright, oh, that's what I forgot. I was gonna set up a Pomodoro timer, but I think we'll just kind of go through what we can go through, you know? Pals! Thank you for 10 what's up for 19 hecky months! Baba booey! Thank you so very much. Oh my goodness, it's actually been a really long time. Holy heck. No auto resub? Whack. No, you're good. You're good. Thank you for your continued support as a sugar bear. I appreciate you very, very much. Baba booey. Anyway. Yeah, let's just get started. Let's not do the Pomodoros for weaklings, and we're mentally strong. Just for today. So anyway, so how this is going to be formatted is that he like I said earlier, he gave us a study guide. I'm going to show you what I wrote in class, what my classmates had wrote, if they wrote anything different, and then his notes, and then we'll kind of all try to understand it together. There's a Quizlet as well that's going to that we're gonna use and try to go over once we're done with the study guide. We'll take a little mini break. We'll see how I'm feeling personally, and if I have to take a little small lunch break, I will. We could watch some, I don't know, cool YouTube videos. I could be those cool kids, or TikToks. Okay, maybe not TikTok. Some of those are like really targeted towards me. Or yeah, YouTube sounds great. YouTube is great. And then we'll kind of go from there, and then we'll switch over. Hopefully after I eat, I don't sound like a smoker, and life will be good, okay? Your streams are so nice and chill, perfect for after work and dinner. Thank you, I appreciate it. That's actually really, really sweet. Thank you so much. And hi Matt, hi, hello. Interesting that we're on an education stream, but also I love the model. Thank you, I appreciate you. Thank you so very much for the follow. Welcome to the Cup Club. Welcome. Yeah, I like to go over some of my notes because Well, I'm gonna explain my big spiel, but basically, me verbalizing it, me being able to quote unquote teach it, really helps me learn. So welcome. So let's go through the study guide. So again, we have about 20 pages, so we're gonna start with the first question. I mean, where else would we start? But so during goniometric measurements, what is the purpose for determining end field on the first repetition? So let me break it down for you cubs really quick. So goni stuff is basically a tool to measure your range of motion for certain things that you're able to do. Like in this scenario right here that we see in this picture, we see this person is doing I'm like, technically they're knees flex, but this is not how you'd measure knee flexion. They're doing hip flexion. And so the goni is a maybe it'll be better if I pull up a picture really quick. Goniometer, da 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 da. Every time I keep Google imaging for whatever reason, I keep accidentally press shopping instead. So I'm like, oh heck. Oh, this is a big boy. This is a big one. So this is our goni, right? So the goni is really cool because you're going to have a fulcrum, or the axis of rotation, a stationary arm, and a movement arm. So in this scenario, we would align the stationary arm to the greater trochanter, which is like a bone right here on the side. Or no, we wouldn't. Oh my gosh, hold on. We're doing hip. Lateral side of the thigh. Lateral side of the thigh. This would be at the greater trochanter. The axis of rotation, our stationary, is going to be... No, I'm messing up! I keep confusing the hip and knee. Either way, no, there's 3 measurements, and I promise I'll be able to measure if I have a person in front of me and be like, okay, let me align this right here. Verbalizing it, though, sucks. I'm better at putting it and being like, oh, this goes here, that goes here, this goes here. I'm so sorry. I'm trying to teach them, like, I don't know. I don't need to know about this kind of measurements right now anyway. We just have to determine the end field for it. Oh wait, Matt says in way too that probably half the stuff I learned in school is obsolete, so I usually teach him stuff things I want to know nowadays, but this is cool to learn. Oh no! Don't worry, you're never, like, what do you call it? That knowledge you learned in the past is also still equally as valuable. It just might be, I don't know, slightly updated. So don't worry. A lot of this, again, it's going to be human anatomy and body based, so feel free to chill out if you want. Oh no! You're drawing? No problem, Atomic. Thank you for lurking. Good luck with your art. I would love to see it. Please share it, okay? Share it in the Cub Club. Peer pressure, peer pressure. And no, you're good, Matt. You're good. So when you're doing the goni measurements, you want to see if they're actively able to do it and if they're passively able to do it. Active means basically that the patient is able to do it themselves. Hey, can you bring your knee to your chest? Passive, on the other hand, is going to be the clinician moving it back, as we see here. We're going to bring the knee back to your chest. When they bring the knee back to your chest, there's supposed to be like an end feel or a feeling of it. It kind of depends, honestly. Thank you for the head pads. Thank you. But basically, you know, you're not able to move a certain muscle anymore. Like, oh, that's as far as I can go, basically. That's pretty much the quote-unquote end field. And so you're gonna have 3 to potentially 4, but he didn't really talk about this 4th one too much. And they're gonna be, hold on. Sorry, I just ate right before stream, so I'm also like borderline smoker voice. Wah. But yeah, the end fields you're gonna feel are firm, which are pretty much for like most things. We also have soft. Soft, a good example of this is doing elbow flexion. So if you're gonna do like a quick like bicep curl, or you know. Oh no! Ian, thank you so very much for the follow. Welcome to the Cub Club. Welcome. Pretty much you see how it's very soft, like both of your muscles are kind of touching each other. That's going to be a soft end field. And a hard end field is going to be bone to bone. A good example of this is kind of putting your hands out flat, and you're going to be doing ulnar deviation. Ulnar deviation is basically bringing your pinky to I'm like lateral side of your arm. How do I say it? if you have your hands flat with the palms down, radial deviation is bring your thumbs in towards your midline, right? That's going to be a firm end field, while a hard end field is moving your pinkies out to the side. Does that make sense? I'm so sorry. I wish I could show you my hands. Hand cam, hand cam, hand. No, I'm not gonna do that right now. I am not mentally prepared for a hand cam right now, so maybe I could get a cute image or something. I'm also not gonna be here too long because I'll go to work, but if you're here when I finish, I shall rejoin. Yeah, no peer pressure. Just thank you for joining. Do what you have to do. There's absolutely no rush. But good luck with work though, okay? Thank you for stopping by. I found it. yeah. So this is this person's right hand, right? So if you put your right hand out and you go a little in, that's gonna be radial deviation, and then you shake it all about. You go the other hecking way, you do ulnar deviation out. That's what it's all about. So yeah, that's the deviations that we're talking about, and that ulnar deviation I was mentioning is going to be that hard end field, while the radial deviation, bringing it in, is going to be soft. The music's also nice, thank you. I appreciate it. I like a little bit of the lo-fi, and I'm glad it's not like too loud or too quiet. I love studying complete silence, but I don't want to hear myself in complete silence. And no pressure on the hand cam. I know a lot of YouTubers do it due to anxiety. Oh yeah. I don't know. I'm kind of a private person. I mean, but once things come out, I guess I can't stop it, right? I've just always been a private person in general from my like very young age on the internet. So I'm just like, oh, that's a little embarrassing. Hand cams are not so bad, but I'm not set up. Knowing my dumb booty, I'm just gonna show my face. I'm be like, I'm so sorry. I did just roll out of bed. I did just roll out of bed. I did just, lay in bed looking at like TikTok, then deciding, hey, I want to play Fortnite because Dragon Ball Z characters are out today. Oh, it's time to stream. Okay, let me go eat. That's a good mnemonic device right there, honestly. Also, I do cake, but when I eat bread, I get hiccups. I'm sorry. I don't know the bio. I don't know the factors going into any of that, unfortunately. Yeah, I'm also gonna guess you're having bread. But I hope your hiccups stop. I'm cursed. I only hiccup like once, and I'm like, I'm done. But yeah. Okay, so we went through a firm end field, a soft end field, and now let's go over hard end. Oh no, we already went through hard. Let's go through empty end field. So this is not an end field that he wanted us to know, but this is something I was finding through the literature. So empty is basically an abnormal end field, aka there's no end field due to like maybe inflammation or pain that might prevent full range of motion. So you have the patient maybe do this motion, but they're like, ow, I can't do it. And it's like, oh, okay. Never mind. We're not doing that. We could not assess end field. We're going to have an empty end field because of that. Only one hiccup? Lucky. No, because then see, if I hiccup more than once, it's cursed. You ever have one of those days where you're just like one bad thing happens? I mean, hiccuping multiple times is not one of them, but let's just say it is. That just determines my whole day, and I'm like, oh gosh, it's gonna be one of those days. 2 hiccups today? Man. Yeah. I ran out of breath and I'm dehydrated in one moment. It's so hot at Bearcat Mountain. I'm so sorry. I am okay, I hydrate again. It's just been so hot lately. I'm not going through like the heat wave like all you guys are doing, but holy heck. 3 hiccups, your week is over? No, not my week is over. It has to be 7, 1 day per week. No. If it helps, my memory doesn't go that far, so it's just like, remember when you hiccup 3 times? Nah. Anyway, so let's go back to the original question, because I know I went on some tangent, so you have to forgive me. That's just me as a bearcat. So during GONI measurements, what is the purpose for determining end field for the first repetition? So we want to assess the quality of the end field, so that's why we're going over that list of firm, soft, hard, or the empty, and maybe even the quality. How many times can they be able to do it? But that's not really something that we look at when doing this. Again, it's more for the quality than the quantity. Quantity we'll talk about a little bit more later. So the end field allows us to feel if the joint is moving normally. So like I said, we can have that empty one if there's an abnormal end field because, hey, that patient's not able to move through that. It would be actually really more of a concern if our passive range of motion had a different end field than expected. So remember we were talking about the ulnar deviation or bringing your pinkies out? That hard end field, if it was somewhat soft for whatever reason, what could it be? That's so weird. There's definitely two bones touching each other, so is there like inflammation or maybe like a weird cyst, bubble, sac filled fluid thing that's in between that's creating that soft end field? And if so, that's probably why this patient might be having a little less range of motion while doing ulnar deviation than normal, because hey, there's something there. Also, it's really important to determine end field in the first repetition so we can avoid muscle fatigue, because we have some patients who are really deconditioned. Like, they're not able to do a lot, which is perfectly fine. Motion is lotion for the body, and the patient should be able to do as much as they can, you know? And if that's their limit, that's fine. At least they were able to try. They might be guarding, so not like an on guard kind of thing, but sometimes patients know that it may hurt to move that certain direction, like let's say the hip flexion, so they'll avoid it, so they'll do muscle guarding, and it'll make it very hard to have them passively move through that range of motion. And kind of in the same hand or same coin, apprehension is also another factor to kind of look for and try to determine the end field, because if we're having it do multiple times, it's like, okay sir, ma'am, what are you doing? What's happening here? Hi Matt, hi, welcome, hello. welcome. So, moving on to question 2. Why must the patient go through active range of motion prior to the therapist applying pressure or resistance? So one of the key things we want to know, especially when doing manual muscle testing to assess the strength of a muscle, we want to see if a patient's able to do full active range of motion to see if they're able to do it against gravity. So I have a scale right here. This is basically our MMT, manual muscle testing scale, and this is what we use. It's subjective. It's a very subjective, a scale, unfortunately. But pretty much, if the patient's able to do it against gravity, like let's say, hey, are you able to bring your arm up to the ceiling? Oh, okay, cool, you have really good, like, shoulder flexion, and you're able to do that? Hey, you made it full range of motion against gravity. Then around 4 or 5, this is when the therapist is going to start applying pressure, and the pressure is also subjective. But apparently we're trying to make it more objective by saying, hey, I put down 30% of my strength, this patient is like a 3+, and it's like, what is really 25% of your strength, you know? Tippa, can I DM you about something? No rush? Yeah. Feel free to. I'm probably not going to be able to look at it until I take like a little mini break, or maybe even after stream, but yeah, no worries. I hate it when doctors try to do this heckery to me. Oh, I'm sorry, Matt. But it's really important to do this kind of stuff just to see, like, hey, is there any muscle weakness here? Yes? Okay, how can we strengthen it? Because if you're weak in doing certain ranges of motion, then you might not be able to do the things that you had enjoyed previously. Like, hey, you're not able to get your shoulder all the way up? What happened? And why are you having this limitation? Is it weakness? Is it fatigue? Is it we'll talk about that later. Like, what's causing the limitations? Let's assess it. And that's why it's important to kind of do these manual muscle testings. As much as they suck, I do not get me wrong, I've been the subject of many MMTs. They are not fun. I had to do what was it? Trunk extension? So basically I had to lay on my back, or no, lay on my stomach and like curve my back curve my back up, so like a little C shape, and I was supposed to hold that position while someone, used gravity to push down on me. I am not gonna lie to you, Cubs, and I'll be honest, I do not have any strength in my abdominals. Leg strength, cool. Arm strength, abdominals, non-existent. So I'm like, I'm so sorry. They're like, yep, my patient broke under 20% of my pressure. I'm gonna give them a 3. Thanks. Remember last time I went for a physical type of thing and they just treated me like a hecking poking toy? It was annoying. Oh, I'm sorry. They're supposed to treat you with respect and kind of explain what the heck they're doing so you don't feel like that. I mean, obviously these are the procedures that they have to go through, but I mean, how do you call it? Okay, this is gonna be a tangent, but basically this kind of goes back with the idea with my professor going with the informed consent. When you do informed consent, you basically have to introduce yourself like, hi, my name is Tipanya. I'm a student here at the whatever Bearcat University. Yeah, that's the full name of my university, by the way. And I'm here today because we're going to do MMT, or manual muscle testing. Manual muscle testing is going to be an assessment to assess the strength of your muscle. What I'm going to be doing is to see if you're actively able to do this motion, and if so, I'm going to apply a force. Don't let me break your form, and then we'll rate you on a number from the scale. If that's not something you're up to, we can do something else, but I highly recommend we do this so we can get a baseline. And do I have your consent basically to do this? You basically have to go through all the steps of informed consent, and hopefully maybe if they had done that for you, maybe you would feel more comfortable. I remember having to do something very similar when I was doing rugby, and it was a woman. Yeah, it didn't work because she asked one of her colleagues to do it because apparently she wasn't heavy enough to crack my back. Wait, cracking back and all that, these are two separate things. Wait. You have me here like, oh my gosh, I'm so sorry they didn't like inform you about all this. It's like, no. Anyway, so yeah, so why must patients go through active range of motion prior to a therapist applying pressure or resistance? So this again is to see, hey, are they able to do it? Cool, it'll be 3 out of 5. If they're not able to do it against gravity on their own volition, then we're gonna give it either a 0, 1, or 2. A 2 means that they can do it, they can do the full range of motion, but it has to be in a gravity eliminated position. So let's say, again, let's use the example of the shoulder flexion. So hey, you're not able to bring your arm all the way up to the ceiling? No worries, because you are going against gravity when you do that. Why don't we do it sideline? Or why don't we use this towel to see, hey, are you able to do it here? And then, I'm too lazy to get like MS pain out, but it's like, oh, you're not going against gravity if you're doing it sideline, so they're able to do it, yay! But for whatever reason they're not able to do it, and maybe they do like a little bit of it, or maybe we could feel some palpation, or yeah, if we're able to palpate or see some visible contraction, then we would give them a 1. And if we see nothing at all, it's like, okay, do the motion, and there's nothing, it's gonna be a 0. So my professor wrote, it's important because you can later compare active range of motion versus passive range of motion. So wait, what does this mean? I'm so sorry. I only formatted the guide, I didn't read it. Why must the patient go through active range of motion prior? I mean, I get this, I guess, but I would always do passive range of motion, then have them do it actively, 3 times, and on the 4th one you're gonna be like, okay, now hold this position, we'll put you mid-range. So I think it's really weird to be like, yeah, this. But yeah, you should always have them do active range of motion to see if, again, they could go against gravity. That gives you your baseline too. Anyway, so question 3. What are the characteristics of normal active range of motion? So active range of motion is going to be less than passive range of motion. So let's say you are struggling to put your arm up, right? So that's going to be a struggle with active range of motion. But if I were to passively move you, like, hey, don't contract, I'm gonna just move your arm up, you should have more degrees of motion or more range of motion, me passively moving you than actively moving you, because I could push you to your end field with like no or very limited restrictions. Another characteristic of normal active range of motion is that we do want to assess the quality and the quantity in the motion. The quality in this case is going to refer to how smooth that motion is, or if there's any deviations. Basically, overall like fluidity. So it's the idea of like, hey, arm up, oh, you're kind of going at like this weird 45-degree angle. That's a deviation. When you're assessing active range of motion, you want to assess an individual's contractile tissue. So the same thing about like, hey, maybe they weren't able to do it against gravity. Can we palpate here and feel a contraction? And at least give them a score of 1. Or in some cases, that's not even really applicable. 2, the ability to perform the activity. Hey, are they able to even do the motion in itself? Are they able to do it against gravity? Or are they not? Should we put them in the gravity eliminated position? And 3, the willingness to perform, because this kind of goes back with the passive range of motion stuff that we were talking about, in a sense that, hey, sometimes the patient might be guarding, they may be apprehensive, or again, they're just scared. Maybe they don't want to move that way because they maybe haven't moved that way in a long time, or hey, moving that way causes them pain, so why am I gonna do it, you know? Oh, Matt says I would hate being any sort of doctor or physical therapist. I know it's a pain in the booty considering the heck you have to deal with. That's okay. It's the idea that I didn't work this hard not to be passionate about it, so I might as well kind of go through it and see how it goes. And if it ends up being like a hecky position, then heck. But from all the times I was able to, how do you call it, observe other people who are already in the profession, I really like the career. Like, I don't know, there's something about it, and I was able to click with a lot of people, and to see them kind of start from like their baseline to see where they were at the end was just really rewarding, and it's just something I want to do for a lifetime if I can, if my body allows it. Well, hi Sage, thank you so very much for the follow. Welcome to the Cup Club. Welcome. But yeah, she says all of this is very interesting, to be honest. I like hearing about anatomy when it's not about organ. Oh boy, do I got you. And a little bit later. But yeah, no, I completely understand the organs and like general biology. I mean, biology was a good topic, but like that kind of stuff is not my forte either. What do you even study? Because I haven't got a Scooby. I can't remember what it's called. I'm like basically a kinesiologist, if that helps. Kind of. Sometimes I'm afraid of like outright saying it because someone's gonna find me and I'm gonna be like, oh heck, you found me. Hydrate though, I got you. I love hydrate. I'm already almost out the water. But yeah, tip embracing the support role IRL. Honestly. What was it? There was like a Reddit post that, or screen cap that was going around many years ago. Rosalie? Whoops, pressed the wrong step. Hi Rosalie, hi, welcome. Thank you for the tier 1 sub for 25 little hecky months. Do not worry, I appreciate you. Wrong button or not. Welcome. Oh my goodness, thank you for your continued support of the Sugar Bear for 2 years plus 1 month. Let's go. Anyway, so yeah, Reddit post, It was something about Overwatch, and basically how they're like cohort. There's a few people who had played Overwatch, but all of them had played support roles because they were all in like medical school or something. So I got too excited. One moment. Bleh. It was just really cool or cute because like, oh, they're all in medical school, but they all are playing support, but we need a DPS and a tank. Woo, this sucks. But yeah. Huh? What the heck is that? Someone who specializes in movement, basically, Matt. I like biology when it's not about fleshy, gooey, or liquids. Same. I think biology was very fun, but I might be biased because everyone's like, oh, do you like biology or chemistry? I will always take biology over chemistry. Chemistry can go heck itself. So I'm so sorry to my math loving cubs out there, but I'm really bad at math. It all started back when I was in 5th grade, where I got my first F on a math exam, and I knew from there it was all gonna go down. I don't know, I do really poor in math. Not like really, really bad. Not offensive, but I did not enjoy it. And I had like a really bad algebra teacher too. He was like a football coach, and we had like a lot of his football students in the same class. So as you see, I didn't really get to like learn a lot. And so it all went downhill, and then of course I had to take chemistry with quantitative analysis, and I'm like, what and it's like convert moles, and I never learned converting. I somehow got through chemistry 1 and 2, and I'm like, how do I convert? Stairs in biochem horror? I'm sorry, Varys, hello? Varys Valgus, let's go. No, I'm so sorry. If you are studying biochem though, I respect you. I mean, I was gonna respect you regardless, but now you have more of my respect. Organic chemistry can also go heck itself. As someone who's never taken the course, that's also probably why I went more of movement science specialist route rather than actual doctor. Stay away from my joints. I can't. Start next week, but soon, TM? You got that down and trademark? Let's go. I wish you the best of luck. I can't believe you're already starting school. I'm about to go on my 2-week break. Hold on. Best of luck with biochem though. Honestly, it's gonna be super fun and rewarding, but boy, is it gonna suck initially. But I think that's with anything. Chemistry isn't exactly something you can apply as often as math either. I politely forgotten just about everything from chemistry. Same. Same. I feel so bad, but it's also been a little bit for me taking chemistry because so how Bearcat School works, so the Bearcat School that I'm in, you needed to take some prerequisites, bio, chemistry, anatomy, and for whatever reason, the spirit of academic success possessed me. And it was like, hey, Tippa, excuse me, yeah, you should just take these prerequisites as early as you can. And I'm like, okay, and so I did. And so because I was so early in my college career, I've kind of forgotten them, so it's kind of eh. Posture check, hold on. Let me sit from my chair, let me lean back, let me twist, do the little twisty twist, da-da, da-da-da, and posture checked. LMG says, oh, I get that, to be honest. I know a lot of people that don't like chemistry. I'm impartial to chemistry because it's needed for machines and metals, which I'm more interested in. See, I think that's fun and exciting though. Again, chemistry would be fine, I just can't do math. That's basically it. That's me complaining. That's me saying like, hey, I had a poor foundation in Bearcat Mountain for math. So math is not very enthusiastic about math, but I have some mathematician friends who are like, they're very passionate, let's just say that. Just as I'm passionate for anatomy. Anyway. Let's go back to it. Where were we? What are the characteristics of normal range of motion? Okay, when assessing active range of motion, you're assessing the tissue, the ability to perform, and the willingness. So one of my classmates wrote, normal active range of motion is moving through the full range of motion independently without deviation and compensations, okay? They either would indicate that the intended muscle is not activating or the patient's guarding. So this is referring to those deviations that we were talking about earlier. So why check active range of motion first? So, So I guess in these like special scenarios, why would you check the active range of motion first? Because at the end field, you don't give the patient time to adjust, modify, or potentially aggravate it. When you assess passive range of motion, you are assessing their end field to see about their capsular, I think they meant pattern, there was like a word missing, ligament, the bursa, the inner tissue, and the elasticity of the muscle when placing the muscle in the opposite direction, somewhat like an MLT. An MLT we talked about a few study streams ago, that's muscle length testing. thing. Basically, if you were to how do you say it? So hey, you know that your biceps flex your elbow, right? Hence, like, you know, those bicep curls to get those big beefy biceps, right? Well, let's say we did the opposite of that motion. What if we flexed you, or no, extended you? If you basically do the opposite motion and you apply a small force of performing an action opposite of that muscles, you're gonna get a stretch, which is why all these stretch clinics popping up around Bearcat Mountain are a hecking scam. I want to apply for the scam, but but basically, to be able to stretch, you just have to basically put the muscle into this different action, and we'll talk about that a little bit after I catch up with chat really quick. Rather, hi, good morning, Miss Anya. Good morning, my fellow cub. Welcome. Matt says, I had a feeling that you would absolutely be horrified at my range of motion considering how much heckery I broke and pulled. Are you saying that your range of motion is really good or is it really bad? I'm gonna assume it's really bad. You have to be really careful with that. Maybe you should go see like a physical therapist or something. LMD says, yeah, it's a lot about how you were presented with these subjects and who was teaching you. It is! I had a lot of nice teachers, minus math. It's heck? Oh, I got ya. Absolute dog poop? Got it. You have to be careful because then you're gonna have limitations while you grow up. You know, our bones don't get better, unfortunately, and our body doesn't necessarily get better as we age. Everything's a little bit slower to heal, or we're not able to have that range of motion as much. So, and the more that you're able to strengthen and stretch and do all those cool stuff and regain at least in normal range of motion, better quality of life is basically what I'm saying. I have to leave. I can only stop and say hi. Oh no, do not worry about it. Do not feel obligated to stay. Thank you for stopping by and say hi. I appreciate ya. I have to learn from ya because honestly, I always politely lurk. I'm like, I should probably say hi. Nope, I will stay here in silence. I do that a lot for big ham streams and I don't know why. Because I'm like, oh, I'm doing something. I want to converse with Big Ham, but I'm like, oh, I'm so sorry. Anyway. Matt, but no, please have a good one. Thank you for stopping by. Matt says everything hurts when I moved the other day, like I pulled my bicep. Go see your primary care physician. Go seek medical attention if you have health insurance. Please. Sorry. That's all I can say as a student. Would you say being flexible when you're younger will improve your physical life when you're old? 7+? Yes! Oh my gosh, do you know you're British? Oh, then alright, doesn't that mean you're good? I'm sorry. You know I don't know the British. I don't. Yeah, exactly. You just have it. Exactly. You're good. You're Gucci. You're on brand. You're good. Here, oh my gosh, this is like a slight deviation, so I apologize. Hold on. I'm gonna show you Cubs something really quick. I have to dig through my TikTok though, okay? One moment. So there's this guy that I follow, and oh my gosh, I have to dig for this. Heck this! Why did I have to be on TikTok for the past 2 days? What? Oh, there this man is. How do I do this? Ness, hi, welcome. Oh my goodness. So there's this guy, and his TikTok or I guess social media in general is called Movement by David, right? He is so crazy to me. Oh my gosh, let me see. Whoa. No, let me see if I could get the other ones really quick. He is so crazy. I wish I could show you the one that I found him drew. Not regression. Heck. He makes so many cool videos. Heck. But there's one I want to show you really quick because I thought it was crazy. Okay. It's time. It's TikTok time. Oh my goodness. I don't think I've ever been to anyone from your profession. I highly recommend it, Matt. Do it. Live your best life. Alright. We're on the TikToks now. We're here. Unfortunate. Hopefully this is loud enough though. Oh, I muted this.
Grip. Instead of just how strong is your grip? Believe it or not, you do not need equipment to train grip. Instead of just picking one exercise to do over and over again, I find it best to do one set of each of these exercises, and it improves a whole lot faster.
It's just how he grabs stuff.
Grip that you see usually during a handstand.
That's crazy.
Second, there's the closed hand grip that you would use while steering a car. And third, there's the pinch grip that you would use to pick up your favorite John Green book. For the open hand grip, do floor presses or wall presses. The more weight
my wrist would cry though doing this.
Difficult it is. The goal is at least 10 reps, but do it till you burn out. Next is the closed hand grip. My favorite way to train it is cross the thumb over, grip just like that, and pull your hand toward your wrist as much as possible. You'll feel it start
basically
to cramp.
MLT.
Just avoid pain, but feel that flex. Hold for 30 seconds. And third is the pinch grip. Just grab something that you can comfortably hold in a pinch and hold it for 30 seconds. After one set of each of those, your forearms should feel pretty pumped out and your grip strength will improve. Stay flexy.
He's just so like this is not the video I found him through.
Have to be weak all the time. Yes, this is real strength. Yes, you can achieve it if you have function. You just need to lean against a wall.
It's so crazy.
Does this hurt your wrist?
Yes. Sorry, I'm gonna watch this now.
You just need a simple regression. Place your hands on the wall and press away like that. The further down your hands are, the deeper the stretch as you do it, and the further away you step, the harder the rep. Your goal is 25 reps for wrist mobility. Stay flexy.
Thank you. That's a cute thing. Anyway, sorry, I'm gonna find the actual video I found him through, but he's just so crazy to me. Oh, this
are so important.
Look at his rotator cuffs. Look at what he's doing.
And most people say not to do dips in this much range of motion. And for most people, that is actually
so
good
crazy.
Advice because you can tear, strain, or pull your rotator.
Okay, I'm so sorry.
The only reason why that happens is because
I'm not gonna get stuck watching his videos. But if I were, no, I think these are his older videos anyway. But if I were, I'm just letting you know this guy is absolutely crazy with like the stuff he's able to do. And I forgot there's like a certain name that people do. It's like it's exercise routine that focuses on both stretching, flexibility, and strength. Let me see. I just want to find the other one.
How are you so strong without looking so strong? As much as I love and respect the sport, bodybuilding is not actually my sport, even if my wife loves my lat spread. I'm mostly focused on body weight strength. The ground is really hot. And a range of motion gains.
So crazy.
But Jujimufu is a great example of how bodybuilding and flexibility actually can coincide. Stay flexy. How are you?
Crazy. Anyway, sorry, I'm getting back to the cool lo-fi. Anyway, I would have face planted in that first handstand. Me too. Honestly, I'm not able to do those crazy mechanics. Even when I was like much younger, I wasn't able to like do anything crazy. I think I did like not a cartwheel. I rolled. What am I trying to say? Like, you know, you put your head in, you tuck your head in, and you just like roll. A cartwheel, I think you have to like go on your hands and go more to the side. Yeah, I don't know. This is probably why I never broke a bone in my body, because I wasn't like crazy or hyper enough to do these kind of activities. I can grab 345 plates with one hand. I don't think that's good in the sense that I think your hands are still healing, but I appreciate the effort. Oh my goodness. Anyway, I'm so sorry. I have a study guide. Oh my gosh, we're only at question 3. I'm getting distracted. I'm so sorry. Anyway, so what was the question again? What are the characteristics of normal range of motion? So basically, know that's less than passive range of motion, and we should assess the quality and quantity of it. Why? Because basically we have to check for any deviations to see if someone's compensating, or seeing if the intended muscle is not activating, or even if the patient is guarding. So what our professor had said is, in a normal active range of motion, it allows the therapist to measure the distance and direction of movement around a specific joint or body part. Yes. While the normal range of motion varies among different joints in the body, the level of flexibility typically plays an important role in the extent of movement around them. Yeah. Anyone distracted more? No. I refuse. I'm gonna politely refuse. Oh no, my hands are hacked. I'm having surgery on my knuckles. They're gone. Oh my god. I'm so sorry. I wish you the best of luck healing with surgery, and I hopefully you get to see a hand specialist. I don't know how it is in the UK, but I think occupational therapists can specialize in hands, so they can help you out 100%. Alright, so that's addressed to the third question, so let's move on to the fourth one. For the primary motions at the hip, internal rotation, external rotation, flexion, extension, abduction, adduction, list the muscles that perform each of those actions and the innervations of each. So I think, we're gonna just go down the list and see how it goes. I'm just gonna read it out. I don't think I have a picture, so this is not gonna be as fun. There are hand specialists, yeah. There's pretty much specialists for everything, Matt. Hand specialists especially, I think, are within the realm of occupational therapy, though. But if you ever need, like, a specialist, we got you. The medical field is amazing in that sort, and people are very passionate about certain things. Like, let's say physical therapy. Physical therapists are very... would you say well-rounded? I think maybe versatile is probably the best way to say it. So yeah, of course, when you think of a physical therapist, you're like, oh, well, they only do muscle strengthening and all that jazz, and maybe they only do lower extremities, so like your legs and hips and after surgery. No, they can also do your arms, your hands. I just don't think there's any hand specialist for PT specifically, but there's other cool things that they do as well. Like they can do pediatrics, they can do neuro, so if someone had a stroke and they're trying to learn how to move again. What else is really cool? They do vestibular, so pretty much if someone has problems with their balance or hearing, they can help train that and do the muscles and help them regain their balance so they're not falling. And they have pelvic health as well, which is pretty crazy. Hey, you're having urinary incontinence, so you're peeing and pooping yourself, basically. Well, physical therapists are able to specialize in pelvic floor and help train those muscles to help you strengthen, so then you don't have those incidences again. Oh no, I hope you don't have to pay too much, but your health is really important, so whatever money it is, you have to spend it. You use your hands a lot, unfortunately. Man, you have old metal in there? That means you broke it before. I hate it here. Anyway, so let's talk about the different motions and the nerves and the muscles and what they are innervated by. So for our first one, we have our gluteus maximus muscle, which is going to be innervated by our inferior gluteal nerve. Gluteus maximus is the butt muscle that most of you are familiar with. It's going to be the most superficial butt muscle that we have. Also recall that we have our minimus and medius. I want to show pictures. Hold on. Excuse me. Hip internal rotation muscle. Excuse me. Was that one or two hiccups? Heck. Alright. So this is a ray. This is an image. But this can help us out explain a few of these things that I'm gonna go over. Where's Peas? No, let me put Peas back. Let me use this disco ball instead. So hip external rotation. So let's say we're seated right now. They're kind of handy to have. Yeah, just a little bit. But yeah. So for hip external rotation, let's say we're seated now. Pretty much bring your knees out to the side is going to put your hip into external rotation. So basically, if you spread your legs, your hips are going to go into external rotation. These are the muscles that are going to help with it. But MKKC, thank you so very much for the follow. Welcome to the Cub Club. Welcome. Oh, I'm sorry, Matt. Hopefully the price you pay to fix it is not too bad. But take better care of yourself. Stop getting in the fights. Anyway, our gluteus maximus is not in this picture, and I'm too late. Oh wait. I'm too lazy to show, but again, it's gonna be your most superficial butt muscle. You can even pat it on the butt. You can even pat it if you wanted to right now. That's gonna help again with that, like the spread leg motion or the knee coming out for that external hip rotation. We also have your obturator internus, which might be a little hard to see. Hold on. SG! I hope stream is going well. I'm very busy with work, but I'm proud to be a sugar bear. SG! Thank you for the tier 1 sub for 25 whole hecky months. That's 2. Yes, count it. 2. 2 years plus a month, so thank you so very much for your support. I appreciate ya. Welcome, 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 and thank you for the 25 whole hecky months. I appreciate ya. Thank you for being a sugar bear for this long. I appreciate ya. Welcome. Ooh, one moment, Cubs. Ooh, ooh, ooh. Oh no! Okay. But I hope work gets better. I really do. Thank you. We're just talking about your butt muscles. So if we're gonna peel all the layers of our butt, so gluteus maximus is out of the way, gluteus medius is in the way, gluteus minimus is out of the way, we have these muscles laying right here. So we have what we call the gemellus sandwich. So not this big muscle right here, your piriformis, the muscle right underneath there. That's going to be your superior gemellus, which is going to be one of the muscles that help with external rotation. Well, technically this whole group of muscles honestly do hip external rotation. You have your superior gemellus, your obturator internus, so it kind of goes, do I have my mouse cursor? Right here. Oh, I forgot I can use my mouse. Wait, here I am using a disco ball. I'm so unprofessional. I'm so sorry. Piriformis, superior gemellus, obturator internus. Then we have inferior gemellus, which is going to be right underneath here, which again, this is the most grainiest picture I can ever pick, so I'm so sorry for doing this. But this is what we call the gemellus sandwich. Superior, inferior, and in between, obturator internus, in between. And then right underneath that, we have the quadratus femoris. All these muscles are going to help with the hip external rotations. Return of butt onion? Kind of a little bit. We gotta get those layers in. Matt says, my doctor said she'd book me for a chiropractor appointment tomorrow. God have mercy on you. I'm sorry. I don't know if chiropractor is what you need right now, though. But again, I don't know your situation. If that's what your doctor says, then no worries. Vera says, butt muscles help with running and moving the hip. Exactly. They do. They're so good. Alright. So let's put this... Let's put this away. Let's go back to document. So we didn't see the maximus, but there it is. The obturator internus, which is going to be between the superior and inferior gemellus. That's going to be actually innervated by the nerve to... I know it says OI. It was just me shorthanding it, so you have to forgive me. Nerve to obturator internus. So the really cool thing about these hip external rotation muscles, or that butt onion that we had just saw, is that their nerve innervations are so easy because a lot of these nerves are named after the muscles that they innervate. So obturator internus is going to be innervated by nerve to obturator internus. Gemellus superior, this is going to be nerve to gemellus superior. Inferior gemellus is going to be nerve to gemellus inferior. Wow, so easy. And obturator externus is going to be innervated by the obturator nerve. Alright, so we'll move on. So we have hip internal rotation. Let's see if I could grab a picture of that. Hip external rotation, or internal rotation. This looks good enough. Fridge, hi, welcome. Oh, I have to zoom in a little bit, huh? So for this one, we're going to be talking about the gluteus medius, which is going to be right here. Hi, Fridge, hi, welcome. Matt says, I haven't been to a chiropractor in about 3 years, so my muscles are very tight. I have opinion. No, I'm just kidding. I hope they're able to help you. So yeah, here's our gluteus maximus. Like I said, most superficial. Gluteus medius, if we peeled this layer off, we would see this. And we would also see the gluteus minimus, which we weren't able to see in that previous picture right there. For the gluteus medius, it's going to be innervated by the superior gluteal nerve, as well as the gluteus minimus, which is also going to be innervated by the superior gluteal nerve. The gluteus maximus, again, is going to be innervated by the inferior gluteal nerve. So kind of think opposites. You think maximus would max it all out. It would have it all. Nope, it has the inferior gluteal nerve, while the medius and minimus have superior. Another muscle we see here is our tensor fascia lata, or latte if you want to be cool and hip. It's lata. Oh, you can barely see the font. I'm so sorry. Tensor fascia lata. You can also see it here as well. This is going to be innervated by the superior gluteal nerve as well. So the stream muscles are going to be innervated by the superior gluteal nerve, and again that's going to be medius, minimus, and TFL. From there we can move over the hip flexion, and actually this image will be a good visual for us. So we have the psoas major, which is this major muscle that's going to come off from our spinal column, insert onto like the transverse processes of the lower spine. I think it's like let's count. Okay, this is L5, L4, L3, L2, L1. Yeah, so the transverse processes of like L1 to L4 come over here, and it's going to insert right over here. This muscle is going to be innervated by the branches of L2 and L3, and this is going to help us with our hip flexion. So what's going to happen with that is, if you're sitting, if you kind of do like seated marches, you bring your knee up, that's going to be hip flexion, as well as knee flexion, but you know. Examples, visuals, kinesthetic learning, you know? We have the iliacus, which is going to be attached right directly onto the anterior surface of your hip. So you see this is a hip with no muscles. Now this is a hip with muscles. The iliacus is going to be right there on the ilium, right underneath the iliac crest. The name is, what do you call it? Easy. If you know anatomy. This is also going to help with flexors or hip flexion, and this is all going to pretty much be innervated by the femoral nerve. Your iliacus, as well as any of the muscles on your quadriceps, which are going to be the four muscles inserting onto the anterior thigh or the front of the thigh, are going to be innervated by femoral nerve. This is also going to account for your rectus femoris, which is not seen here, but let's see, can we get another picture? Quadriceps. Oh, we have a spin picture. That's nice. But hold on. Let me go back really quick. Gracilis is right here. This is this really long muscle. This is the up. Wait, where is it? Because this is the adductor magnus. Oh, never mind. It's right here. It's right here. I'm so sorry. It's this outer muscle right here. And that's going to help with both, what do you call it? Hip flexion, as well as hip adduction, which we'll talk about a little bit later. Adduction, remember, it's kind of like adding together. So it pretty much brings the legs together. So instead of like spreading your legs, you're bringing your legs in. And that muscle is going to help right there. You can feel it contract a little bit when you bring your legs in. So yeah. Quadriceps are going to be all innervated by the femoral nerve. So we have our rectus femoris right here, our vastus medialis right here, our vastus lateralis right here, and then vastus intermedius is going to be underneath this rectus femoris if we were to remove it. Alright? By the way, gracilis is not going to be innervated by the femoral nerve. It's going to be innervated by the obtural nerve, just because it's kind of in that group of the adductor muscles. But as you see, or as you're kind of getting the pattern, muscles, especially if they're super big, are going to have more than one action. Oh no, these are other muscles that we didn't really get to talk about, but your pectineus, your adductor longus, your adductor brevis, your abductor magnus, and TFL, the tensor fascia lata, are all going to also help with hip flexion. And those are going to be innervated by the obturator for the most part, with the exception of TFL being the superior gluteal nerve, which we were talking about earlier. All these adductors plus the pectineus and the gracilis are all within that adductor group. So I just have to remember anatomy. For hip extension, your gluteus maximus is also going to be at work because it is a hip extensor as well as a hip external rotator. We're going to also have the adductor magnus. So the adductor magnus, you might have saw that it's divided by upper and lower part. So the upper part is going to do flexion while the lower part is going to do extension. It's actually dual innervated by both the obturator nerve and the tibial nerve. Moving on, we have your bicep femoris. The long head, that's going to be innervated by the tibial nerve. Now we're getting to our hamstring muscles. We have pretty much 3 muscles in the back of our leg. So we have the bicep femoris. It has the word bi, and that meaning 2, which is why it's going to be divided into a long head and a short head. The semitendinosus is also a part of your hamstrings, and that's going to be innervated by the tibial nerve. And then we have the semimembranosus, which is also going to be innervated by the tibial nerve. So right now we're moving on, and we have hip abduction. So if you were to stand, I guess you could do it seated, but I think standing is much better. And you were to stand on one leg and you basically kick the other leg out to the side. That's going to be abduction. So gluteus medius is going to help. Gluteus minimus is going to help, and tensor fascia lata are also going to help. What else do they help with? Internal rotation. So bring your knee in, they can do that, and they can also pretty much help you get your leg away from the midline as they abduct or abduct away from the midline. We also have hip adduction, which is going to be your adductor muscle group. So again, your pectineus, adductor longus, adductor brevis, adductor magnus. And we also saw those for hip flexion. So pretty much just kind of correlating and knowing the difference and the similarities that these two, all these muscles have, and whether or not they have like 2 actions. Wow. Question 5. Actually, wait 1 moment. Let me sip some water really quick. Alright, for question 5, describe the difference between the measurement of lumbar flexion and thoracolumbar flexion. So pretty much breaking it down, they both have 2 different starting points. So lumbar is going to only refer to our lumbar region. We talked about the spine being divided into these different segments. We have our cervical spine, our thoracic spine, our lumbar spine. So for lumbar flexion, we're only focusing on the very bottom half right here. Thank you for that, Pat. Thank you. For this to measure, we're going to measure 15 centimeters above S2, and we're only measuring this. So once you're upright, we measure, and then when they flex down to go reach their toes or something like that, we pretty much do math. So from the 15 centimeter mark, how much did that expand? And pretty much you do the difference. For the thoracolumbar flexion, we're actually going to have 2 places to start. So we're going to have S2 still, which is going to be down here, relating to the sacrum or our second sacrum vertebra. And then up here at C7 to T1, C7 again, it's going to be that very prominent cervical vertebra. So if we were to touch like the back of our neck, and even if we flex it, we might feel a bump on the back of our neck, and that's going to be our bone sticky end. That's C7. We can pretty much palpate or feel and bring our finger just slightly down right underneath that, and we'll find T1 or the first thoracic vertebra. That's going to be, these 2 are going to be your starting point, C7 to T1, and then to S2 is going to be your second. Having the patient upright, you're going to have them bend again, flex. Can you reach to the can you reach for the floor with your fingertips and see how low they're able to flex? From there, you just gather that number. Oh, hold on. My cat's visiting. I'm so afraid because I'm like, oh, please do not press the power button. I love you though. Oh, remove was taken. Thank you so very much for the follow. Welcome to the Cup Club. Welcome. But yeah, so that's pretty straightforward. It's just knowing the difference, like, okay, is it thoracolumbar or is it lumbar? And if it's lumbar, of course, we're not going to be going up to C7 or T1 because we're only focusing on the lumbar region of our spine. Ta-da! Alright, so what's going to be the purpose for providing stabilization with lumbar range of motion measurements? So it's pretty much to avoid compensation. Anytime we stabilize, we're trying to avoid compensation in general, because sometimes maybe the patient will quote unquote cheat, and we'll talk about that a little bit later. But for like this example right here, when we're taking these measurements, which is technically range of motion. Hi, Peace. hold on. She's so cute. I love her. Sorry. She's just going to her little cat bed. I set up her cat bed right next to my computer desk, so she always passes by, and so I can pet her in arm's reach. to commemorate such a moment. Anyway, I'll put her a little bit smaller though, so she's not distracting. She's so cute. Yeah, so these two are considered range of motions right here. And normally what you would do is that you'll have a second person hold on to their hips. So you'll hold on, because how to explain it? Sometimes when people are reaching for the floor, maybe they'll like their heel will come off or something like that. When you're asking someone to stabilize, you're keeping them grounded while holding their hips. This is amazing. I'm glad. Anyway, what my professor said though was pelvic stabilization restricts pelvic tilt anteriorly or posteriorly, which that's something we're going to go super heavy into detail. This should be done in order to have a true measurement of the lumbar spine, preventing any compensations. So anterior and posterior pelvic tilt is in relation to where the ASIS is going, but I have some images, and that's something we could talk about together, because I need to also understand it a little bit more. Sorry, not to keep breaking, I apologize. My classmates are having a whole discussion right now. So, to fill you in really quick. So remember I was telling you about the study guide that I'm making, and then we had a study guide available by our professor who's like, hey, I'm not going to give you the answers. Okay, now I'm giving you the answers. Actually, well, I gave you only some of the answers. Now you just have to look in the book for the remainder. Tell them we said hi. They literally see my status as streaming. That's up to them if they click in. A lot of them are not like familiar with computer usage or Discord, so until one of them comes in, I'm just gonna play ignorant. But let's see. You know, did I ever tell you one of my classmates was like, oh, I saw you were playing Fortnite. I didn't click the stream or anything. It just said you were playing Fortnite in like the Discord title, and I'm like, oh, that's so funny. She's like, my boyfriend plays Fortnite. I'm like, oh wow, that's so funny. There's no way of hiding this. I'm gonna be with them for 4 years, so if they find out, cool, and if they don't, cool, it's whatever. One of my classmates, she's like, hey, do you like anime? Like, I give out that vibe. And what had happened was she wants to join for our anime nights. I'm like so nervous, but she's so cute because she's like, oh, my boyfriend got me into like Black Desert Online, and she's like, I really like the customizations and how do you call it, and the guild that I was a part of. Like, you have a guild too, right? And she's like referring to you guys, you know, the Cub Club, and I'm like, I have a guild. So maybe you'll get to see her for anime night, but I definitely was not gonna have her like watch Made in the Abyss. Like, oh yeah, you haven't watched the first season? Yeah, just jump in. What the heck? No, especially that would be such a bad impression. Cause she's like, oh, I watched like Samurai Champloo and all that. Is that how you say it? Like when I was younger? I'm like, oh yeah, I remember that. So she's like, I want to get into more anime, and I'm trying to watch it with my boyfriend, but he works at night, and I'm not on his same time, so we end up not watching a lot of shows together. And I'm like, aw, we can watch shows together, that's fine. So please expect her, but please also be nice to her. Oh my goodness. So how many questions remaining? Maybe 30? Maybe 30. Anyway, no, but I'm distracting myself because I opened up Discord really quick because I just saw like a bunch of like the little white tab right beside the Discord, and they're having a whole conversation because they're just like, if we hold on. Yeah, they have every right to complain. So pretty much what happens is that the professor's like, eventually you'll learn this. And it's like, wait, that was never presented in class at all throughout the semester we're in. Yeah, but you're still gonna be tested for it. I hate this man. I hate this man with a passion, but it's okay. I only have him for like one more class. Anyway, that's what they're talking about. Let's get back into it. So question 7. Describe the patient and therapist position for hip goni of internal and external rotation. Be specific and provide tips for the class for your classmates to know the difference between these two motions. Professor, yeah, big ham smash. Ah! He hit my elbow. Ah! Alright, it's okay. It's fine. That's my fault for not having my desk economically. No, just kidding. Anyway. So hip internal and external rotation is pretty much going to be very similar. What you're going to do is that you're going to have the patient seated. You're going to have them elevated off from the floor, so the table is going to be raised as so. You're going to place a towel underneath this and you're going to align as so. So what happens is that we're talking about the goni again. So our stationary arm is going to be perpendicular to the floor. Our axis is going to be the knee at the center of our anterior patella, which is just a fancy word for saying our kneecap. Excuse me. And our movement arm is going to be right here on the midline of the anterior surface of the tibia. This line should be pointing in between our ankles right here. If we're to draw like an imaginary dot, it should be between these two lines, or our two malleolus, or the two ankles that we have. What kind of stocks are you gonna recommend? You know, I never got into like the stock market, but I know Lamork was trying to get me into Dogecoin for crypto. I think I put like a penny in there. Anyway, so hip external rotation and internal rotation are the same. It's pretty much like, hey, where's your knee going? Because like we were mentioning earlier, we can do hip external rotation just in the seated position. So we have like our knee going out, which is going to be hip external rotation, and the knee going in, that's going to be internal rotation. But at this ankle, kind of follow the your ankles. If your ankles are going outward like this and your knee is going in, that's going to be hip internal rotation. Same adjustments, by the way. Hip external rotation, same guide marks right here, except we're going to move the ankle more inward so the knee can go out, and that's going to be external rotation. This table is basically saying how you should have them presented, how you should stabilize them, where's going to be your goni, and what are you going to do. So pretty much have the patient put their hands on the iliac crest, which is basically their hands on their hip, or cross their arms. You want to do this so they don't compensate, and use leg to support their distal leg to pretty much externally rotate or internally rotate. The end field is going to be firm with this, and the measurements, the normal range of motion for both internal and external rotation are going to be 45. Ta-da! So super easy. How are we going to differentiate between the erector spinae and the quadratus lumborum muscles, and how are we going to confirm that we're on each of these muscles? So both of these muscles, as fun as they are name-wise, they're pretty much located in our backs. So the erector spinae muscles are going to be our mnemonic "I love spaghetti," which is going to be, oh my goodness, potatoes high. Isn't this like super basic stuff? It is. But it's a cumulative exam, so it goes over some of the stuff we learned earlier in class to some of the newer stuff that we have right now. Why are we back here? Because these are the back muscles, potatoes. That's why we're back here. Just kidding. I understand what you're saying. It's just, I don't know, cumulative stuff. But anyway, so the erector spinae muscles are going to help erect your back muscles, or the spine, and they're going to be located right here, and there's a cool mnemonic called "I love spaghetti," which we have the iliocostalis, I love spaghetti, heck, mnemonic with flipped. Iliocostalis, I love longissimus, which is a long muscle, and spinalis, which is going to be closer to your spine. Then we have the quadratum lumborum right here, which is going to insert onto your iliac crest and onto the T12, or your 12th rib. So it's just asking, hey, what's the difference between the erector spinae and the quadratus lumborum? Well, other than their location, because these are two completely different things. But remember, the quadratus lumborum would technically be like right here, so I understand why it's asking for that differentiation. Yep, English. So how you're gonna do this is that you have to understand your basic anatomy. The erector spinae group is gonna be more medial, while the quadratus lumborum, as you see, is gonna be more lateral or outward. So from here, we can just ask the patient when they lay on their stomach, like, hey, can you extend your back? You place your two fingers right there and you feel for a contraction. If you feel for a contraction right here in the medial area right here, that's going to most likely be your erector spinae. To activate this muscle, the quadratus lumborum, you have to ask them to hip hike. Hip hiking is just it's like a weird, like, how do you explain it? Bring your hip to your ear, I think that's what they would cue, but that's such a weird way to say it, but that's how you're gonna activate this particular muscle. So yes. Did you say spaghetti? Yeah, I live off mnemonics when studying, so I love spaghetti. It was just one of those like mnemonics that they threw at me and I'm like, I'll take it. So yeah. Oh boy, so we're on question 9 right now, and this is going to be talking about anterior pelvic tilt and posterior pelvic tilt. And potatoes, if you are an expert on this, I would like appreciate you. Heart emoji button voice. if you can clarify some of this information, because my professor definitely just drew this into the study guide and he was like, yeah, you'll learn this eventually, and it's like, what? So the patient stands and walks with a lumbar spine in a more forward flexed position. So let's say they're kind of like hunched over pretty much. What structures on the posterior aspect, for example, maybe like the lumbar spine, pelvis, and hips, could be stretched? So maybe I should get paint out. So it's cropped a little weird. That's fine. So what happens is that in this scenario, right? Let's say you're in a slightly flexed position, right? What the heck is this question asking? Welcome! Welcome to my suffering! Listen, my professor is a beautiful person who writes these well-worded questions, but this is to my understanding, right? So let's say this is the person, right? And they're in a more forward flexed position. So this was kind of weird because my tutor said, hey, they might not even be talking about muscles, even though the muscles say that. It might be a ligament question. And I'm like, look, I'm just gonna go with whatever he had told me in class. I'm so sorry. So yeah, if they're in a forward flexed position, apparently they're in an anterior pelvic tilt, because we know we have our hip muscles which are right here. But anterior dies. Hold on, let me get a picture of anterior tilt. Anterior pelvic tilt. And then I'll explain what I think it could be. Shadow, hi, welcome. Hi, welcome to Studying 101. How's life? Let's go here. So an anterior pelvic tilt, again, we're going to reference the ASIS, which is around here, but in the front, and that's going to tilt forward. I feel so bad. Maybe my poor guy's not hunchback. But it's so fun to use this cup example. Look, listen. My cup right here is having anterior pelvic tilt. My cup right here is popping out the booty. Here's another picture, but with an actual person this time. Oh goodness. Oh goodness gracious. So this is an anterior pelvic tilt because well, where's a normal one? Alright. Oh no, you can't see it. Ah, heck. Sorry I keep getting the crunchiest photos known to mankind. This is how the professors must feel. Dump truck, basically. But it's the same dump trunk. They're just like pushing out what they got, whatever they got. All right, so let me grab the right size. So this is normal, right? Okay, yeah. So the pelvis is aligned. We had that one drawing that's like, yep, it looks like this. But if you were to have an anterior pelvic tilt, what happens is that your pelvis that was here, can we copy and paste this? Can we like this is now this to that. So what's gonna happen is that because it's anteriorly tilting, the pelvis is shifting this way as well, which is why his booty's popping a little bit. And that's going to be your anterior pelvic tilt. So from this to this. Yep, this is so good. Anyway, I'll go back to my cup drawing. I'm so sorry. These are just real life examples. It's alright. I'm seeing the bear and I'm now picturing an anatomically correct human body with a bear face. That's basically me though. Ah! Yow! Anyway. So yeah, the pelvis is going to tilt here, hence the anterior pelvic tilt. So what's going to happen from here is, hey, these muscles in the back are going to stretch or lengthen. No, my MS Paint days are over, cubs. I have not done this in a while. So these are gonna lengthen. Yeah, that's how you spell it, right? Lengthen. Somehow it's worse. And these are going to be tight. The muscles in the front are going to be tight. Potatoes, don't dot me. I'm learning. This is a study with me, not a let me teach you. This is not a teach me stream. This is a learn with me. So this is a posterior pelvic tilt. Yeah. So, from my understanding of the question, it's saying that, hey, they're walking more in a forward flex position, and so what muscles could be stretched? Well, what happens is that if they're walking more forward, that must mean their anterior side is more tight. So maybe like our hip flexors are tight, which we talked about, like the iliacus and all that. So hip flexors, maybe our I don't know if we want to get like knee extenders. Yeah? Yeah? Getting nervous here at the question. Yeah? Posture check. Okay. Thank you for the posture check. I actually have to take a baby break soon. I've been sitting for almost 2 hours and I didn't do a little break yet. Guys. I am also breathing. Thank you. What? Anyway. What is with this question? I'm just here learning. So, so lengthen, right? So our back muscles would lengthen, and what would lengthen? I will have to analyze really quickly. What is this question? What does it want? Who sent it? Listen. The patient stands and walks with the lumbar spine in a more forward flex position. What structures of the posterior aspect of the body could be stretched? So I guess my professor is assuming, hey, for them to have a slightly more forward flex position, it's to understand that they're going to be in an anterior pelvic tilt, which we talked about with that booty popping. So from there, we have to understand, why is this person in this forward flex position? Well, it must be because the muscles in the front are tightening up, where they're constantly under some kind of contraction. and is going to force that person or our cub in this beautiful image to stay in this position. And then their booty will be popping because the anterior pelvic tilt. So now we have to assess all the anterior muscles and be like, hey, what are tight? Or what is tight? And if those are tight, that means the muscles in the back must be stretching to compensate. So those are going to be lengthened and possibly even weak because they're not able to bring the what do you call it? They're not able to bring the back, you know? This seems neat, but I gotta go. But I also gotta know, what's the bad word? Oh, the bad word was heck. The biggest heck. But please have a good one. Thank you for stopping by, Shadow, okay? Thank you, 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 thank you. But forward flex position as you drew though? Yeah. This is what my imagination is seeing. Heck! Yes! So that. I have a good one though. Not the booty poppy, but the booty pops though still no matter what because of the toe, right? Let me pull out the really blurry example again. Oh wait, I found a better one. No, not transparent, not transparent. So, you see this is the good? Oh, let me bring the brush size bigger. Take care, I was gonna redeem hydrate, but I had to know what your definition of swear was. It's okay, I'll hydrate in your honor. I'll take a little baby break after this question. So this is good, right? Good? Oh my gosh. I can't get a happy medium with this. Bye! Bye 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 bye! So this is good! Right? Good! Go go! Huh? Matt? Matt, thank you so very much for the follow. Welcome to the Cub Club. Welcome, welcome, welcome! Please forgive me as I'm trying to figure out my life. So the answer would be booty muscles? Well, that's the thing. Breathing? I got you. Ah! Hello there. Hello. Welcome. So this is good. Like, this doesn't look that great, but let's just say this person is normal, right? And I didn't have, like, weird curvy lines. But the anterior, it's gonna look like this, you know? And the posterior, he's gonna be like, whoa. How do you draw a posterior pelvic toe? This guy is a moon. I don't know. I'm so sorry. I wish I understood this question, but it's fine. So, he's in an anterior pelvic tilt because he's in the slightly forward flex position. So the position won't be hunchback. No, I guess not. You wouldn't be hunchback. You're in a slightly forward flex position. I guess if we're considering here and here, this is technically slightly flexed and not like a hunchback position like I was thinking about earlier, so you have to forgive me. Pinati, hi, welcome, welcome. Oh no, not studying. I know, it's actually the worst right now. Imagine not knowing what you're studying. Couldn't be me. Imagine having a final in about 6 hours. Screams! Welcome, welcome, welcome. Alright, either way. It's fine, you're learning. I know, but this should been learnt. Is that a word? This should be solid information for the time of the final. I just wish I had more direction as a student. How's your exam last week? It was good. I got the A's and all that, so life's good. Anterior pelvic tilt, blah 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 blah. Anterior pelvic tilt is just a twerk. Okay, bun. Yeah, I have my test today, so I have to actually understand what I'm learning, which kind of sucks because I never understood it the whole semester, so I guess it's a little too late, huh? 6 hours? Yeah, my test is at 7 p.m. EST, so I have to understand this. I have to get through this document! Ah! And then I have work tomorrow. And I got really, what do you call it? I got really distracted yesterday. I didn't really want to study. I didn't really want to do anything because I'm just like, well, end of the semester, but I still have my 2 finals. And, excuse me, I was supposed to really study yesterday. Like Patho and AA. And I just didn't do it. I was working on the video, which, what do you call it? Big shout outs? Not really the big shout outs, but I'm like, hey Cubs, if you haven't seen the little music video I made, I would appreciate if you go watch it. I worked a day on it. I chose this instead of studying. So please validate my poor life choices. But yeah. That's why I'm trying to study all today, but it's just not going too well because I'm just like, man, this sucks. Thick pelvic? It is a very thick pelvis. I dropped out of college to stop studying. I don't blame you. Honestly, whatever you get to choose with your life, as long as you're happy and stable, that's all that matters. Welcome back, Lai. Hi. Hi Selic as well. Hi, welcome. Oh, not working? I am not working. So there was actually a really funny story with work, right? My work never puts out my schedule 2 weeks in advance. And apparently for next week's schedule, I'm off Monday and Tuesday, and I read it as this week's schedule, right? So my job texted me when I woke up. It's like, hey Tippa, where are you? And I'm like, well, you know, I've been working here for like 4 months and they never put the schedule 2 weeks in advance, so I thought when I was looking at the schedule it was for this week. So I really need to study though. Don't fire me. And my supervisor's super nice. She marked it as like an excused absence, and now here I am just on stream trying to realize what an anterior pelvic tilt is. Remember, C's get degrees? No, I can't do that here. If I get like more than 2 C's, I'm out of the program. So it has to be B's. B's get degrees. I mean, not what do you call it. I get out of the program. That was my previous program. This program I have to stay within a certain GPA, but I still shouldn't be getting C's. I have to stay over 3.0 GPA, ideally. B's get degrees. B's get degrees. Well, thank you, Salikama. I appreciate you. Thank you. Let's figure this out so I can take a baby break. Wow. Alright. If the person is in a slightly flexed position, because this is neutral, right? Well, look at this. We're going to draw a line on this guy, right? Yeah. Look at that. He's slightly forward. That must mean he's flexed. Alright, if he's flexed, what muscles can be whatever? Stretch. We could say hip flexors. So then, if these are stretched, the back must be weak. So we have weak or stretch. And those are going to be whatever muscles we look at. So I'm going to politely put this drawing off to the side and we'll read this together, okay? So if the patient's in a forward flexed position, it's going to be an anterior pelvic tilt. The muscles anteriorly are tight while the muscles posteriorly are stretched or weakened. The following muscles that are stretched or weakened, okay? So our back muscles, we have our gluteus maximus and our hamstrings, which can involve the semitendinosus, semimembranosus, and the bicep femoris. So here's going to be another, maybe I should put this away. Let me put this one away. So here's going to be like an actual drawing of the anterior tilt. So we said again, we have that forward motion that we saw in our previous drawing. Spine slightly flexed forward because we were doing a posture check. So that means that these are going to be small and tight, while these are going to be elongated, stretched, or weak. So da-da. Oh, hi Marshall, hi. I too draw back like the dude in the middle. Me too, on my weekends. No, I'm just kidding. I don't want to get into it. I do not think I can perform the actions of the people that they do on the weekend. I do not think I can throw it back. The only throwback I'll do is, hey, remember that one time? Anyway, B Daddy says, funny enough, I didn't do bad in college. I actually got on the dean's list, but I did not enjoy the 2 years I went, so I stopped going. Absolutely fair. I won't get in too much personal detail, but I hope everything is okay for you. And B, I hope it was just more of a oh, this isn't what I was passionate about, rather than the people there. She says, bees get the knees. Everyone else loses them. Get bats out. What? What does this mean? Anyway. What do I mean by anterior? Huh? Oh, I might mean like the anterior photo. I don't know how to spell anterior photo. So we have the erector spinae muscles, which is going to be, actually let's do this, posterior. Bring this back up, and we'll just do that. So posterior, we have the erector spinae muscles, the I love spaghetti muscles. But for the anterior, we're gonna have like, again, our hip flexors and all that. So like our iliopsoas. Sure. So put this here, put that there. And then this is the posterior. Okay. So the anterior photo again is gonna go over an what did we say? A posterior pelvic tilt. While the posterior photo, P-Daddy, thank you so very much for the follow. Welcome to the Cup Club. Welcome. Sorry, I'm like typing notes here as we go. Actually, it'd probably be better if we did this. Make a table. So we can have the information side by side. And the posterior photo is going to show an anterior pelvic tilt. From there, we can look at the posterior muscles again. The anterior muscles are still going to be this. So posterior pelvic tilt. These are all the things in our back, so I'm just gonna politely paste those in there. No one else answered anything else about this, so I'm kind of like, So what is our general consensus? If you have a posterior pelvic tilt, you're going to be in a slightly flexed position, which means anterior muscles are going to be tight. And why is this the case? Because the tight muscles in the front are pulling you into that flexed position, so that's why they're going to be tight. Oops. While the posterior muscles are going to be weakened or lengthened, and these can be like the erector spinae muscles, the I love spaghetti. And so we'll just type the opposite for the back, just to say that we brought into existence, and this is from my understanding. So the anterior pelvic tilt, that's going to be, you're going to be in a slightly extended position, which means that your posterior muscles are going to be tight. And this means, let me keep in the same format, tight. And so anterior muscles are going to be weakened. And that's going to be, in this case, let's put the rectus abdominis, because that's also going to be an anterior muscle, and that's also going to stretch. I also assume the iliacus and all that will also stretch with it, but we're not talking about that now. Anyway, we'll come back to this later, because I think there's like 2 or 3 more questions in the study guide. We're on page 33 out of like the 47. So we're almost there. Wait! No! Don't tell me! Am I understanding it wrong? Because this is like what I understand of it, but I wasn't not really taught of it. But I'm waiting. It's the opposite? Wait, why would it be the opposite though? Let me break it down again really quick. So the anterior, these are tight, and so this is gonna bring it down. The interior photo, the average TikToker pose. They have to get that checked. They have to get it checked. And for posterior, this is tight, right? So the gluteus maximus and the hamstrings and all that, and that's why he's gonna do a posterior tilt, which is going to tight. These muscles being tight is pulling into that action. And see, this is taut. So for the anterior, wouldn't the posterior be weak? Is it weak? I thought they would be tight. Not saying that they're strong tight, but I thought what would be weak are the flexors because, or the anterior muscles because they're not strong enough. They're weak / lengthened and they're not strong enough to pull it back from that extended pose. APT is when the butt sticks out. Tight backside, but weak front side or hip flexors. Oh, did I mix the words up? That's so funny of me. I wish I could read. Oh, look, it's so fixed. Yeah. I'm gonna end myself. Was that the issue? Is it because is it because I typoed it? Yes. That's basically how I have it, right? Yeah. I'm gonna free myself so I can go grab more water so I can hydrate and stretch because it's been 2 hours. And how many questions? So 9. 35. I have to get to question 35. I have to. And then we're gonna go over a Quizlet, and then if I have time I'll go over I better have time. I have to go over Pathophysiology because I work tomorrow. What class is this? It's like applied anatomy. So basically it's like, hey, you know anatomy? Now apply it to scenarios. And it's like, okay. But for now, I'm gonna be right back because I want a break. I want a polite break. Anyway, I'll be back, Cubs. I'll set the raffles. Make sure to also like stand up, stretch, and also get some water if you haven't. Okay? Good luck in your final later. Thank you, potatoes. I appreciate you. Thank you. I'll catch you, Cubs, in just a few minutes. Be right back. Ta-da. Mwah. I'm back. And I don't know why it's always rigged for my favorite. It's not like I always win, but I win a good chunk of the time. But I hope you got your stretches in, you stood up, you pet your cat. That's something I forgot to do. And drink lots of water. I am back and ready to eliminate the study guide in the next 2 hours. Help me. Niseki on? Heck. Hi, welcome. Thank you for the welcome back. I appreciate you. Welcome. Thank you. P Daddy says, I only did basic anatomy. I was in the nursing program. Honestly, the nursing program is so stressful. I know my community college had offered it, and it was a 2-year program as well, but it was so competitive, and there was like a really long wait list to get into. I do not oh my goodness, I do not envy nurses by any means whatsoever, and I know I have a few nurse friends as well, and I'm sure they could give you feedback if you ever need advice getting back in, if that's something you even want to go back into. But heck, so we are back, and we're gonna go back to question 10. So this one's asking the same question as the previous question, but let's read it again. So the patient stands and walks with lumbar spine in a more forward flexed position. What structure on the anterior aspect could be shortened? And so this one we're going to say again, it's going to be like the iliopsoas, the psoas major, iliacus, and the rectus fem. So here's going to be a some other fun guides to understand the pelvic tilting a little bit, and hopefully we can both get it. So let's see. Anterior pelvic tilt. So this is the front of the body. Oh, sorry, let me get a mouse. This is the front of the body. This is the back of the body. Anterior pelvic tilt and a lordotic back. Lordotic back means that's going to have this curvature right here. So this is going to have the pelvis tilt forward. Okay, we see the ASIS a little bit more forward than usual. The lumbar spine forced into hyperlordosis. So then the spine right here is also going to curve backwards, maybe because of some of the muscle attachments that we have back here. Posterior pelvic tilt with a flat back. So pelvic tilts backwards. So again, this is our front because we could see our patella right here, and the spine being more to the back. And so this is going to come backwards, and the lumbar spine is going to be pulled flat back. See, I feel this is weird. I mean, I obviously understand like the interaction that it has, the pelvis with the lumbar spine, but I don't think you're going to get like a flat back from it. I don't think it's going to dramatically change your curvature like that. Does it? Does it? Panic. So we have, and then this is nothing that we have to worry about, but some people can have a sway back posture, which means that their back pretty much like leans a little bit more back and their pelvis is more front, kind of like that moonwalking guy I was trying to show earlier. And neutral spelt different, so I don't even trust his resource anymore. And this is just a normal what your body should look like, basically. Here's more IRL examples. So these tilts, as dramatic as I draw them, they don't have to be that dramatic. So we have a posterior pelvic tilt, which means that the ASIS, which should be like here, more horizontally at like a 180 degree, it's going to be tilted slightly up. Hence posterior. While the anterior ASIS is going to be slightly down and pointed down, and that's going to be giving us that booty popping thing that we kept talking about. So let's move on to question 11. The patient complains of anterior hip pain. You notice limited hip extension when taking the Goni measurement. What muscles could be tight? What muscles could be tight that will give the measurements you found? So okay, so they have anterior hip pain. That means they have pain in the front of their hip, but they have limited hip extension. So we know that the ones that do hip extension are going to be our gluteus maximus and our hamstrings. So if we're not able to do that, this is kind of going into the concept of, that I personally am not a fan of, the antagonist and protagonist, antagonist? Do they say protagonist in anatomy? Wait one moment as I understand this again. I think it's agonist versus yeah, agonist and antagonist. My bad. I'm like, I don't think they say protagonist. So for it, antagonist is going to be the muscle that holds back, while the agonist is the muscle that allows the motion. So in this case, the agonist is going to be the hip extensors. Those are going to be limited by our antagonists, which are going to be the tightness that we feel in our front. So any of the anterior hip muscles. So yes, the villainous spine and the heroic spine. Honestly, anatomy's kind of wonky that way. but basically, because of this concept, the front muscles are limiting the back muscles because it's not letting it move because of how tight our front muscles are, such as our hip flexors, such as the iliopsoas or our rectus femoris, which is why we're going to have limited hip extension with our glute maximus and medius. So this is what a classmate wrote. Limited hip extension would mean tight anterior hip muscles, referred to a list in number 3 for possible contributors for hip flexion. Okay. Basically did that so you don't have to worry. Question 12. The patient complains of lateral hip pain. On standing, you note that the patient stands with the hip and more hip adduction. I almost choked. Hold on. Hi. What muscles could be weak that could be contributing to this position? Why? And then how would you find the strength? How would you strength test this muscle? So here's our patient. This patient is standing up. They have lateral hip pain, so they're having a hip pain on the sides of their hip. So, but you notice that their adductors must be a little tight because you notice that they're when they stand, they're more in hip adduction, which means that their hip might be a little bit more into midline. So what muscles are weak, why, and what are being a strength test? So let's find the weakness. So this is going to be a weird concept. So for this one, the adductors are going to be strong. The leg is, our body parts are always going to be pulled towards the stronger side, which makes the abductors weak. So would you make it almost like a similar word or simultaneously or synonym? Saying that strong would be tight in this case? Because tightness normally would pull a muscle like that. That's a ask a classmate question, I guess. I need my classmates to discover the study stream. No. But so the adductors are strong, but the abductors are weak. The abductors. Why are they weak? Because we can't really get out of this hip adduction. They should be at neutral, but they're not. So this also makes sense because, hey, remember, this patient is complaining of lateral hip pain. Our hip abductors are located more laterally or out to the side anyway. So the abductors being weak, it's going to be like our TFL, the tensor fascia lata, the gluteus medius, and minimus, with the most lateral being the tensor fascia lata. The lengthened muscles are weakened. So, can they go more into detail with that? So my classmate said weakness could be contributed to the lengthening of the TFL and glute med, which again, those are going to be muscles to help us abduct, but we're having some pain, so we might also have some weakness with that. These muscles are in the lateral aspect of the femur. This compensation could be due to an overactive or shortened adductors, which is why we're in that hip adduction. So we can do two things to muscle test these. So we can test for gluteus minimus, which we said again is that butt onion layer. We take out the gluteus maximus, we go into the gluteus minimus, and we're going to have the patient side lie. So they're going to lay on their favorite side. It looks like they're having bilateral hip pain, so we'll do one of each. The pelvis is going to be put into a neutral position, so no like leg forward or leg back for hip extension or flexion. And what we're going to have the patient do is we're going to have the patient hip abduct, but they need to be slightly extended to get rid of the glute maximus and do external rotation with the knee extended. So let's see if we can get a good picture of that, because holy heck. Glute sign MMT. Or at least a video. Let's see. Yeah, this is a good video. Good picture. So as you see, neutral position, slightly extended, slight external rotation, which I'm trying to like visualize the slightly external rotation, because this foot's kind of neutral. Whatever. As long as you're doing the big motion, the hip abduction should still be okay. And you're gonna resist near their ankle. Okay, so this image was wrong. No. Alright, I found a better one. Alright. Crop that. Crop this. Crop this. Crop that. So yeah, so that's going to be testing for the strength, because pretty much we're going to have them do this motion, which is going to be all the motions we know that the gluteus medius can do, and then from there we're going to push them, like, okay, don't let me break your form. You're doing this because your gluteus minimus is innervated. Alright, I'm going to try to push you into breaking the form. If you break the form, then I'll give you either a scale of like 3 to 4, and if you don't break it, then you get a 5 out of that MMT scale that we were talking about earlier. Let's see if I can get a good TFL image, and then we could talk about it. TFL MMT. So this one looks good. So for testing of the tensor fasciae lata, again, our most lateral muscle in our body, you're going to have the patient supine, which means laying on their back. Your stabilization is going to be at the contralateral iliac crest, and we're going to move the body or leg as so. We're going to move the hip into internal rotation. We're going to have them flex, and we're going to have them so slightly up, and we're going to have them what is AB? We're going to have them abduct their knee, and the knee is going to stay extended. So they're going to be in this position right here, and then the force is going to be down here, and we're going to try to break them from there. So TLDR, basically this really long question. Hey, patient complains of lateral hip pain. They're standing with more hip abduction. What's happening? Did I say abduction? Heck. Adduction. Heck. So remember, the adductors are going to be super strong, or they're going to be tight, and they're going to pull the patient in that direction, hence why they're presenting with hip adduction. The abductors must be weak, and that's why they also must be experiencing weakness or pain with that, and that's why we have to address their strength and then go from there using an MMT. Alright, so what are some possible compensations that would be observed during manual muscle testing with weak gluteus maximus? What is the psoas site, and how is this tested? So some compensations we could see with a weak gluteus maximus is that they may use their hamstrings to compensate as they extend their hip, because the hamstrings are also back there with the gluteus maximus, and it can also help with hip extension as well. Hamstrings will do hip extension and knee flexion. Also, when you're testing for MMT of the gluteus maximus, the back may arch and the hip may lift off, or it might even externally rotate. Any of those compensations you have to definitely be careful of, and that's why it's really important to stabilize when doing MMT. My professor in blue says it will result in a lurching gait, characterized by posterior leaning of the trunk at heel strike in order to help keep the... We didn't talk about the gait cycle. Why is he saying heel strike? Sorry. It will result in a lurching gait characterized by posterior leaning of the trunk at the heel strike in order to keep the hip extended during the stance phase. It's caused by weakness of the gluteus maximus. It's also called hip extensor's gait. So, weak gluteus maximus gait is a backwards lean of the trunk during the flat foot phase. Impairment means weakness of hip extensors, which is going to be our glute max. And the reason for deviation, leaning back during the stance phase shifts body's line of gravity posterior to hip, reducing the need for active hip extension torque. I'm going to kick my professor's booty. So yeah. I don't know why we're talking about the gait cycle when we're just talking about manual muscle testing. Screams. But yes, the weak gluteus maximus, you will see issues with extension, which is why I guess that would relate to the gait cycle, but we just haven't got there quite yet. Just be careful when you're doing MMT, because maybe they'll lift up or arch, or maybe they'll use another muscle to help compensate. For psoas though, on the other hand, psoas is really interesting. Let me see if I can also grab like a quick image of this. It all comes back to gait cycle. Full circle! Oh, this is why I didn't want to show psoas, because it's possible like I can get in trouble for showing a butt. Fine. I'm sorry, Cubs. So psoas is going to basically be if you have the patient lie on their left side while the right thigh is flexed backwards. So basically lie on your side, your knee is bent, and the right leg is going to go slightly back. The pain may indicate an inflamed appendix overlying the psoas major muscle. Heck. The weak gluteus maximus will... Oh, and that's what my classmate's saying. Heck. TLDR, psoas is really interesting because basically we have this really cute... It's not cute at all. We're still not sure why we have it, or why it hasn't been like phased out by natural selection yet. But you know how some people have to get their appendix removed and all that because it's inflamed? Well, one way to test it is to have the patient lay on their side with their right leg flexed and go backwards, and bam. If they have pain with that, that's going to probably be the pain that they're having because their appendix is inflamed, and that's when they have to go see their primary care physician. The answer that my classmates have put is that a weak glute max would compensate using muscles of the back, iliacus, and hamstrings. Trunk rotation can also be used. And they also just talk more about the psoas sign. Iliopsoas has a strong relation to its surrounding organs, kidneys, ureter, cecum, appendix, sigmoid colon, pancreas, lumbar lymph nodes, and nerves of the posterior abdominal wall. When one of these areas is diseased, the movement of the iliopsoas causes pain. To test, lie on the unaffected side. They should be laying on their left side though. Heck up. Anyway. Question 14. The patient has pain in their posterior buttocks. List the structures you would palpate in this region to see what can be contributing to that pain. So we talked about this earlier with our butt onion, and pretty much the posterior buttocks are going to be the gluteus maximus, the medius, and the minimus. So we see our max, our medius, and minimus right here. We can also feel for the piriformis, which is going to be right underneath the medius, or minimus right here, I apologize. And then we have our gemella sanguis, gemella superior and inferior. Paz, hi, welcome! I hope you don't mind. I was briefly hinting at you earlier about your current job without giving names or identities. But hi, Baz. Hi. Welcome. Your occupation was brought up. I'm like, yeah, I have a few friends there. Wow. And I'm not envious of your career path, but I'm happy and proud that you're there. But yeah. Oh yeah, I don't mind. Okay. Well, everyone. No. Nursing and like doing like therapy and all that, two different things. That's why I'm like, I'm not envious, but I know how competitive that field can be. I was telling them that in my community college that there's like it's 2 years to do your nursing program, but there's like a very long wait list to even get in there, so it can kind of be a pain in the butt. Which is why I'll have to palpate the gluteus maximus, medius, minimus, piriformis, obturator internus, gemella superior and inferior. I don't know why we're not able to palpate or why on this list I don't have obturator internus, but blah. Oh no, I do. I'm sorry. I cannot read. Reading is not my strong suit. Resuval and Marshall. Bass, please. Roselia, look, that was the butt muscle that felt tight yesterday. I'm sorry. You know what some people do? They get like a tennis ball and they'll like roll out certain body parts against the wall. So maybe you could do that with your butt. Get a little tennis ball and like, you know, move your body. Get that knot out. Oh yeah, I'm sorry. My classmates wrote, we learned to palpate the glute max, mid, piriformis, and the sacrotuberous ligaments. Other structures in that area? Okay, the gemelluses and the internal and external obturator. Alright, Describe the process and procedure for the Ober's test. Identify all the possible positive findings and what muscles are tight based off each possible positive finding. Oh, so many P's. So the Ober's test is really interesting because this is going to test again our most lateral muscle that we have, the tensor fascia lata. Do I have a picture here? Yeah. So So the Ober's test is basically you're going to be assessing the IT band and the TFL. The patient's going to lie on their side with their hip and knee at the lowermost extremity flexed at a 45-degree angle, and we're going to stabilize the pelvis right here. So I want to read it, but I also want to try to see if I can explain it and then be like, oh, was I right or wrong? So pretty much you're going to have the patient like this in the starting position, and you're going to have their leg bent down. You're going to slowly lower it, and if for whatever reason their leg can't go down, that means there's a tight tensor fascia lata or IT band, while if their leg does go down, it's going to be normal. That's the TLDR. Now let's just read it just because it's here. For the examiner, after instructing the patient in the movement, the therapist is going to place one hand on the ipsilateral pelvis, so the same side of the pelvis. So if I'm working on this side, I'm going to put my hand on this side to stabilize and maintain a neutral pelvic alignment to prevent, again, that anterior posterior pelvic tilting when doing this motion. Examiner uses the other hand to passively abduct, remember to bring away from the midline, abduction, the hip, and extend the hip up on the upper side in line with the trunk. The TFL is then over the greater trochanter, so bring it up because our greater trochanter is going to be here. Slightly elevate, raise right there, should be good. The examiner is going to ask patient to relax muscles of the lower extremity while allowing the uppermost limb to drop into adduction towards the table due to their available range of motion. As the limb drops towards the table, the examiner prevents flexion and internal rotation of the hip, again with the stabilization hand right here. If we had to do it modified, instead of the leg bent like this that we see in the second image, we would have the leg straight out like this. The reason why is that because sometimes they might be uncomfortable with their leg flexed or their leg flexed for so long. So basically we'll give a break to the rectus femoris, which is going to be that hamstring muscle that's going to attach where all the other hamstrings attach on the tibial tuberosity, and then oh my goodness, I hope rectum is AIIS? The anterior inferior iliac spine, or does it originate from the ASIS? I'm so sorry, hold on, cubs. Rectus femoris origin. Let's go! It's the AIIS, the anterior inferior iliac spine, which is gonna be, let's see if I can pull up a picture. I don't think this is a good picture. Okay, this one's a little bit better. One moment. Here's our rectum. This is going to be one of the muscles again of our quads. If I said hamstrings earlier, I'm so sorry. Quads. Tibial tuberosity down here because that's where it's going to insert. And then it's going to be right here because this is going to be our anterior inferior iliac spine. This looks like salmon, just a little bit. I actually kind of want sushi. Is that bad? I'm hungry, but I have some leftovers that I can heat up and yada 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 yada. But yeah, but muscles normally don't look like that, or maybe they do. I only get to see dried up muscles. Anyway, so let's see. So yeah, the modified instead of the bent is going to be straight to give a break to that muscle we just showed, the salmon looking one, and any other discomforts that they might have with knee flexion. And again, if the knee does not adduct past the horizontal, then the TFL and the IT band are considered short and considered a positive Ober's test. Wow, so many words. Describe the process and procedure assessing hamstring muscle length. What is the reference to determine if the hamstrings are tight? So let's follow what my classmates said because your girl did not write that correctly. I wrote something, but I don't know what I wrote. So how can we assess hamstrings? So we know our hamstrings again are going to do what? They're going to help flex our knee and extend our hip. So we can actually test this with a straight leg raise. The patient is going to be laying on their back or supine with hip and knee extended for both legs. The examiner is going to instruct the motion and flex the patient's hip through the full available range of motion while maintaining the knee in full extension. Did I confuse the actions? No! Hamstrings... No, wait. Hold on. Again, this is a study with me stream. One moment. Okay, they flex the knee and extend the hip, yeah. Okay. Let me also grab a picture to show you cubs as well. Straight leg raise, test. Salmon muscles? They are though. It's very rare to get like a little cartoon, but we can get this one. Yeah, I think this is actually okay here too. So instruct the motion, flex the patient's hip, so bringing the leg up is going to flex it to the full available range of motion while maintaining knee in full extension. One hand is placed on the thigh to ensure that the knee is extended, to making sure it's kept up. And when the resistance is felt, the test is complete. So let's see what they're saying. In what reference to determine if the hamstrings are tight? This doesn't seem right. I'm pretty sure like if they're not able to get to 90, they have tight hamstrings. So they have to get all the way up here for it to be tight. But they're saying 80 degrees with a straight leg raise is distal hamstring, which doesn't really say too much. It's just saying this is where it is. I'm like, oh, what? If we have to modify it though, we would actually bend the knee slightly and then raise it up. We wouldn't do a straight leg raise like this. The knee would be maybe about right here, bent, and then we push up from here. This, I have no idea. I'm just gonna I'm so sorry. This is a ask my classmate questions. Let me see. Oh no, my classmates are gonna riot. Anyway, so question 17. The patient stands and walks with the lumbar spine in a more extended position and an anterior pelvic tilt. This one's specifying and a pelvic tilt. Holy heck. What would happen to the hip flexors and back extenders? What would be short, what would be tight, or what would be lengthened, and why? So, what did we say? More extended and extended back. So let's see. Excuse me. So let's see what my classmates wrote, because then we can look at the image, because I remember in class they were mentioning lower cross syndrome, which is a very interesting thing of like, hey, if this is tight, if these are tight, these are weak, and then vice versa. These are tight, then these are weak. So this person is presenting with a slightly extended back, and so they have increased lordosis, hence that curvature in your back. And they have anterior pelvic tilt, which should mean that their anterior muscles are tight. So yeah, tight hip flexors, iliopsoas, pulls pelvis anteriorly, and tight paraspinal weaken. I guess. Are weakened. Stretch rectus abdominis and hamstrings. This is I will ask a classmate, but I think I have a very vague idea. Arnimo, hi, welcome. You come here with the cursed head pats. Let me see what I have in my goodie bags. There it is! But I can't grab it? What? I can't grab my hand? Oh, I grabbed it. Alright, on the count of 3, this one goes up for you for cursed head pats, okay? On a 1, and a 2, and a skibbity-dibbity-doo. Thank you for the Chris head pats. I appreciate you. Welcome, welcome, welcome. I'm sorry. I'm struggling with studying right now, so you have to forgive me. I mean, you don't have to forgive me. I should know this. I have a final. But I think this is just basically going over the concepts that we went over earlier. If you have an anterior pelvic tilt, that means your ASIS is moving more forward. And from that means that your anterior muscles have to be tight. Artie with the Artie email. Let's go. Thank you. No problem. You're welcome. Thanks for redeeming it. Those are some good headpats. I have to. I gotta get out of my system. Anyway, so what is the effect on the hamstrings if the patient has excessive anterior pelvic tilt, and what is the effect on the hamstrings if the patient has excessive posterior tilt? So, before I read this, let's see if we're gaining the knowledge correctly. So, if someone has an excessive anterior pelvic tilt, this is going to mean that their front muscles are tight, and we know the hamstring muscles are going to be on our posterior thigh or the back of our leg. So if the front is tight, the back must be weak or lengthened or loosened. No, I think we're sticking with weak or lengthened. So if the hamstrings though in the posterior pelvic tilt, we know those are going to be tight because the hamstrings are going to be bringing the hips back into that position. So hamstrings will be lengthened if anterior pelvic tilt. Hamstrings will be short or tight if there's a posterior pelvic tilt. Big thumbs up. we're learning. So my classmate wrote, anterior pelvic tilt lengthens the hamstrings. Posterior pelvic tilt will shorten them. This happens based upon the rotation of the ischial tuberosities that serve as the proximal attachment to the hamstrings. Yay. Sorry, I'm getting so sleepy. No, I can't be tired. I have to examine. It's almost 2. I have it like in 5 hours. I have to do my best. Let's see. Let's see. So 19. How does the ACL, which is going to be our anterior cruciate ligament, restrict motion in the knee? So your knee is kind of funky because you have lots of ligaments here to connect your femur with your tibia and your fibula. So we're talking about ACL in particular. Your ACL is going to be this tiny little ligament right here. This gets very injured often, as you see, because it's so tiny. But it's going to be crossing here, and back there is going to be our posterior cruciate ligament. So how is this tiny baby muscle ligament going to restrict motion in the knee? So what's going to happen is that the ACL is going to prevent displacement of the Alright, let me simplify it. ACL is going to restrict the anterior translation of the tibia. So the tibia, which is our bottom right here, it's going to prevent it from going forward. While the oh no, Preston, thank you so very much for the follow. Welcome to the Cup Club. Welcome. While the ACL is going to restrict the posterior translation of the femur. So let me this image was not placed well. So it's kind of weird to do it, but basically how I like to imagine it is I put like my 2 fists together, and the top one's going to be the femur and the bottom one's going to be the tibia. So with the femur, again, the ACL is going to restrict posterior translation, which means that grinding or pulling back of the the femur onto the tibia, while the tibia, which is going to be your bottom fist that's stacked, is going to restrict anterior translation or prevent it from going forward. I'm going to give everyone a big hug. Okay, but it has to be a big quality hug. It has to be like a bearcat hug, not a bear hug. Bearcat. Either way, welcome. Thank you for the hugs. I appreciate it. Welcome. But yeah, So overall, the ACL is going to prevent displacement of the femur and the tibia. It's going to prevent the tibia from going forward in front of the femur. So that's going to be its main thing of preventing anterior translation. Normally this ligament gets injured by a planted foot and twist, which is pretty common. So pretty much if your foot and you twist in, it will it will most likely get injured, or a lateral blow. So that means basically like, hey, maybe you're playing football, or maybe someone like takes a bat like a bat to your knee and they hit like the side of your leg. That's how you're going to pretty much injure this ACL. So what about our PCL? So this is going to be our opposite, okay? So this is going to restrict posterior translation of the tibia on the femur. So if we put our two fists together again, the top and the bottom, the top one being the femur and the bottom one being the tibia, restricting posterior translation of the tibia onto the femur means that that bottom one, the tibia, can't really go or slide as much back as you want it to, while the PCL again is also going to restrict the anterior translation of the femur on the tibia. So the top fist going forward, it's going to restrict. I wish there was like a really cool way to memorize this. This may just have to be pure memorization, unfortunately, but I'm just gonna bold this. I'm just gonna bold this because for whatever reason the names give it away and what it does, right? Oh heck, that's not the one I wanted. It gives it away and tells you what it does, so it shouldn't be too bad, but my brain's kind of like, okay, but what on the tibia, what on the fibula? One fibula doesn't do anything. My bad. But yeah, so ACL restrict the anterior translation on the tibia because we always want to focus on our bottom first, and then they'll kind of go hand in hand, very straightforward. A for A for A, P for P for posterior, and we should be good. We'll kind of review this back again just to make sure that I'm like, wait, which one again? Yeah. So this is our patella, right? This is our kneecap that we say very informally. So the next question is, how does the patella contribute to proper motion of the knee? So the patella develops after 2 years of age, and pretty much it serves as a biomechanical movement arm. It's going to help to improve the effective extension capacity of the quadricep muscles by increasing the movement arm of the, movement. I'm going to just fix that for my sanity. By increasing the movement arm of the patellar ligament. I think they referred to this as like the, oh my gosh, what did they call it? Screw hole mechanism, but we haven't gotten into that detail quite yet, so please forgive me. My classmate said it's going to serve as a mechanical pulley for the quadriceps as the patella changes the direction of the extension force through the knee range of motion. Patella moves proximally with the knee extension and distally with knee flexion. So pretty much your patella, it's almost like a free floating bone right here that's going to be attached by ligaments, but it is going to move depending on what you do. So when it says proximally, it's going to move up with knee extension, and if you that's so weird. If you want, I guess if you're also sitting, you can extend your leg and feel your patella go slightly up. And then with knee flexion, it's going to move back down. So come up, come down, come up, come down with flexion and extension. It's also going to prevent excessive friction between the quadricep tendon and the femoral condyles, because the quadricep tendons are going to be like right about here, because all of them again are going to insert into that tibial tuberosity. What are the ligaments of the lateral aspect of the foot? So there's going to be three main ones that we like to associate with time. Do I have a clock? Do I have an image right here? It's like 3, 6, oh, my cursor. 3, 6, and 9, right? So at our 3 o'clock, we're going to have our anterior talofibular ligament. Talo because this is the talus, which is going to be right below our ankle, and the fibula because it's going to attach to our fibula bone. Anterior talofibular ligament. At our 6 o'clock, we're going to have the calcaneofibular ligament. This is going to attach to the calcaneus, that's going to be our heel bone right there, and it's going to insert onto the fibula. And as we have an anterior, we must have a posterior. So the posterior talofibular ligament right here. These are going to be our 3 ligaments of the lateral aspect of the lateral ankle. Yeah? So now we have to know about the medial ankle. The medial ankle, they don't really want us to know ligament names for that for whatever reason. Maybe it's still too early, but it can be grouped up into the deltoid ligaments, which I don't know if we have a picture of. Nope. That's okay. Really, we're mostly focused on the lateral side. I've seen a few questions pop up in previous exams about this, so I'm more focused on this anyway. But with that, with all these ligaments, minus the medial one, I'm so sorry, deltoid ligament, you're gonna have different grades of sprains, okay? So, and what ligaments are going to be torn with each grade. So right now we see this beautiful picture. It's not that beautiful, but hopefully you're never in this situation, or if you have, just never again. We're going to have a grade 1 sprain. So this is going to be stretching that are going to include the ATFL, which is going to be right here. Again, this is the image of this right here. So this is the ATFL, or the anterior talofibular ligament right here that's being stretched, as well as the calcaneofibular ligament. For grade 2, they're going to be large but incomplete tears, so we see the severity right here. They're not quite all the way through. As you see, like, it's just starting, but there's still this tip that's still attached, and this one is teared as well, but doesn't go through the whole entire ligament. This is still only going to involve our 3 o'clock and our 6 o'clock ligament, our ATFL, and our calcaneofibular ligament. From there, we have grade 3, which is going to be complete tears that are going to include all the lateral ligaments that we have at our lateral ankle, which again is going to be the ATFL, our calcaneofibular ligament, and our posterior talofibular ligament right here. So as you can tell from these, tears alone, what is the most often injured ligament in the lateral ankle? And that's going to be our anterior talofibular ligament, or our ATFL. Here are the names of the deltoid ligament, but we don't have pictures for them, so I'm so sorry. But as you see with the naming pattern, it's going to be named to what it's attached to. So, excuse me, I'm so busy digesting my Cheerios. Alright, for deltoid, it's going to be your talonavicular. So this is going to attach to the tip. No, we're getting pictures. Heck this! Heck this! One moment. Deltoid ligaments. Let's see. This one's kind of it's a little green. Let's see. Got this, get that. Alright, so the deltoid ligament, you're going to have your tibionavicular, which is going to be attaching to the tibia, as well as the navicular bone right over here. And we're going to have your tibiocalcaneal, which is going to be onto your tibia and onto the calcaneus that we saw, our heel bone. We're going to have the posterior tibiotalar ligament, so again, tibia and then the talar. And then we're going to have the anterior tibiotalar, which is going to be right over here onto the tibial and the talar, meaning the talus of our foot bone. Yeah. Question 25! How do you find the pes ansorinus area and the 3 muscles that make this area? So understand the pes ansorinus is just like a location onto our body. This is going to refer to the anteromedial aspect of our knee, and it's about 1 to 2 centimeters from the tibial tuberosity, which is something we're talking about again with the insertion of the quadriceps. So it's going to be the insertion site of 3 muscles. SGT, it's like the abbreviation of sergeant, and we like to use the mnemonic sergeant goosefoot because it's supposed to look like a goose, but this is probably not the best image to represent that, unfortunately. So we have your sergeant, your S for sartorius, your G for gracilis, and your T for semitendinosus. And here, this area is going to be the pes ansorinus, again, the medial anterior aspect of the knee. What is the importance of the Gerdy's tubercle and what can cause pain to this area? So the Gerdy's tubercle is a lateral bump on your tibia called the Gerdy's tubercle, and that's going to be the insertion of the IT band. And when the IT band is tight, you can pretty much feel pain in this location. So how do the hamstrings restrict tibia motion? So Oh, these are the new questions you started answering. So I'm like, why don't I have my thing here? Heck. So my classmates say the hamstrings are going to restrict anterior translation. If the ACL, which we were just talking about, the anterior collateral ligament is damaged, the hamstrings can compensate for that. So pretty much remember that anterior translation is just that sliding forward motion. The bicep femoris is going to do external rotation. The semimembranosus and tendinosus is internal rotation. The opposite muscle will restrict the motion. Huh? I was like, why did you bring up these muscles? I'm so dummy. These are muscles of the hamstring. Remember, we have those three: the bicep femoris, the semimembranosus, and semitendinosus. So overall, as a big group, hamstrings are going to restrict anterior translation, but bicep femoris is going to restrict external rotation, while the semimembranosus and tendinosus will, limit internal rotation, which makes sense because of where it's located on the body. The semimembranosus and tendinosus are going to be more medial of your hamstrings on the posterior thigh, and your bicep femoris is going to be more lateral, hence it limiting or restricting external rotation. No! The opposite muscle will restrict the motion. I'm so sorry. Okay. It's still the same idea of where it's placed. That's how you're going to test them. But for restriction, it's going to be the opposite. So even though I said yes, the semimembranosus and tendinosus do internal rotation, apparently they're going to restrict external rotation. Same with bicep femoris. It does external rotation, and that's how you're going to test it when you're doing maybe like a hamstrings MMT or manual muscle testing, but it's going to do the opposite. So, bleh. How do you perform MMT of the sartorius and tensor fascia lata, and what is the main purpose of performing an Ober's test? So the sartorius, again, is that really long seatbelt muscle that we didn't really talk too much today about, so I apologize. But we're going to find out how to test that muscle, as well as the tensor fascia lata, which we talked about earlier when assessing the difference between that and the glute medius. So for sartorius, we're pretty much going to put the person into a hacky sack motion. So you know when you play hacky sack, you kind of like kick your leg up and the knee is kind of bent outward. We're going to do the same thing. So the hip is going to be externally rotated. We're going to flex it, and it's going to abduct the knee into internal rotation. And it might be easier to get a picture. Sartorius MMT. Let me grab one. This one's good. Let me post it in here. So again, the sartorius is your hacky sack muscle. So we're going to flex the hip, externally rotate it, so this is slightly tilted that way. Bend the knee, and then you're basically going to push the opposite direction to assess the strength. Like, hey, hold that form, don't let me break you, okay? TFL we talked about earlier. Again, that's going to be the most lateral muscle. You're going to test both of these supine, so the patient's going to be laying on their back. You're going to stabilize at the contralateral iliac crest, so you're just going to place your hand across. Let's grab another image really quick. That's not it. One moment. I'm looking for them doing it supine. No one's doing it supine. No. Alright, I might just have to give you a vague idea. I'm like, okay, just ignore his stabilization hand though. So TFL, we're pretty much going to move the hip into internal rotation, flex, and abduct, and the knee's going to stay extended. And we're just going to push and be like, hey, hold that form, don't let me break yet. His hand should be on the other side though. It's okay. There's an attempt. Cute! All this time? No, I'm just kidding. I'm just kidding. Thank you so very much for the follow. Welcome to the Cup Club. Welcome, 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 welcome. I'm sorry, this is your like second impression of me. Struggling. But yeah, I'm studying, but I'm almost done. I'm almost done. Don't let me break you totally doesn't sound intimidating. We have to like be super careful with our words, and that's what we had all agreed with. We're all like, don't let me break you, don't let me break your form. Actually, don't let me break your form was voted to be the most appropriate to say. Don't let me break you is pretty intimidating. But at least I have like a vague idea of what you're talking about and not be like anything else. Why was I following? You're fine. Twitch and what do you call it? Twitch and Twitch. Wait, huh? I'm so tired. I'm so sorry. Twitter and Twitch are two separate things, so do not worry about it. You're a-okay. Do not worry. Hello, welcome officially to the Cup Club chat. I'm so sorry. I've been studying for like almost 3 hours, so my energy is like z. But yeah, welcome. But yeah. So for question 29, how are you going to perform the hamstring single leg raise and the quadriceps Eli's test? So we talked about the straight leg raise before. I don't know why there's a repetition on that. Really, again, either you have to, for the single leg raise, you either have the leg straight the whole time, or if they need it modified, you would bend it first and then raise it. But let's talk about the Eli's test. This is going to be new. This is something I think deserves a picture as well. So let me grab that. This cartoon explains it so perfectly. So this one is interesting because this is going to be a test that you test with the patient in prone, which means that they're going to lay on their belly. And what's going to happen is that you're going to be testing for the rectus femoris, which is that muscle we were talking about earlier, the salmon muscle. And pretty much whatever leg you're not testing, you're going to have it straight forward, outstretched, and the other one that you are testing is going to be flex. The stretch that you're going to do should end with a firm end field. So remember we're talking about like question 1 about assessing end fields, if it's firm, soft, or hard. And basically, if you feel the end field is soft when you do bend the leg back like this, like bringing the heel to the butt, and you're just like, it's a little soft, then you have a positive Eli's test, and you can't test from there to see if you have a tight rectus femoris. So you have to do a Thomas test, which is a completely different test that I have. I will not worry about because it's not on the test. It's a little bit difficult to explain because you're testing like 5 different muscles, and it's just But basically, you get to assess what muscles in your hips are tight. That's basically the summary of the Thomas test. For the negative Eli's test, so again, we have it prone, the hip does not raise from the table, and they can basically freely flex or touch the heels towards their buttocks. And there's a firm end field, bam, negative Eli's test, bam, 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 bam. Hi Glenn, hi, welcome. Hello Tip and gang, hello, welcome. So, how are we going to perform MMT and MLT of gastrocnemius and soleus muscles? So these seem like really intimidating muscles. These are going to be the muscles on our calves. So let me grab a picture. This one's cute. It's so big though. So our gastrocnemius and soleus muscles, these can also be grouped together to be called the triceps surae muscles. Our gastrocnemius is going to be our most superficial muscle, the one that you're going to touch if you pat like your back of your calf. You know, behind your leg, below the knee. Yeah. And your soleus is going to be a little more deeper than that. So we're gonna see how to perform an MMT, or a manual muscle test. For both of these, actually, I forgot. For the MMT, what you're gonna end up doing is that you're gonna have them go on their tippy toes. So pretty much you're gonna have them standing. The patient's gonna be facing the bed and using their fingertips on the bed to support them. They shouldn't be using it to, push off. And pretty much you're gonna go on your tippy toes once. We're gonna see, okay, that's how they go on their tippy toes. Okay, cool. So we're assessing the quality, and then from there we're gonna test only one side at a time. So we're going to have the patient lift the side that's not being tested, and they go on their tippy toes multiple times. If they're able to do 1 rep, that means that they're able to go against gravity. So it's going to be a 3 out of 5. To score 4 or 5, let me see. I think it ranges. If they score a 4, I think it's 10. I think it's 2 to 10. And if they score, no wait. I have to go double check the chart, because I think over a 5 is over 24. If you could do this tippy toe business for at least 24 times, you're good. Anything under a 4, but I think it's 1 through 9. 1 through 9 is a 3. Yeah, 10 through 24 is a 4, and then 25 or higher is a 5. Ta-da! To test soleus though, you're gonna do the same thing, but you're gonna actually have the knee bent. When you have the knee bent, you're gonna get gastrocnemius out of the way, because you see how this is attaching above the knee? Well, the soleus has nothing to do with the knee. So once you do bend the knee, you get this out of the equation, and we're only focusing on this. I'm not sure if you cups have ever stretched on like an incline board, or on an incline in general, and you know how they're like, you feel like good stretch on the back of your legs, you're like, oh, that feels so nice, and it's like, okay, now bend your knees, and you feel like a totally different stretch. That's because when you bend your knees, you're eliminating gastroc, and you're only focusing on the soleus, which is that deeper muscle right here. So when you're doing a not weight bearing, basically you do the same thing, but you basically have them sidelined. So oh, don't let me move you. It's also another formal way of saying the MMT stuff. You'll be heading out? Oh no, no worries. I know it's been long, so easy. I hope you have a good rest of your day. Thank you for stopping by. Oh, have a good day and good night. Oh yeah, isn't it actually late for you? So please have a good night, by the way. Thank you for stopping by. I hope to catch you later, okay? Bye. I'm sure you'll do great. I'm hoping. I just have this exam and tomorrow, and I'm free as a bird. I'm so excited, but I don't know. Sorry, I'm stretching. I just can't wait. I want to be free for 2 weeks and just stream. I want to catch up on games. I want to finish Persona. I want to finish so I can start Yakuza and then finish Nier. Huh? I think I prefer Don't Let Me Move You. Yeah, sounds like there's a chance of bones being snapped. I don't know, some people are so aggressive. They're like, oh yeah, this person broke under like 75% of my voice. I'm like, why did you put that much? Gastroc sounding like an NPC from Dark Souls or Elden Ring? Let's go! I don't know why they had abbreviated it like this. Yeah, they just wrote Gastroc. Oh, whatever. So for MLT, what you have to understand is that it's muscle length testing, and to stretch a muscle, we have to put it in its opposite action. So what's going to happen is that let's see. You're going to place the position supine with the sock off and the ankle off the table. You're going to extend the knee because the gastroc is going to be a knee flexor, and then you're going to dorsiflex the ankle because it is a plantar flexor. So knee flexor, the knee's bent, but really this person's laying on the back, so extend the knee out. They should have a straight leg. And what you're going to do with the ankle is that you're going to dorsiflex it, which means to bring the toes towards you instead of away from you, because what happens is that the gastrocnemius is a knee flexor and a plantar flexor. So let's do the opposite actions. Excuse me. I think these are my hiccups. I think I'm like burping and hiccuping at the same time throughout this whole stream. I'm so sorry. But you see how it's like once and done? Hate it here. Anyway, so you're going to stabilize at the anterior tip fib, which is just above on the anterior side, because you never want to be holding on the muscle. Remember, gastroc is going to be posterior or on the back of the leg, while this is saying to stabilize at the front. We're going to cup the calcaneus, which is going to be our heel bone, and use a form to apply pressure when to dorsiflexion, so making sure that your force is perpendicular. And so since this is a 2-joint muscle, you probably won't see a lot of dorsiflexion, and about 10 degrees is normal. And then basically you ask your patient, hey, do you feel a stretch? And they should, because you're applying a force in the opposite direction, which is going to be stretching the muscle, because again, gastroc is a plantar flexor and a knee flexor. For soleus, you're going to do the same thing, but you're actually going to ask them to put a towel under the knee to get it at a slight knee flexion, about 20 to 30 degrees, and you basically just do the same thing. You should see full range of dorsiflexion because it's a one joint muscle. There should not be that many, I guess what you would say, like roadblocks, you know, for the motion. 31, because we only have 35, so let's go. All right, so question 31. What are the muscles that are going to perform dorsiflexion and plantar flexion? So dorsiflexion is going to be the muscles that, again, are going to be toes up to, like, I don't know, you're sitting, so bring your toes up. That's dorsiflexion. All right, now lift your leg. Now point your toes down. That's plantar flexion. Dorsiflexion, plantar flexion. Dorsiflexion, bringing it dorsally. Plantar flexion, planting your toes to the ground. Yay! So yeah, for dorsiflexion, you're gonna have the tibialis anterior, extensor hallucis longus, and extensor digitorum longus. So there's a mnemonic, so please forgive me. It's called Tom, Dick, and Harry, which are their tendons are gonna run in that order through the by the medial malleolus. All those three muscles are going to do dorsiflexion, so bringing the foot up. But you have so many muscles that are gonna help you or assist with plantar flexion. So we have the plantaris. That's gonna help plantar flex. We have the gastrocnemius, the soleus, the flexor hallucis longus, flexor digitorum longus, tibialis posterior, and the peroneus longus and brevis. All those are gonna help with plantar flexion. So when in doubt, plantar flexion it out. So how are we gonna measure range of motion for inversion and eversion? I don't feel like explaining. No, I'm just kidding. So I don't think you would do it seated. I don't think you would be doing it seated. I need a refund on whoever answered this. One moment. Now I have to explain it because now I think it's incorrect. Wham wham. Oh well. Let's see. Let's find this out. Why is it hard to find feet pics? Like seriously, I'm finding like the subtalar one, which is not the one I want to show you guys. I didn't test it in supine. I mean, I didn't get tested at this at all, but now I'm just like, I got tested in supine. Mad. I'm actually not mad. It does not matter. So I guess we'll just go and take this image really quick, okay? One moment. So inversion and eversion's a little funky. So this person is measuring for range of motion of eversion. So the sole of your foot or the bottom of your foot is going out to your side. That's eversion, while inversion is going to be the foot going in. So the sole of the foot or the bottom of the foot tilting more in. So I'll take this out. So for inversion, normal is going to be 35 degrees. They said it's seated. I'm pretty sure you can also do supine. And for eversion, you don't really have that much eversion. So whatever the lady was doing, that was eversion. You're going to have a normal of like 15 degrees. So, oh, here's another picture right here. So eversion, 15. Inversion, bringing the foot more in the midline, it's going to be, what was it? 35. 35. 15, 35, 15, 35, 15. For a total of 50. You have to put in the other 50 to give it your 100%. Yay. I told my classmate this and he just looked at me and I said, you know what, I'm never coming up with dumb things again. But yeah. That's gonna help me remember which one's which, because again, it's much harder to get your foot into eversion, TBH, without compensating or be like, oh look, I can do it. It's like, maybe you're not doing it correctly then. So what are the muscles that are going to perform each action? And what is the deltoid ligament? Oh, I hate it here. Alright, back from studying for a bit, let's go! I still haven't taken a break. I need a formal break. The next break when I'm done here, which is very soon, I think I'm just gonna go heat up some chicken. I have some leftovers from yesterday. I'm gonna eat that and then get back into it, and then we'll do the Quizlet, and then life will be good. Hopefully. How's it going? It's going well. I'm still on the same guide, but I'm almost done. So I hope your studying's been super productive as well, and that you're doing your absolute best and trying to make it during these like last few, days, or maybe for you weeks of school. Heat up some chicken and play Fortnite? Oh my god, I would love to play Fortnite. I want to play Fortnite. I played it earlier, and I played it with Rip and it was fun. We'll Rip play Fortnite. Well, she's busy. It's okay. I'll wait to play Fortnite. SG was really excited about it, and I play Fortnite with SG a lot, so maybe we can play it together. I'm staring at Fortnite. I'm like, I want to play Fortnite. Anyway, sorry. Let me stop staring off in this space. Anyway, so what are the muscles that can perform the inversion and eversion, right? So inversion, again, bringing the sole of the foot in, is going to be due to the tibialis posterior and anterior. Both tibialis muscles are going to help with inversion. It is that tibialis anterior helps with dorsiflexion, so the toes up, while the tibialis posterior are going to help with the toes down. Eversion is going to be due to your peroneus, or the fibularis longus and brevis. For your deltoid ligaments, though, again, it's going to be the ones that are not the ATFL or the posterior I don't know, what does the A stand for? Huh? I don't remember what ATFL. Anterior talofibular ligament, ATFL. Yes. So posterior. I forgot. Talofibular ligament. Yeah, posterior, and then your calcaneal tibial ligament. There you go. So if it's not those three, it most likely will be a posterior deltoid ligament, or not posterior, a deltoid ligament, which is going to be located medially, and that's going to be your tibionavicular, tibiocalcaneal, posterior tibial-talar, and the anterior tibial-talar. So how do you find the cestum tali, and how do you differentiate the different tendons from corresponding muscles that pass by the structure? This is my last question. So the cestum taculi is a very interesting structure, because once you go here from the medial side of the foot, off the medial malleolus, you go about like an inch, or I'm sorry, not an inch, a centimeter off, and you feel like another bony prominence, and that's going to be right here. So roughly 1 centimeter off the distal end of the medial malleolus, and you're going to feel for this bony structure. How do you differentiate the different tendons from corresponding muscles that pass through this site? Cestum taculi is bone. Thank you. Good night. My Twitch chat lets me heat up some chicken and play Fortnite for my break. Yippee. My chat lets me get away with anything. I can get away with murder, and they'll be like, alright, I won't report you, and I'll be like, thanks. But no. Let me see what this is again. Calcaneofibular ligament. There you go. I'm done. I'm done. I'm done. I'm done. I'm done. I'm done. I don't want to look at this anymore. I hate applied anatomy. No, like, I like it. I like it. I just don't care for the professor teaching it. That's it. So let me check this really quick. So one moment. So I have about 67 flashcards that I wanted to go over. I am going to take a little mini break. I don't know if I do want to eat right now, or should I wait like in between patho or not. You guys are making it through the document? It only took me 3 hours. I want a vacation. I want to be free. But no, the issue is just I don't have snacks anymore. And would you believe I ran out of milk today for my cereal? So I can't even snack on cereal. Oh, what if I'll eat some mints. I'll eat some of the little soft mints that I have around. I'll stand up and stretch, I'll take some water, and we'll get back into the flashcards, because I don't want it to be really bad. I'm a bad influence. I would say take a very long break. I would, but oh my gosh, the exam, I have to study for patho tomorrow, and so I really need to make sure I take kind of small breaks because I need to study for 2 classes. The final I'm studying for right now, or what I am studying at this time, is tonight, but it's just because I work for the majority of tomorrow and I have to go to DMV. Oh, it's a mess! It's a mess! So I won't have time to study tomorrow, so I have to make sure I optimize my time. Yes! Tippa, please? Yeah? I'm sorry. I promise it'll be okay though. But I'll be right back. I will get through these flashcards because they're basically the study guide. I hope. Yeah. I be right back. Yay! Sorry. Alright, I am back. I ate 2 soft mints. That's all. I probably should have got more water, but I was like, whatever, I'll take a short break, but it ended up being longer than I thought, so I'm like, you know, it's fine. Anyway, so we are back. We're gonna do our Quizlet, and then this shouldn't be too long, or this shouldn't be 3 hours where like the study guide was. So hopefully we'll get through this quick, and then maybe we can jump into Patho. And then hopefully once everything's done, once we go through and review everything, life will be good, and I'll have some time to relax and maybe play Fortnite off stream. That would be good. I've never been more excited to play Fortnite in my life. Anyway, so first question. There is usually less dorsiflexion available when the knee is extended than when it's flexed. What is most likely the rationale for this? So we're kind of just talking about the stretching of the MLTs, the stretching with MLT, the muscle length testing. What does dorsiflexion? Let's break that down. So dorsiflexion is going to be when we bring our toes up, and that muscle is going to be responsible for tibialis anterior. But we're also talking about the concept of agonist and antagonist. So in this case, these questions are word salads? Welcome! Yeah! They are. So in that case, we might actually need to focus on the gastrocnemius, because there's usually less dorsiflexion available when the knee is extended than when it's flexed. And what did we say? Hold on. Ha! I think this was a pure memorization, because I was asking classmates this and we were both really confused about this, and I thought I had the courage to explain it. But so the gastrocnemius is a knee flexor and a plantar flexor. So when the knee is extended and when it's flexed, I'm gonna just flip it, I'm sorry. Passive insufficiency of the gastrocnemius. So passive insufficiency of the gastrocnemius is because it's the opposite action. Or is it the idea that you're basically doing all the opposite actions of a gastroc? I think that's the conclusion we had got to last time. Because the gastrocnemius is the knee flexor and a plantar flexor. To do the dorsiflexion that we were just mentioning earlier, to do the MLT, we would see only like 10 degrees. Well, when it's flexed, it's the idea that the soleus gets involved in all that jazz as well. And the soleus is a one joint muscle, so blah 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 blah. At the ankle, there are 3 tendons that run over the dorsal aspect of the foot. So this is the mnemonic I was telling you earlier about the Tom, Dick, and Harry. Tom referring to the tibialis posterior, Dick referring to the flexor digitorum longus, and Harry referring to the flexor hallucis longus. I know it's a little bit of a stretch, but that's just what they teach. Those are going to be our 3 tendons. What's going to be the most medial? It depends on how they're asking it. Oh, I'm so sorry. Those tendon things that I was just mentioning, that's in reference to the 3 ligaments that run medially or by the medial ankle or malleolus. This is referring to the dorsal aspect of the foot. The most medial should be anterior tibialis. Just because anatomy-wise, it's really weird to think about it, but we don't really have a lot of muscle below our knee for the anterior, like our shins. It's like tibialis anterior and then like the 2 flexors, and that's it. And it's like, Alright. Which of the following? Marble mocha macchiato power dog. Let's go! Hi Terry. Hi. Welcome. I feel bad. Even if you're caffeinated, I feel like study streams will be z. So you have to forgive me. But welcome. Glad to see you up and powered. Which, oh, let me also give you. Shout out. Alright. But I love learning. No, Sarah, this is suffering. This is for my final. I'm suffering. Anyway. Which of the following structures can be palpated in the medial malleolar groove, approximately halfway between the malleolus and the medial insertion of the Achilles tendon? So, as Marshall said, this looks like word salad, and it is, but this is what it's trying to say. So, our body is really cool and fascinating, right? We have arteries all over the place. We can feel for multiple. We can feel for our carotid. So you know that artery where people place like their 2 fingers on their neck and you feel a pulse? That's our carotid artery. We have a brachial artery, so like our armpit of the elbow, the antecubital fossa, you're gonna feel for your brachial artery. And we also have the radial artery, which is a very easy to access artery that a lot of people may do when they're checking someone's pulse. So they'll put like the 2 fingers onto the thumb side, a little bit towards the medial of the wrist, and you should be able to feel a pulse, but you might have to press down a little bit. This is asking, hey, what artery are we going to find in between our medial ankle, or the medial malleolus, or medial malar groove, so like a little groove or a little opening area, and between the medial insertion of the Achilles tendon? We know our Achilles tendon is going to be like the back of our foot, attaching to the, well, back of the foot. So what you're going to do for this one is that you're going to palpate between the Achilles tendon and the medial malleolus, and you're going to actually find the posterior tibial artery. Because the dorsal pedis artery, though it sounds very similar, the dorsal pedis is going to be relating to the foot, the back of the foot artery. Popliteal is going to be behind the knee, and the anterior tibial artery is going to be more anterior rather than here, where this is going to be more in the back. Ta-da! So according to Kendall text, the gastrocnemius muscle is tested in what? So we had just talked about this. This is going to be doing the opposite muscle opposite actions, right? So this one's actually a unique one because the gastrocnemius and the soleus are actually going to be tested in standing. So it should be C. Standing with the patient performing an active heel raise. Like we went over in the guide, this is the one where they're going to be on their tippy toes and going up and down basically. Let's see. Yeah, perfect. Which of the following ligaments is most frequently stressed in an inversion sprain? So we talked about the inversion sprain being the sole of our foot going inwards, correct? So this is in relationship to us causing stress laterally. Even when you do this motion right now, don't you feel like that stretch, or that like the feeling of your ligaments on the lateral side of your ankle, on the sides of your legs? So which is the ligament that's going to get injured the most? Well, we had actually talked about this earlier, and that's going to... Sorry, I don't mean to keep saying like we talked about this earlier. I'm just like, but it was on the study guide, so that means it was good that we learned it because we see it here now. But yeah, that's going to be the ATFL, or anterior talofibular ligament. That's going to be the one that's most frequently injured anyway, and this is the one that's going to be most frequently stressed with the inversion sprain. Bam! So what nerve can be palpated just behind and distal to the fibular head? Okay, this is something we didn't talk about, unfortunately. But nerves are very interesting in how they distribute among the leg. Right here is... Oh, Ichi! Hi, Dad! My son! The brightest in the world! Hi, Ichi! Thank you for the tier 1 sub for 20 Hakimas! Welcome, 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 welcome! How are ya? We're just talking about nerve distribution in the body, and pretty much what's going to happen is that we talked about it in that chart earlier of like, oh, this muscle is innervated by this nerve and yada 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 yada. So this nerve is actually really interesting because this one right here, behind and distal to the fibular head, is something you can even palpate on yourself, and that's going to be the common peroneal nerve. Anytime we see the word common in anatomy, we know that's going to split off to something. So the common peroneal nerve is going to split to the deep peroneal and the... Well, my memory is dying. No, don't do this to me. This is embarrassing. Okay, deep Superficial and deep peroneal nerves. Yeah. There you go. I'm just like. Ichi says, I'm good, gamer. Just woke up. Oh no, you're getting ready for work? I remember that grind. That grind sucked. But please have fun. May the vending machine man bless you. May you get all the cool snacks. Yeah, common peroneal nerve. Hack work? Yeah, hack work! Hack work! Hack work! Hack work! Hack work! When I used to work 10 to 7, I used to stay up like really late because I'm like, oh, it's okay, don't worry about it, you know? But then when I woke up, I'm just like, I have to get ready for work. There's nothing else I can do. And thank you, yeah, no problem, no problem. Alright, more word salad! So, if the normal end field for this joint motion is firm due to tension in the tendon and muscle of the triceps surae, and we talked about the triceps surae being the combination of the gastrocnemius and the soleus, the posterior capsule of the joint, and the ligaments of the posterior portion of the deltoid, talofibular, and calcaneofibular, what is most likely the joint motion? Oh, interesting. So, shouldn't it be plantar flexion alone just by the triceps surae? Let's not assume. I'm assuming. Ta-da! No! Talocrural dorsiflexion. Wait. Is it the opposite? Is that why? Heck. If the normal end field is firm due to tension in the triceps surae, because we do agree triceps surae, it's the gastroc and soleus that's gonna help with plantar flexion. The posterior capsule, and the ligaments of the posterior portion of the deltoid. Maybe it is just opposite, that's why. Because I can't really justify it anywhere else, and I can't really tell you why it's opposite. Which sucks. I'm sorry. Talocrural dorsiflexion. Yeah. Alright. A patient complains of trouble moving her left foot. She has 15 degrees active range of motion of dorsiflexion, so she's only able to bring her toes up 15 degrees, and on the right she only has 4 degrees of active range of motion of dorsiflexion on the left. So 15 on the right, 4 degrees on the left. But she has 20 degrees past the range of motion with a Fermi end field bilaterally and no pain on testing. Based on this information, the patient likely has what? So, I think this might be weakness, because if she's able to do this, 15 degrees is not super offensive, is it? Let's see. Yeah, because I think 20 is the normal active range of motion. So 15 degrees is not as offensive. And 4 degrees is really little motion. I think she has weakness and she's just not able to do it. It shouldn't be any capsular tightness or bony block because she's able to do it on the other one. But watch it be short and gastrocnemius and I'm gonna cry. Yay! Weakness! So the reason why it couldn't be the others is because the shorting one would assume tightness. And I'm sure she would have said like, oh, I feel a change of symptoms when being passively moved like that. Anyway, according to the text, the peroneus longus muscle is tested with resisting what? So this is just knowing the motions of the peroneus. And also known as the fibularis, this is going to be attached on our fibular bone. Bone on the lateral side or the outer side of our body, or the of our leg below the knee. So that peroneus longus muscle is going to be responsible for plantar flexion and eversion. So we're going to resist that, right? Yep, plantar flexion and eversion. Yay! Progress, learning, yay! Oh, the pes interinus on the medial tibial plateau is the insertion site of which streak tendons? Right? Easy. So we know that's our sergeant goosefoot. SGT. The S is going to stand for the sartorius, the G is going to stand for our gracilis, and the T is going to stand for our semitendinosus muscle. in some weird order. This is still correct though. The ELISA test is an MLT, the muscle length testing for what? So this is going to be in relation to the rectus femoris. This is the one test that is tested on the person's stomach, and where we have the knee bent, and then it's like, okay, can they bring their heel to like their back or their booty? How's the end feel? Is it firm? Is it soft? If it's soft, we can't really do this. We have to do another test to assess the tightness in the rectus fem. But if it's firm, there's no compensations, they'll have negative sign for ELISA test, so yeah. Rectus fem! Alright. A manual muscle test is performed in prone with the knee flexed to 60 degrees, and the lower leg medially rotated on the thigh. What muscle is being tested? So, a unique way, I guess the appropriate way, to test for hamstring strength is that you're going to have the patient in prone, which means laying on their belly. Their knee is going to be up, similar to the ELISA test, but their leg is going to be more medially rotated. You can test it in neutral, or more medially rotated or externally rotated, but when you're turning it in a more medial fashion, you're testing the more medial muscles on the back of the leg, or your hamstrings. You only have two of these muscles, which is going to be the semimembranosus or tendinosus, and semimembranosus is the only option there, so ta-da! Gerdy's tubercle is located where? So Gerdy's tubercle, remember, that's the one where if you have a tight IT band, you might feel some pain right below your knee on this Gerdy's tubercle, which is going to be located on also the side. So on the tibia bone, below the knee, of course, on the lateral side, you should feel a small bump, and that's going to be the Gerdy's tubercle where the IT band is going to insert. So I will say lateral proxima tibia. Oops. Yay. Alright. According to these texts on Goni stuff, which again is that measurement to assess range of motion, the amount of degrees normal for ankle inversion is what? So remember, this is the silly mnemonic I made about like, okay, one of them's 35, one of them is 15, they add up to 50, but you need to put your other 50% to give it your all, aka 100%. So we said eversion's a little bit harder, so that's going to be 15 degrees, so inversion must be 35. According to our text on Goni, the amount of degrees normal for ankle dorsiflexion. Oh no, this is where they get me. I don't remember for dorsiflexion. Is it 20? I think it's 20 and 30. And if that, it might be 25. Oh, okay. So normal bringing the toes up, the normal range of motion should be 20. You're going to actually have more degrees doing plantar flexion. So think of like the ballerinas in Aladdin, how flexible they are. They have extreme range of motion when doing that activity or action. So what are the primary actions of the peroneus brevis and longus? So again, remember, we had just talked about this early in the Quizlet. So the peroneus, otherwise known as your fibularis, is going to be a muscle below the knee on the side of the leg, and that's going to be doing what two actions? It's going to help us plantar flex, similar to the tibialis posterior, but this one is going to be doing eversion, so bringing the sole away from the midline of the foot or out to the side. I just imagine getting checked out and the person checking me out busts out a protractor. That's basically what they do. It's not necessarily a protractor as it is a goni. So let me see if I can pull up a picture for you. Goniometer. Bum, 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 bum. We'll see it in motion. Ta-da! Oh really? It's been a minute. No, you're good. Basically, they bust out this tool, which is your goniometer, or your goni, and basically they're like, alright, do this motion, flex your arm up, and it's just like, okay, alright, you have like this many degrees. Good job. So yeah. It is cool as heck. I think testing range of motion, it can be really fun. It's just kind of a pain in the butt. No, you're okay. You're okay. Do not worry. No, you're good. You're good. Don't worry. Here, let me. So, So I had to move these. So, oh no, this is the wrong one too. Heck. This is for Patho. This is for later. Anyway. Alright, what is the most common injured ligament? A. TFL. Anterior tibial fibular ligament. What ligament is most likely injured in an eversion sprain? So this eversion is going to be, again, if you move your foot and you put ankle eversion, you can feel that sprain kind of stretching it a little bit more. You feel kind of a stress in the medial ankle. So that's going to most likely be your deltoid ligaments that are getting, or most likely going to be injured if you were going to have an eversion ankle sprain. Ta-da! By the way, I'm sure a few of you cubs might have had ankle sprains in the past. I haven't. But these are the ligaments that you have that will get injured depending if you had an inversion or eversion ankle sprain. I feel like the most common ankle sprain though is going to be your, how do you say it? Your lateral side, so like your ATFL. So which motions do the tibialis anterior muscle do? You know why I'm so tired, by the way? Heck. I forgot I had coffee. No, I had coffee. This coffee is 4 hours cold. Hold on, let me sip it. I'm like, why am I tired? I forgot I put it to the side to let it cool off, and then Peace walked over, so I was like, oh, she's gonna walk here, so I'm gonna put this to the side. No. I love my cold, slightly bitter coffee. One moment. Should I chug it? I'm like contemplating. I'm like, just chug it. Be awake. Love your life. Thank you for the head pads. Thank you for the posture checks. Thank you for the hydrates. Thank you. Microwave coffee. Let's go. Let's do it. No, I think I might chug it. Bleh. I keep forgetting. Could just turn into iced coffee at this point. Let's go. Hold on. There's so much coffee here though. There's too much. I'll save it as a little treat for later then. Alright, now that the placebo effect has impacted me immediately and I feel more awake, let's continue. So tibialis anterior, that's going to be that weird muscle attached onto your shin on the front side. That muscle is going to be responsible for inversion similar to tibialis posterior, but this one is not going to do plantar flexion. This is going to do dorsiflexion. We can see the pain in that chug. Sorry. I don't really chug things. I want to master the art. I can like eat food really fast, but I can't like drink really fast. Anyway, which of the following muscles or muscle groups do not plantar flex the foot? So again, plantar flexing is bringing the toes down in that planting of the foot kind of thing, wink wonk. And we're going to figure it out. It's going to be the tibialis anterior because that's just the muscle we talked about. The gastrocnemius is going to help with plantar flexion. And what? And flexion of the knee. The peroneals or the fibularis muscles are going to help with plantar flexion and eversion. The soleus is going to help with plantar flexion alone. And the tibialis anterior, that's going to be again our drumroll, our dorsiflexors, not our plantiflexors, and also help with inversion. So due to its location, extensor digitorum longus is responsible for what? So the extensor digitorum longus is going to be in its name about its action, extensing, sorry if I say it weird, extending the digits of the foot, long muscle. I mean, it doesn't have to be the foot, but in this case we're talking about the foot. So extending the digits, or like our toes, long muscle, extensor digitorum longus. So it's going to be responsible for extension of toes, and it's going to be responsible for, I believe, plantar flexion as well. Dorsiflexion. No! I'm just gonna mark that one down. I guess because now that I'm thinking about it, the extensor digitorum is right by the tibialis anterior, and if the tibialis anterior does dorsiflexion, so probably this one should too. Alright, what nerves of the lower leg originate from which proximal nerve? Huh? Huh? The nerves of the lower leg originate from which proximal nerve? Okay, proximal means like closer up to the surface, so that's gonna be our sciatic, most likely, because our sciatic is going to then split. Yay! Sorry, I don't know why my brain's like, huh? Which artery can be palpated in this location? What location? I hate it! Alright. So the dorsal pedis, which again is going to be on the dorsal or dorsum of the foot, runs between the extensor digitorum and extensor hallucis longus tendons. Okay. What is the best description for palpation of the posterior tibial artery? So we talked about this already, so we'll just skip through it. So this is going to be behind and slightly below the medial malleolus of the ankle. Again, it's going to be between this and our Achilles tendon, so that like ligamentous ligament structure that we feel on the back of our foot. What are the three tendons? We talked about this: the pes anserinus, our sergeant goosefoot, sartorius gracilis semitendinosus. What structure can be palpated from the— wait, why are these repeating? Can the test be this easy? Can the test oh, sometimes the test does repeat, by the way. That's not fun, especially if you don't know the answer. Anyway, what structures can be palpated from the posterior to the fibular head as it wraps around? That's going to be our common peroneal nerve, which again, we see the word common, it's going to split, and it's going to split to the superficial and deep peroneal nerve. So what are the primary actions of hamstrings? So we associate the hamstrings a lot with the gluteus maximus because they're both going to do hip extension. So if this does hip extension, it's going to do the opposite action for the knee. It's going to do knee flexion. Your hamstrings again are going to be the muscles located on the posterior thigh. What hamstring muscles is responsible for knee flexion and lateral rotation of the lower leg? So this is depending on where it's going to be placed onto the body. So the bicep femoris is more laterally or more out to the side, so the one that should be responsible for both knee flexion and lateral rotation should be bicep femoris. Yay! So where do all four quadricep muscles insert? So our anterior thigh muscles, or the quadriceps, are all going to insert to the tibial tuberosity via the patellar tendon. Yay! The interosseous membrane sits between what two bones? That's going to be our tibia and fibula. So those two bones right below our knees, the tibia and fibula, they're not really connected other than through this membrane that we have. So use your imagination. Ooh, scary bones holding themselves up by ligaments and membranes. Oh my goodness. So what does a medial collateral ligament prevent? So I think this is like the opposite, right? So the medial collateral ligament is not a ligament we were able to talk about, but we did talk about the ACL and the PCL, correct? So the collateral ligaments are not that like X-shape in between the tibia and the femur. This is going to be collateral, so think out to the sides. This is going to prevent valgus stress. So the medial ligaments can prevent any lateral blows to the knee. I hope. Yay! Skeleton spooky? It's so spooky. I can't wait to become a skeleton for Halloween. Femur? I barely know her. Hi, SG. SG, when you can get out of work so we can play Fortnite. By the time you come out of work for Fortnite, I'm gonna be taking my dumb test. I want to play Dragon Ball Fortnite. I want to ride the dumb Nimbus cloud. It's not dumb. It's actually kind of cool to use. Oh, this is going over dermatomes, which I don't really know if he's gonna go over. Well, we can briefly go through these. So dermatomes are gonna be really cool. How do you call it? I think this might be actually best to grab a picture for. One moment. Dermatome. Trust me, I want to play too. I have about 3 hours left. Aw. Boo. Boo. No, it's okay. Alright, let me find one that doesn't have genitalia on it. Oh, heck yeah, brother. Can I just get one of the legs, though? No? Okay, heck me too. Would it be appropriate here? And we'll put it here. Oh, heck! We could just get the legs here. Let's go! I'm still in and out? Oh, wait. I'm so sorry. Let me read. I'm still just in and out of stream due to work, but I love swinging by. Surprised you're still going? Me too. But you know, yesterday I didn't really study, and today if I force myself, politely, to just sit here and study, then I'll be okay. Normally I would be doing these study streams, but again, because it's the end of semester, I'm just kind of losing my general drive to do things. So if I study and I sit here and I study as long as I can, or if I'm physically able to, not that something bad's gonna happen, but like until I get hungry, maybe you need like an actual like bigger break for like lunch, I think I'm okay to go until my exam. Not saying I'm gonna stream till 7, but if I had to, I could. And I don't know, it just helps me keep more focused so I can stop getting distracted and like going through Twitter. I would delete social media, but I will not. Big Ham, hi, welcome. Actually, thank you for shouting out Big Ham, I appreciate you. But yeah, I know we're at the dermatones. We're halfway with the Quizlet right now. After that, I can probably grab more water. Maybe. And then we can move on to Pathophysiology, and I'm really hoping I can stop at 5:30. It's almost 3 right now. I'm hoping I could stop soon so I could take like an actual mental break and then look over this again if I have to. I probably look over it with some classmates, and then I'll be set. And then I have one more exam done, and then I just have one more tomorrow, and I'm so excited. I'm not excited to take it. I still don't know anything about it, but one more exam. But Big Ham, sorry about that. I'm like in my world right now. How was your collab yesterday? Did you get what did they call it in Apex? Are you the champion? I'm like, did you get those victory royales? We did not win? Oh. As long as you had fun, that's all that matters. I was so confused because you know how you had shared all the screens? I saw Himpon's level, and it's like bad oh my goodness, I was gonna say Valorant. Bad Apex Legends player, and I'm like, but she's level 200 and something. Anyway, let me change this music. I have no idea what it switched to. Where did my music go? Oh, that's cute. It just switches to like really upbeat music when the playlist is about to be over. Level means nothing? I realize. She also isn't bad though? No. I assumed it was like a self-proclaimed like thing. Oh my goodness. Alright. I think we're yeah. Okay. We're back. But yeah, I'm glad that you had fun. I was getting like monk ass, and then I was just like, oh, go for it. And then we had anime night. So I'm super excited we get to cram as many episodes as you want. Actually, Big Cam, now that you're here, not to put you on the spot, are you still okay for 8:30, or did you want to still do 9 p.m. EST? Completely up to you. I know you do stuff when you get home, or when you're done with work at least. So just let me know, okay? What was I saying? Oh yeah, so the dermatones, right? So pretty much there's some really cool stuff that's happening with your spine, which I wish to show you. Oh heck, it's too zoomed out. Okay, look, there's a picture of your spine right here on the right, yeah? And so these spinal nerves come out, and what's gonna happen with these spinal nerves is that you're gonna have myotomes and dermatones. these myotomes and dermatomes, we'll focus on dermatomes first, are going to be these spinal cords innervating these certain regions in the part of your body. So we're going to be focusing on the lower extremities. So this one is referring to L1 dermatome, which is going to be the anterior pelvis or thigh or the inguinal region. So what was it again? L1. So we have L1 right here. The inguinal region is in reference to the inguinal ligament that you have right here. And this is your anterior or the front of your thigh. So yep, that makes sense. L2 is going to be mid-anterior thigh, which also makes sense. This is still like the medial aspect of your thigh, because if we were to cut this person in half, I would not. This would be the anterior, kind of like middle? Mid-anterior? Okay. L3 is going to be medial knee. Okay, yeah, I see that. Okay. L4, medial malleolus, anterior lateral mid-tib. Well, that's a lot. Medial malleolus. Okay. And then what was it again? Anterior lateral mid-tib. Anterior front lateral mid-tib. Okay. So I need to know L5? Yeah. And that's gonna be the what do you call it? Excuse me. Dorsal aspect of the foot, dorsal web space of toes 1 to 2. And this is going to be L5, which is going to be the dorsal aspect of the foot. And we see that right here, and it has the web space right here. I need to know more. S1 dermatome is going to be the lateral malleolus. So we're going to go out, so S1. And all the S's seem to be kind of going more back here and into the genitalia as well. So let's see. S2 is going to be heel. I guess? I guess we're kind of stretching it here, my friends. I don't consider S2 the heel. I consider more S5, but each this is going to be wacky. Each dermatome image that we'll get is kind of varied. Alright? L1, and now we're moving to myotome. So let's kind of go over this really quick, okay? So we have L1 to S2. So S1 is going to be the inguinal region, L2 is going to be the anterior medial thigh, L3 is going to be the medial knee, L4 is going to be like medial malleolus, and the anterior medial surface of the tibia. L5 is going to be that web space in the dorsum of your foot. S1 is... I forgot? Oh, my memory was doing so good! That's one I forgot. Did we say heel? Is that the one I was hyper focused on? S1 is heel, and then S2 is what? No! S1 is lateral foot. Okay, and S2 is heel. Got it. We'll go back to this later if we have to. So myotomes, on the other hand, very similar thing, but this is like the spinal nerves that we're talking about are going to innervate certain actions of the body. So L1 to L2 is going to be responsible for hip flexion. There might be a different image. Let me just double check really quick. Myotomes. This image is so baby small. This one is too dummy complicated. So what were they saying? They're saying L1 to L2, right? So we have L1 right here, L2 right here, and these are going to be responsible for apparently hip flexion, even though this says hip abduction. I'm just going to politely look away. So L1, L2, and this makes sense because we do have our hip flexors here. So, okay. Oh, yeah. L3 myotome, knee extension. Alright, L3 at the knee. Alright, I'm so sorry. He did not say to focus on this, but I feel like it's going to be on the test and I'm going to panic. But basically, myotomes and dermatomes kind of overlap in layering, so it's not too bad, honestly. I just have to kind of be like, is this the knee? Alright, now guess 50-50 basically. We'll still go rent. Oh my goodness, I keep pressing for the patho. Knee extension, L4 is ankle dorsiflexion, so toes up. Sure. L5, toe extension. Okay. S1, stop going. S1 is over here on the side, lateral. Are you gonna do like eversion or something? Let's go! Ankle eversion, plantar flexion, and hip extension. S1 kind of do be popping. Where else is on? S1? How the heck does it do all that? It's so tiny right here. Again, the image might be wrong, so teehee. No, I don't want my toes. S1 to S2 is gonna be knee flexion. So S1, S2's here, S1's here, and that's gonna be doing knee flexion. No, I no longer want to see these. Alright, L3, L4, this is called a deep tendon reflex, a DTR, and that's going to be in reference to the patellar ligament. So that's the one where pretty much where the doctor hit you in the knee, and to see if you have a response to that. The L5S1 deep tendon ligament is going to be for the Achilles tendon, and that's pretty much just testing that ligament out just to make sure. For your reflexes, L5S1 is going to be medial hamstrings, lateral hamstrings, hip. Okay, is this gonna switch? Yeah. One moment. Alright. When palpating the greater trochanter, which motion helps confirm its location? So the greater trochanter is going to be this bony prominence off the side of your hip. So if you were to grab onto your hips, you would feel a hip bone, right? Now kind of lay your hands flat out to the side, and what you want to do is kind of put your toes in and out when you're standing up, and you're going to feel a bony prominence pop into your hand. That's going to be your greater trochanter. So you would do the hip rotation internal and external. One moment. Right? What are the structures? Oh no, I'm losing my voice. I hate it here. What are the structures of the femoral triangle medially? So I know the borders. I don't know the context exactly. Is this referring to sale or mnemonic of like the inguinal ligament and the sartorius and the adductors? Sartorius. Okay, that's all that matters. What are the actions of the sartorius at the knee and hip? So remember, sartorius is our hacky sack muscle, so we're just gonna kind of flex the hip.
I've been waiting for this.
What? I can't know. Gatorade? Cute! Well, welcome, my fellow gators. Welcome. My name is Tipanya. I'm a bearcat VTuber to the cow ninya, and right now I'm studying. Normally it's more, not interactive, but more with a study guide rather than a Quizlet, but I have a final today, so I'm taking any resource and forcing myself to study. But how was your stream? You were just chatting? What were you just chatting about? Or were you, oh, don't tell me, were you also studying? Yeah. Either way, welcome. I appreciate you. Thank you so much for the raid. Unborn Vessel, hi, welcome. Damien, hi, welcome. Audi eats food. welcome. Nikita, hi. You were doing one too? Oh, anatomy? Yeah? Yeah, I was doing anatomy. What were you studying? Don't wait. Is it embarrassing? Will it click? Will it open my Quizlet? No. Hold on. Let me go back over here really quick. What were you studying? So I could be a little like stinker about it. Microbiology. Let's go. Let's go. I hope you're having lots of fun with that. We were just talking to someone who's like, oh, I'm like a biochem major. I'm like, oh gosh. Getting me sweaty over here with anatomy, and you guys are like ahead. Yeah, flexors in knee, let's go. Yes, I was referring to the sartorius as our hacky sack muscle. So again, we got the flexion of the hip, flexion of the knee, and external rotation, and oh gosh, abduction, something like that. But thank you for the follow. Thank you. But yeah, so oh no. And Odd, thank you for the follow as well. Welcome to the Cup Club. Welcome you too. So yeah, I have my final today, and pretty much this is like a applied anatomy course, so pretty much it's like, hey, remember this muscle? How are we gonna use it? Yada 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 yada. Molly Eats Food, thank you so very much for the follow as well. Welcome to the Cup Club. Welcome. And you're studying physiology? Let's go! Let's go! May I ask what your major is? If you don't have to share that with me. I also understand because I also vaguely share my. I'm curious. It's very rare to see other people studying physiology, so I'm just like, oh yeah. and Monkey, thank you so very much for the follow as well. Welcome to the Cup Club. Welcome. But yeah. Any resource possible. So I'm 51 out of 67 on this Quizlet. I was gonna take like a little mini break after this just to refill my water and chug the remainder of my coffee, and then we're gonna move on to pathophysiology, nursing, going into sports medicine, or pediatrics. Let's go! Oh my goodness, I love both of them. I love both of them, honestly. I wish you the best of luck with nursing. I know how, like, oh my gosh, you're already in nursing? Like, you're already in a program? Okay, this is the third time. I'm so sorry for the cups are here. The third time I mentioned this, but I was talking to another cup who was going into nursing. I'm like, oh my gosh, it's so competitive. My community college had a huge wait list, yada 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 yada. So for you to be in it, congratulations! Or for you to like want to go into it, congratulations! I wish you the best of luck. Sports medicine is not a bad career whatsoever. I think I had shadowed under like a outpatient orthopedic clinic, and I liked what I saw there. So yeah, and pediatrics is really fun too. I think they're super cute. It's cuter with like the slightly older kids who you can have conversations with though, because I felt so bad. I'm not sure if you're familiar with this condition, like what is it called? Torticollis? Oh my goodness. It's basically like the neck is stuck in a certain position, and it was like a tiny baby. He didn't know what was happening, but we're like, I'm watching like the clinician like move their like or stretch their neck, and this poor baby's crying. I'm like, oi, tiny baby, I just want you to understand we're trying to help you out. What muscle is it? Your sternocleidomastoid is stuck. Let's get it unstuck. It's just simple baby terms. Either way, best of luck with your career choice. I'm rooting for you. I'm rooting for anyone really. Everyone going to education, good luck. Anyone who's done with education, good luck. Anyone who's decided education is not their thing, good luck. Waiting for tips to hire me? Okay, when I open my own clinic, Marshall, I got you. But you have to give me like 10 years. Wait for me, Marshall. Wait for me. And move to Bearcat Mountain. But yeah. Oh goodness. I can wait. Let's go. I don't know. I never really thought of opening my own clinic, but it's a very popular option. Let's just say that. But anyway, so the sartorius muscle is going to do hip flexion, abduction, and external rotation. It's also going to help with knee flexion. And again, that's one of the muscles that are going to insert to our pes anserinus. So the inguinal ligament runs diagonal and lies between which bony landmarks? That's a good question. I'm actually not sure. I have to flip this one. I can't even like pretend to guess. No, I could have guessed. Alright, so it's the pubic tubercle, which is just, yeah, and your anterior superior iliac spine. So these are going to be the two structures that's going to run between ASIS and pubic tubercle. But just for reference, for my reference, what pubic tubercle are we talking about? And is it it definitely has to be before the pubic symphysis, right? So yeah, let's go. So we talked about the ASIS, right? Imagine this wasn't a zoomed in picture of the hip, right? So right here without the zoom in would be the ASIS, and then this is your pubic tubercle, and then from here this is your inguinal ligament. Just pretend it's there, okay? Yeah. Huh? Yo man, hi, welcome. How's everyone and their mothers doing? I hope my mama bearcat's doing really good. Welcome, 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 welcome. What's being studied? Right now I'm studying applied anatomy, but I'm almost done with this because it's 4 hours in, and I'll be switching to pathophysiology in a little bit. But welcome, welcome. Where's the femoral artery or post easily palpated? So isn't this gonna be in the femoral triangle? Can the answer just be femoral triangle? No, but that's basically it. So the femoral artery, you know how we're talking about the arteries to feel for pulse, and we talked about the radial, the brachial, and the carotid? Well, femoral arteries is also another interesting one you can palpate. I don't know why you would necessarily actively want to palpate it, because it's kind of in a, not saying it's an intimate place, but it's kind of on the anterior thigh. And it's kind of, let me see, I think it's more medial, yeah. So so this is going to be between the midline of the ASIS and the pubic symphysis. So this is going to be a little bit higher up than what we had just previously saw in the other image. Wait, no it's not. Oh my gosh, my brain, my poor brain. Okay, so you know how we're talking about the inguinal ligament that's going to be at the ASIS and then to the pubic symphysis? Well, this is saying that's going to be the midway between the ASIS, which again, pretend it's there, to the pubic symphysis. So anytime medial from here, that's still like the front of your thigh, and like, again, it's too intimate. But you can feel for right here. Apparently it's going to be the best place to feel for your femoral artery. From here, what two muscles make up the upside down V? What is this? Of the lateral femoral triangle of the hip. Is it your sartorius and your adductor magnus? No, TFL! No! Are you studying to become a doctor or something? Yeah, basically. I have to get my doctorate, so I basically will become a doctor without being a doctor. Doesn't that suck? Imagine it's like, yeah, but no. You will refer to me as Dr. Tipanya in like 4 years, though. Well, you don't have to. I'm probably gonna be like, yeah, you can just call me Tip. It's like, but didn't you get like all these years? Don't you want the title? Not really. I'm just doing it because I enjoy the career, I guess. I hope. Hi, Atomic. Welcome back. How's the art? The studying is kind of like dummy. Studying kind of be stinky, but I'm almost done with the topic we've been focusing on, so I'm excited. Huh? Yeah, so there, you don't need, oh my gosh. I don't know how to explain it. Your doctorate is like the highest degree you can get in anything, and technically you are a doctor in whatever you study, but you don't, what? How to become doctor, Google. How to become doctor. Because medical school and like the school, bearcat school, are like two different things. Yeah, education system kind of stinky though. Art's still in progress, but the idea of where it's going is there. Let's go! We love a work in progress. I'm super glad that's going well for you though, and that you made some progress. Not like I've given up, but I'm like, no. But no worries. I'm so sorry, but I have given up on the search of what it takes to become a doctor. I just know they go through lots of years of school. I mean, I am too, but apparently to Google it says 10 or 14, so I'm like, okay, maybe not that long. So the two muscles are going to make the upside down V of the lateral femoral, lateral femoral triangle. That's where I got messed up. I scream at rocks for a living? That's a good life. Do not worry. Just know I'm trying my best. And this is me trying my best, actively. Welcome, 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 welcome. Yeah, let's see. Where's the fulcrum place for measuring hip abduction and adduction? This should be the ASIS? Yes. So, this is probably better in a picture, but you know how I told you hip abduction and adduction, abduction, adduction, are going to basically be like, hey, are you bringing your leg away from the midline of your body or from the center of your body? Are you kind of kicking out or are you kicking back in? To perform this range of motion, you're gonna lay on your back, and basically the goni that I had showed you, that tool, we're gonna overlay the middle point, the fulcrum, or the axis of rotation on top of that ASIS structure that we've been identifying so often for these last few questions. And then you kind of go from there. Your movement arm will follow your leg whether it goes in or out. What is inter-rater reliability? That is a great question, Quizlet. So inter-rater reliability is 2 or more examiners are able to reproduce the results over time. Okay, cool. So you're not using like fake science or whatever. It's just like, hey, I did this. And it's like, did you really do it? Yeah, try it. Whoa, I got the same thing. Wow. Inter-rater reliability. What is validity? Each time a test or measure is performed, we must understand that the results of the test compare with the truth. So I guess, hey, is this tool valid enough to do this? If I use a ruler, is that a valid tool? Yeah. When is the instrument considered valid? When it measures what's supposed to measure. Let's go! Ruler, goonies, let's go! True or false? A valid instrument is always reliable, but a reliable instrument may not be valid. So a valid instrument is always reliable because it should measure what it's supposed to measure, but a reliable instrument may not be valid. Yeah, because reliable is not the same as valid, so this would be true. Yeah! Accuracy requires consistency. So yeah, though you have old reliable, does it really measure what you want it to? Let's say like a thermometer for temperature. Do you really have a fever or do you not have a fever? God King Killer? Hello? YOLO? I'm a little spooked. What does this YOLO mean? You're spooking me. But hi, welcome. Unless you mean, yeah, hello. Welcome. So, oh heck. So this is just another definition. So the examiner is going to be able to reproduce results over time. So again, this is again the inter-rater reliability. The examiner is going to be able to produce results over time. The minimum amount of change that is not considered measurement error is going to be like minimal detectable change. Let's go! I'm losing my voice! Cracks, one moment. Alright. Thomas test. Oh, so Thomas test again, this is the one that's going to test like the various muscles in case the Eli's test from earlier didn't work. Huh? Okay, what is it? What is what? Huh? Anyway, so the Thomas test is going to refer to see if you have any tightness in the following muscles. It should be your iliacus, your rector femoris. What else can it be? Let me see. TFL, the tensor fascia lata, or sartorius. Why is Thomas testing my muscles? That's a great question. You know, when someone finds something, they're like very self-absorbed. They're like, I'm just gonna name this test after me. Yeah, that's basically what happened. Yeah, so you're gonna test, oh, not 5, I'm so sorry, but the 4 muscles. Iliopsoas, iliacus is basically the same thing. So iliopsoas is an informal combination of the name of the psoas major muscles and minor, along with the iliacus. One moment. Slightly dies. Alright. So that's a combination of the iliopsoas, the rectus femoris, sartorius, and the TFL/IT band because that kind of runs over and overlaps with each other. And that's going to be your hip flexor test. So the Thomas test normal measurements. I'm going to flip it over to see what it means exactly by that. Oh, okay. So the thigh touches the table with the knee at least at 80%. So the Thomas test is a little weird. I don't know if there's really a good image for it. We might have to watch a video, but I'm also not that dedicated to the Thomas test, so you have to forgive me. supposed to open it? Oh, I have to download? No, no thank you. Hold on one moment. So the Thomas test is a very interesting test because you have to have your patient stand up, you have to be on their this side to help them out, you lean them back and their leg goes down. So pretty much, if I remember this correctly, if the leg is still up, you have to determine if it's one or two muscles, if it's the iliopsoas or it's the, let me see, the recte fem. And if you straighten it out and the leg goes down, that means that it's still potentially recte fem, but definitely you've taken out iliacus or your hip flexors out of the way. Then you do a whole nother procedure and Thomas test can go heck itself. So yeah, when the thigh touches the table with at least 80 degrees of flexion like we see here, that's going to be normal. Because what happens is that it won't be normal if the thigh was still coming off, like a little bit higher off the table. If it touches, we're good. Shortness of rectus femoris is evident when you're not able to flex the knee at 80 degrees, but the thigh can touch the table. So similar to how we just cleared iliacus. So, okay, the knee's not able to flex? Okay. So it would be maybe like right about here where my mouse cursor is, but the thigh still touches? Okay, maybe it is recte fem. The shortness of iliopsoas is evident when the knee can flex at 80, like we see in that picture, but the thigh doesn't touch the table. So it's much lifted off, but you still get this bend, if even more so right here. Alright? Shortness of TFL or tension fascia lata is evident when I believe you're doing internal rotation. That's going to be the main thing. So you're able to do the flexion that we've been wanting in these Thomas tests, but your knee is basically going to point more inward, while for sartorius is going to be more outward for external rotation. And that's it! We're done with this Quizlet! So let me close these tabs right here. So pathophysiology, I'm going to take a little break to grab some water. We'll probably go over it in the next hour and a half, hopefully not that long. We'll try to go to the Quizlet, which will take an hour. And then from there, I can take a baby long break and play Fortnite or something. I don't know. Anyway, make sure to stand up and stretch, live a good life, and I'll be back. I'm just gonna grab some water, okay? And stand and stretch, yeah? Please do the same as well, okay? BRB, be right back. Ah. Ah. Hey, the rigging's... There's no rigging for the raffles. If you enter, you enter. And if you don't, well, you don't. Anyway, I am back. Life is very okay, I guess. I don't know. I don't want to study, but I have to because I would be putting my future self English. I would be doing my future self a disservice if I decided not to study. I mean, come on, I already studied for 4.5 hours. What's another 2 hours gonna do to me? Nothing! Nothing! And then after my exam today, if there's enough time, I could play more Fortnite. And then afterwards, it's gonna be anime night where I get to marathon like Full Metal Alchemist. So, hello? I have so much to look forward to. I just have to get through these next few hours. Ah! Anyway, thank you for the ass. Too risky? Someone say Fortnite? I did! I'm excited to play. I wanna get the Dragon Balls. I don't wanna pay $18 for it. I just wanna do the dumb side quest. Anyway, is Rosalie around? Rosalie! Marshall needs you! Just imagine how much Fortnite you could play after your no test. Right? I'm so excited! Oh no, I have to see this through. Hold on. I'm ready. Oh my goodness! Congratulations, Rosalie! How many points do I have? Oh. Is it points? I'm poor. No, what's happening? Lim says, I spent the last 2 hours memorizing the locations of the Kamehameha locations. Well, a good one is the familiar place on the far island. Actually, it was so funny because when I got to play, I was Kamehameha, that's how I would say it, a person, and they hid behind a rock. But it turns out that when you perform this action, it basically obliterates everything on sight. Oh no. Oh no! I can't believe I'm seeing stealing live in chat. It inspires me. Inspiration met. I can finally study for 2 hours now. I have all the hope in the world now. Familiar place is so heckin' crowded. Okay, I'm not gonna lie to you. I must have been really lucky because when I had first got into the game, it was the furthest place in the line. So yeah. Anyway, so many wins. Oh no, no, not Teru though. I'm sorry. Hold on. I got you, Teru. Give. I forgot the command. Yeah, give Teru. Give Teru 1,000. I'm rich now, Teru, so you can have it. Anyway, gosh, where am I? So I'm back here in my little study room, and so right now the thing we're going to be studying is pathophysiology. So basically, how does the body work and any disease related to it. This is not my study guide because God knows I do not look at pathophysiology, but so whatever happens, we're going to be learning together pretty much. We're going to be learning about the respiratory system and the renal system. I don't think we had a chat quite yet about the last chapter, but that's something I can look over, some notes and all that jazz. So fingers crossed, paws crossed. If Teru trusted me, she would have made so much. Marshall, it's okay, don't worry. Teru gets to choose who she trusts and doesn't trust, and you're on the untrusted list. Yeah. So let's learn this together, okay? Let's go over Unit 12, and once we go over this is only 14 pages. This is baby stuff. Let's get through it and hopefully take a baby break soon, okay? So Unit 12 is going to be in relation to the respiratory system. So we actually have some muscles that are going to help us for respiration. That's going to be our intercostal muscles. So we have muscles in between our coastal, let me not say that, between our rib cage. We have an internal and external. We have our diaphragm, which is this big balloon shaped like muscle that's going to be below our thighs. Oh my gosh, ribs a lot. We have the scaly muscles, which are going to be our neck muscles right underneath the sternocleidomastoid or right besides it. And then we have our big boy sternocleidomastoid. All of these 5 muscles are going to help us for breathing. So for inspiration, when we breathe in, our diaphragm relaxes, so that big, I'm gonna get a picture because the diaphragm's pretty important, TBH. Hi, welcome. We're studying about inhalation and exhalation. Welcome. Let me get this, let me get that, let me make sure no one said anything dummy in chat. No one said anything dummy in chat. Posture check. Hi, Toho Fanatic. Hi. Say the bad word. You come in here and you tell me to say the bad word. Heck. The biggest heck. Welcome. Huh? About the habit. What? The habitat? Oh, my habitat here in Bearcat Mountain can be warm. I think it's hot all over, so that's pretty biased. My immediate habitat, which is my room, pretty comfy. I hope that answers it. Tara says, I don't remember if I put your name on the list, and I also don't trust myself, so there's no way to confirm it. No! I need those Teru bots. Are you a doctor? Not yet. But thank you for the head pat. Thank you. I didn't get to say it. Heck. Alright, did I get my diaphragm muscle? Yeah. So this is your diaphragm muscle. Pretty cool muscle, right? Let me make it a little bit smaller. Here's your thoracic cavity. So there's this, and then here's going to be your ribs. And right underneath the ribs, like I said, is going to be your diaphragm. Big balloon-like muscle that's going to be a big part of your inspiration or breathing in. And then we have the abdominal cavity right below. Blue, hi, welcome. Wait, no. Good night. It's only a short visit. Not a problem. I know it's kind of late over there anyway. So please have a good night and the sweetest of dreams. Thank you for stopping by, okay? Bye. So. our inspiration. So when we inspire, when we breathe in, our our diaphragm is going to relax and our thoracic volume is going to increase. So from the side view, we could see the expansion by a pump handle, and this increases the anterior and posterior dimension of the rib cage. So yes, the diaphragm, when it relaxes, is going to be the cause of the thoracic volume increasing and making our chest go big. Does the diaphragm attach to the lungs and contract to pull the lungs down? I'm not sure about the interaction with the diaphragm and lungs. I don't know if it pulls it down. I don't think the diaphragm has no connection to it, but maybe the whole breathing cycle may affect it. But I'm not 100% sure. I'm sorry. I can't confirm with you though, as the origin and insertion of the diaphragm is not anywhere near, not anywhere on the lungs. So ta-da! So the front view, look at this Pepe. Anyway, and so the front view is going to be a bucket handle where it's going to increase the lateral dimension of the rib cage. So I'm not going to lie to you, this is something I didn't really understand, so let's kind of see about it. Movement of the thoracic cage and diaphragm. Respiratory movement, movements of the ribs. So the pump handle movement, they were saying that this is something that we see on the side view. And when they say pump handle, they're only going to be in reference to this, like an actual pump handle for getting water. So this is going to increase both the antro and the posterior, so the front and back diameter of the thoracic cavity. When this happens, the ribs can move? Yeah. Yeah, ribs can move. You know you have floating ribs right down under as well. Those are definitely movable. Definitely something to be cautious about, because when someone injures their ribs, depending on where it is, I think you could like puncture your diaphragm or something like that. But I'm only a student. IDK. How can the chest expand? Wouldn't that need broken bones? No. You have enough room in your thoracic area, your cavity, to go. What? I don't. I'm sorry. If the ribs couldn't move, CPR would be very different. It would. Hi, Pretori. Hi. Welcome. They're not like, I'm not saying your ribs are elastic, but they're able to move. So they're saying the pump handle motion will happen here. I wish I can read whatever the heck this is saying. Superior and anterior movement of the thoracic, I guess. So it moving up and down is going to be the pump handle. But if we were to look at it not from the side, but if we were to look at it through the front, it would be a bucket handle movement, which is going to increase the lateral diameter. Oh, I am understanding now. So this is why this is the pump handle, up and down. So again, when your respiratory system, when you're gonna inhale, it's going to move up, down. But this is like more of a bucket handle. It's gonna also move up as well. Do ribs have connective tissue to connect to the sternum, allowing them to move? You have hold on. I don't want to say it wrong, because I'm like, you have coastal cartilage, and the cartilage connects it to the sternum. And it is, yeah, cartilage is it. I'm like trying to confirm. Let me not spread fake information. So yeah. So what happens is, do I have an image? Here? So your ribs are going to attach using the coastal cartilage, which is a type of connective tissue, to attach to the sternum. But what happens is that your ribs are also further divided into true ribs and false ribs, and your false ribs are going to be down here. And the reason why they're false, rib 11th and 12th, is because they're not connecting to the sternum. So wow. The ribs have to move together with the expansion of your lungs to make sure you don't stab yourself. Let's go! Not stabbing yourself. But how are you? I'm good. Thank you for asking. Wait, says if my knowledge of human anatomy is correct, that is? Yeah. Basically. If you do adult CPR correctly, often they get broken ribs. Yeah, but save their life or broken ribs, you know? Hi, Mr. Dark Souls. Hi. Welcome. Hello, are you a doctor? Not yet. That's why I'm gonna keep telling Cubs. Not yet. I'm not planning to be a doctor. I need a doctor degree, so I will technically become a doctor. There's a lot of loop-de-loops in my modesty and privacy. Mr. Dark Souls, thank you so very much for the follow. Welcome to the Cub Club. Welcome. But yeah. Alright, let's move this back down. Alright, so when the diaphragm relaxes, when we breathe... Sorry, let's start again. When we inhale in, so as we breathe in, the diaphragm is going to relax. As the air is coming in, the diaphragm relaxes, the thoracic volume is going to increase, and we could see it in a different plane. So we could see it on the side, and we could see like the pump handle, which we're going to see both like the expansion of both the anterior and posterior diameter, the cavity increase, and then we could see it from the front, and we could see it like the bucket handle, and we're going to see the lateral diameter, so lateral being out to the sides right here, increase as well. So for expiration, the diaphragm is going to relax as well. Are they confused? Is one gonna increase? I'm not gonna say this is gonna increase. I'm gonna say this is gonna expand. I'm gonna say that. And then this is expiration, the diaphragm is going to relax. That to me makes way more sense. It's how you're gonna have the diaphragm relax. Blah 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 blah. Student notes. Blah 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 blah. Mr. Dark Soul says, I see. You're planning to steal organs and sell them to the VTuber market. Man, if I didn't switch over to slobs, switch over from slobs to just regular OBS, I would show you a secret thing. I do steal organs. I have stolen eyes before, I will admit that. But, you know, that is a good idea now that you bring it up. I can actually sell them? You're absolutely right. You know, thank you so much. I'll give you a small percentage when I start doing it, okay? Bad end. Yeah. So we have different lung volumes and capacities. So this is a chart of the lung volume. So you have the maximum possible inspiration, as much air as you can keep into your lungs, and the different capacities, which are going to be the sums of these. So I hope they explain it here. Because you have like your residue volume, your expiratory residue volume, your tidal volume, the internal reserve volume, IC, I don't remember what IC is, I'm so dummy. VC, yeah, let's go here. So your capacities are like the different types of volumes. So let's go over just regular volume though. Seems like despite the Bible's creation story, men and women both had 12 pairs of ribs. Is that the math? Yeah, I mean we had 12 ribs. Yeah, a pair, one on each side. Yes, you are correct. Hi Disco, learning. I am learning. Thank you. I'm trying my best to learn. Dang, I guess I'm a criminal now, but now we're partners in crime. Isn't that cool? You have a friend in me. Or more like a friend enemy. Frenemy? Puyo says, and some people can have extra ribs above their normal ones called the cervical ribs or the thoracic outlet syndrome. I have heard of this. I can't speak too much because I don't know too much of it, but isn't it like something about the first rib? Heck. Anyway, so yeah, the volume. So we have tidal volume, which we're gonna see here, which is the amount of air inspired or expired during normal resting ventilation. So as we breathe in and out right now, that's gonna be the normal amount. We're not hyperventilating, we're not hypoventilating, hopefully not. That is gonna be our tidal volume, which is gonna vary from each individual. Then we have the expiratory reserve volume, which is gonna be the amount of air in excess of tidal breathing. So yeah, okay, so we breathe out normally, right? With normal our breathing cycle, but we could push more air out. So I could do you see? Sorry, that's probably like weird. But you could push more out. You could push more air out than normal outside your tidal volume, and that's going to be your ERV. The inspiration is the amount in excess from the tidal breathing. So yeah, I inhaled air in the normal amount, which would be like, but I could probably breathe more out in. Oh my gosh, what is my English? You could probably breathe more in. So a normal breath would be, and then the second one would be, and that's your inspiratory reserve volume, or your IRV, your residue volume is going to be the volume of air remaining in the lungs after your ERV has been exhaled. So residue, think of like the word residue. Basically, it's going to be the amount remaining. You cannot expire this as much as you want to expire, because if for whatever reason you exhale your residue volume, I'm pretty sure your lungs would collapse. And I'm pretty sure that does happen to some individuals. I think not to put names, was mentioning that their coworker deals with collapsed lungs, and I think that's horrifying. So these are going to be our volumes. So let's talk about our capacities then. Oh, but sorry, let's before that look at the graph again. So the maximum I'm sipping water. I'm taking a breath. Hold on so I can stop stumbling. I'm so embarrassed. Hold on. So this is the maximum possible expiration, and we see it's right here about 1,000 milliliters, but you see this is the expansion from 0 to 1,000 for the residue volume. Again, this is the amount that we can't expire. This is our expiration, the expiratory reserve volume right here underneath the tidal volume, which again is going to be our normal breathing cycle in and out. And then we have the inspiratory reserve volume. So this is the maximum possible inspiration, which is going to be about 6,000 milliliters. Right? From there, let's talk about capacities, which is going to be the sum depending on what volume we're adding up. So for capacities, it's going to be 2 or more lung volumes. She did an abbreviation called VFit, but I have to try to remember what that entails exactly, so give me probably a hard moment. So, excuse me. So we're going to have 4 different capacities. We're going to have a vital capacity, a functional residue capacity, an inspiratory capacity, and a total lung capacity. So for the vital capacity, that's going to be our tidal volume plus expiration plus inspiration reserve volumes. These are going to be the all possible volumes of the air in the lung under volatile control. We can't control the amount of air that we have in our residue volume, again, because we need that amount of air so our lungs don't collapse. But we can control, again, these 3, the TV, the EVR, and the IVR. For the functional residue capacity, that's going to be the combination of residue volume plus external residue volume. So this is all going to be the lower side or the bottom side of our lung volume. See? EVR, VR, together, functional residue capacity. Our inspiratory capacity is going to be the tidal volume plus the inspiration tidal volume. And then the total lung capacity is going to be everything combined. So your total residue, your EVR, IVR, and residue volume. So that's going to be, I guess, our abbreviation of VFit. Vital, functional, inspiratory, and total lung capacity. So vital, again, everything under our control. Functional residue is if we exhaled almost everything. Inspiratory is what if we inhaled everything. And total is going to be everything, even the one that's not under our volatile control. Blue says, fun fact, when people are stabbed in the chest, it may cause a sucking chest wound, so they're advised to take a credit card to hold over the wound for a good seal to prevent lung collapse. That's horrifying. That's so scary to think, but in anatomy in general, for whatever reason, there's been a lot of incidences where, not real incidences, but like, my anatomy teacher would be like, hey, if you got stabbed in the chest right here, and you got stabbed over this nerve, what would happen? And I'm like, do people get stabbed here often? Like, our long thoracic nerve. So let's say you don't hit the lungs or you puncture them for whatever reason, but you get stabbed enough into the rib, you might hit your long thoracic nerve. And what's going to happen there is that you may end up with winged scapulas. So your shoulder blades have like the blade at the most inferior angle or the bottom angle might start poking out from your back because you don't have any innervation to it, because of the stabbing wound or the stab wound of the long thoracic. So, oh boy, okay, this is where I remember getting lost in the in the guide. Oh no, I'm getting hungry. But so here's the trick. So we're gonna know obstructive versus restrictive. We're gonna talk about the types of ventilation. And whoever spelled dilate, they don't know how to spell dilate. So I'm gonna fix this really quick. And from there, I think I will take a little mini break. I'm gonna go heat up food because sugar is getting low. So I'm like, heck. So for obstructive, you're gonna have problem getting air out. Hence obstruction, or like, hey, something is blocking this or obstructing our view or our path or etc. So for the obstructive, you're gonna have problem getting air out, while restrictive, you're gonna have problems getting air in. So nothing's obstructing you, but you're having trouble with breathing, so it's like it's very limited or restricted. So we're gonna look at the equation for each part and find the problem. Oh boy, I actually don't remember this from the study review. Have good noms? Thank you, by the way. I will. I have the best noms right now. Hi, Flame. Hi. Oh, thank you for the follow as well. I appreciate you. Welcome, welcome, welcome. First time seeing an education stream. Wait, how did you find me? You just randomly go through the tags? It's like education. It's like, oh, heck. Either way, welcome, welcome. We're learning about pathophysiology right now. We're learning about lung capacities and all that. Or we were. Now we're just talking about general, like, breathing. It was your recommendation? Let's go! Look, Mom, I'm on the recommendation. But thank you for the follow. Thank you for stopping by. I appreciate ya. Blue says, I saw someone dissect a pigeon on Twitch the other day. They can do that? The lung was dark red and had spongy cross section? That's interesting. So if it's dark red, I guess there was a lot of... I was gonna say blood, but I'm like, wait, don't say that. Maybe that's just the normal coloring for a pigeon. A pigeon, though? Sorry, I feel bad for any animals. Did you know, how do you call it? Someone was telling me that in their high school they were dissecting cats. And I don't know, maybe because I'm a cat owner now? I mean, even if I wasn't a cat owner, I think dissecting cats are so scary. I think it's a little too real. I mean, as I dissect humans, but like I don't know, a cat makes me feel bad. I remember dissecting on like a frog and fish, and it didn't make me feel as bad, but like I don't know, a cat would make me feel really bad. I know Dr. Pestis dissected a bird. Not sure if it was a pigeon. So scary. Yep, it was that streamer? Oh, small world, let's go. Wait, what? What? It'd be sad? Yeah, exactly. Where are they getting these cats? I think it would make me really sad because someone had told me they had dissected a pregnant cat, and I'm like, no way. I mean, I did have a study last semester. Don't tell me you dissected a cat. I don't want to hear it. It's so sad. Anyway, so I'm gonna hope to understand what my teacher was saying. So anything red is obstructive, and anything in blue is gonna be restrictive. So in total vital capacity, you're going to have obstruction getting air out, so you're gonna have trouble with your expiratory reserve or residue volume, which makes sense because we just talked about that being the like forced amount air you can take out, and if you're having problems with it, that means that this is going to be decreased. But for restrictive, you're gonna have trouble getting air in, so this is why this will also be decreased, because again, inspiratory reserve volume is the extra that you can inhale, and if you're not able to, that means you're having trouble getting air in. Wow, this is actually easier than I thought. I mean, I did have a study last semester. It showed humans are more sympathetic to abused animals than abused humans, but some animals are more likable than humans. Just a little bit. I don't know. It's a weird, touchy subject. I think the best way I can kind of sum it up is that I make sure to show Peas, which is my cat, on my head, like extra love. She's a real animal, by the way, not just some random PNG on my head. I show her extra love because it's one of those things where I'm like, well, you don't understand human speech and language, or I mean, you understand your name and you understand when I say food or up. But you know, I make sure to show her love because I don't think she just like understands. So I want to make sure she's as loved as much as possible, basically. I just noticed Peas. Oh, she's like a nice fashion accessory. She really matches like the dress and the scarf and all that jazz. But yeah, I needed her for emotional support midway because I was getting like, oh. I make sure to study hard, not for a future me, but also for Peas. I'll get her a cute cat tower, or when I get like a house or something, I'll get her like those little, how do you call it? You know that people have like random shelves on their walls? I think that would be super cute. Peas is very athletic. I have like an extra mattress sitting in like my apartment hallway because my my roommate had an extra, or I have a bed frame. How to explain it? When I moved in, my roommate had an extra bed frame and a... No, they didn't. They had an extra mattress. Sorry, not to put my roommate's business out there. But they had a bed frame. I'm not gonna lie to you, the previous place I lived in, I did not have a bed frame. I only had a box spring and a mattress, and I kind of basically slept on the floor, which didn't really bother me because I'm like, oh, I'll get a bed frame later. So when I moved in here, they're like, you can have my bed frame and you don't need your box spring anymore. But I'm like, oh, but I also like my mattress too. So I have like a bed frame or my previous box spring and their mattress out in the hallway, and Peace kind of just like traverses it from time to time. So super cute. So I kind of want to just get her that, and I want to make sure to work hard for that. I obviously can't really do that in the apartment because I'm worried about I don't know, the contract and whatever, but it is what it is. How old were the humans, by the way? Oh, I guess that varies as well. That girl, hello. Teru, no sad. Don't be sad. It's okay. I think it's really important for us in general to be able to like work for future us, you know? Even if it's like very silly goals like that. But yeah. Oh, I'm getting so hungry. I may accept to actually stop. Not stop, but I might have to take a break really quick. But let's see if we can get through these remaining 3. I probably won't get through types of ventilations until I'm done. So for functional residue capacity, so again, as one of our capacities, for restrictive, we're going to have increased residue volume. So you're going to have that trouble getting that air out, which makes sense because this is air that you're not able to get out in general. You can't really touch under volatile control your residual volume, but you will have decreased expiratory reserve volume because of possibly this increase in residue volume. So, but curse head pats, I got you. Let me finish this. I'll curse head pat you, and then I'll BRB. For inspiratory capacity, this has nothing to do with the obstructive. This is going to only deal with the restrictive of getting air in. So you'll have restriction getting air in voluntarily through the inspiratory reserve volume. And for total lung capacity, overall, you're going to have a decrease in expiratory reserve volume because of the obstructive disease or lung disease that you may have, and a decrease in inspiratory reserve volume. Bam. That's something I have to go over like a billion times over during the review, but we'll talk about types of ventilations when I get back after I eat something, because nom. But first, here's head pats. Pet your lungs? I will try. Do I have to do like a... Is that ASMR? Is that me just really hitting my mic? It's like a... Anyway, I pet your lungs for you on the count of 3. 1, 2, 3. I pet your left lung. I pet your right lung. I pet the all lungs. I pet both lungs. Gabriella, thank you so very much for the follow. Welcome to the club. Would you pet with the inhale or the exhale? Why not both? Maybe it gets forced to inhale and exhale? Yeah. Let me put these away. Alright. Says please, I can't breathe this fast. Marshall, don't hyperventilate. That's going to increase your respiratory rate or volume without the increased metabolism. And you may have some examples of emotional hyperventilation because you might not feel like you're up to the par to inhale and exhale on par, or you might have it while blowing up a balloon. I go take a break. I was gonna air fry my or to reheat my chicken, but now I think I might just microwave it and hope I don't die. The height of hyperventilation? I'm sorry. It's okay though. Anyway, I'll be back. Get up, stand, stretch, life's good, and I might take a little bit longer, so it might be like a 10-minute break. I don't know, it'd be cute if I could watch stuff with you cubs, but I don't think I have anything cool on YouTube. Also, will I get in trouble? Question mark? And then people would be like, is this really a chatting stream? I'm like, no, I'm on break. If there was a new Simple Flips. Or we could watch walkies, but I'll like die choking. So I don't know about that. I don't know. I'll just take a little mini break though. BRB! I'll write a little note too. Take your time and enjoy your noms. I will try my best. Thank you. Alright. We could just watch Simply Flipping Kappa? We could. We could. Or maybe I'll just inhale my chicken really fast too. Who knows? Almost caught up with walkies? Let's go! It's so long. I'm so sorry. But did you get to the Luigi part, Robo? Did you get to it? Luigi ran away? Oh, it's so good. It was so good. I could watch it multiple times and still get like the same reaction, which is awful. Cause he's just so, yeah. Either way, I would love to watch walkies. No, I think I'll inhale my food. Luigi got mind game. Let's go! I'm 8 hours into the 9.5 video. You're almost done, then. I'm so proud. Honestly, I didn't think the walkies would be as funny as it was, but I'm glad that you two, especially, are super enjoying it. I'm glad to share my dad. Anyway, okay, I have to go because it's gonna take me 500 years to, like, I don't know, heat up my food and then be like, it's so hot. I have to wait for it to cool down. Woohoo, woohoo. Alright, be right back. Be right back. Be right back. Be right back.
かに響き渡る教会のチャイム、祈りを捧げ恐怖を裏切る。暗い森の中をさまよって暗絶の壁が残月になるの。透明な嵐に待ちなさい。甘い淡い蜂蜜でもっとベトベトにした。お願いいい子になるから私を承認して。クズに舞う絵本のページが影になって記憶を揺らすの。 私はここにいるから曖昧な未来であって何も怖くないよ差し出された手に触れて絡まった糸が優しくほどけた不条理な傷つって舐めてあげるから星の夜にねあの森で待ってるからあの場所で待ってるからあの場所で待ってるから空っぽな世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて花びらがゆっくりと二人を包むよ星の夜にねえねえねえかすかに響き渡る教会のチャイム祈りを捧げ恐怖を裏切る暗い森の中をさまよって暗絶の壁が酸欠になるの透明な嵐に待ちなさい甘い淡い蜂蜜でもっとベトベトにしたお願いいい子になるから私を承認して風に舞う絵本のページが影になって記憶を揺らすのずーっとあの場所で待ってるから空っぽな世界の中全てこぼれちゃっても鮮やかにもがきながら時間を歪ませながらも見つけて花びらがゆっくりと二人を包むよ星の夜にねえね迷い込んでしまった出口のない迷路ぼんやり口ずさむ同じ聖書秘密の呪文ちぎるようにオルゴールが静かに歌うの透明な嵐に待ちなずに弱く荒く噛んでもっとぐちゃぐちゃになったらお願いいい子になるから私を承認して絡め合って恍惚な時が重ね合ってあの日を照らすのずーっと私
Wow. Oh no. Even though I took that little mini lunch break, it's one of those things where my voice is gonna crack a lot, which I feel really bad about. Because I want it to be like nice and calming, but then you're gonna hear this because I just like vacuumed my food. Anyway, I am back. I am ready. I will try not to like cough up a lung or anything like that. and we will have a nice calming remainder of these studying hours that I have to do. Right now we're on page 3 out of 14, so that's not too bad. But what is bad is the Quizlet, because that's like 97 questions, so I'm like, yeah, it's quite. Yeah, I hope everyone got to stand up and stretch. I'm glad I got into like the little time range that I set myself up for, because I was so scared I reheat my food up too much. I'm like, oh, this is so hot. Not hot enough, still edible, so we're good. I did a little Doug break. I actually really like Doug's content. I started getting into it more recently because he makes really funny videos. I think he's the guy behind the whole like, hey, if I say this one word, I'm gonna try not to say this one word, don't make me say this one word, because if I say this one word, this bad thing will happen. Excuse me. And it's been like super what do you call it, funny, because it's so versatile. I think Smollett, I did it for like Minecraft and like Breath of the Wild, and he did it for like GTA 5 and other fun stuff, so I highly recommend it if you're looking for like a new content creator. He just recently put out this new video that I linked like a few minutes ago, so that's why I'm like, yeah, I guess I'll watch this. So that's funny. Anyway, so, oh no, hold on. Sorry, there's a piece of jello on my hand. Mama Bearcat had gave me snacks a long time ago, and I forgot she gave me jello. So I'm just like, oh, I'll just like have that as like a little dessert. It'll be so cute. Anyway, I'm sorry. Yeah, so respiratory system. So we talked about the different kind of capacities and the lung volumes, which will hopefully refresh back tomorrow or maybe in my own private time. Let's talk about the different type of ventilations though, okay? So we have how do you pronounce it? Eupina, hypernia, hyperventilation, hypoventilation, tachypnea, dyspnea, and apnea. So for European it's gonna be normal quiet breathing. There's really no examples. It's basically what you do day to day. This sounds like there's maybe something wrong, but this is just again a very fancy word for normal quiet breathing. We have hypernia, which is going to be increased respiratory rate and or volume in response to increased metabolism. So yes, your heart rate may increase, or your respiratory rate may increase, and it's going to be also in relation to an increased metabolism. And this is going to be really the example with exercise. Maybe you're working really hard, or maybe you're doing some cardio, you're getting a little more kind of thing, and with that kind of reaction, is hypernia is going to be the increase in respiratory rate and then metabolism. But hyperventilation, which is some term that you hear like more often than the previous one, that's going to be in relationship to the increased respiratory rate and or volume without increased metabolism. So this can be emotional hyperventilation, like if someone goes into like some type of panic or anxiety attack, or maybe they're just hyperventilating in general due to some other emotional response, or even blowing up a balloon. It's the you know, that kind of noise or example. We have hypoventilation, hyper meaning like above, hypo meaning below. So we have below ventilation, which is going to be the decreased, oh my gosh, alveolar ventilation, which is going to be very shallow breathing, maybe like asthma, or even in relationship to some restrictive lung disease. We have tachypnea, which is going to be kind of in relationship or have the same prefix as tachycardia, which is going to be like a rapid heart rate, but this one is going to be in relationship to rapid breathing. This is usually increased respiratory rate with decreased depth. So something like panting, like maybe you went up the stairs, so you're like, you know, very deep, trying to get all that air in, but because it's rapid, it's again that panting kind of example. Dyspnea is going to be difficulty breathing, a subjective feeling sometimes described as air hunger, and so there could be pretty much various pathologies, or even like very hard exercise can lead you to difficulty breathing. So not like, hey, you're working really hard on what do you call it, your cardio. It's, hey, this is a little bit worse, you're having difficulty getting that air in and out. And apnea is going to be the cessation of breathing, or the stopping of breathing. So this is voluntary breath holding, depression of CNS, which is our central nervous system control centers. So, excuse me. So many of you might have heard of sleep apnea. This is like the same thing. This is why it's important for those with sleep apnea to sleep with a specific kind of machine to ensure that they are breathing throughout the night. So now we could talk about local control of the arterioles and the bronchioles by oxygen and carbon dioxide. I think this is probably a better image. Let me see if we can get any image. Let's see. One moment. Let's see. Yeah. Alright, is this one okay? Sorry, I wish I had the images up and ready, but I didn't have any time, so I'm just like, I hate like learning without like looking at like what I'm learning about. So let's see. Is this okay? Arterioles and bronchioles? Maybe this is better. So I'm going to copy and paste two images. I hope you don't mind. So we have that one, and then we also have, I don't know if they're going to have like a I want like a total picture. I guess this is okay too. Alright, so local controls of basically our arteries that we have in our lungs and the bronchioles, which is going to be like the venous system, and this is by oxygen and carbon monoxide. So we have these like very bumpy things right here, and these are going to be a combination of our oh my goodness, I can't pronounce it, I'm so embarrassed. Our pulmonary system, the dice of embarrassment. Anyway, these are going to be at the end of pretty much our lungs. And this is again in relationship to the oxygen and carbon dioxide that we're getting in there. So for gas consumption, if for whatever reason we're getting an increase in CO2 or carbon dioxide, what's going to happen is that the bronchioles are going to dilate, or they're going to open and expand, while the pulmonary artery, which we can see right here, is going to constrict. Which means that the systemic arteries are going to dilate as well and open up. So the really cool thing about this chart is that there's a pattern here that we can see. So if the bronchioles dilate, it's going to dilate. The systemic arteries are also going to dilate. So dilate, dilate, constrict, 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 dilate, dilate. This also is a what do you call it? A pattern here as well. Let me see if I can change the color really quick to see if I can show you cups. So what we're going to notice is that there's going to be a pattern of the opposite. So yes, we just talked about carbon monoxide increasing and the bronchioles are going to dilate. So what's going to be the opposite action? If this increases, this must decrease then the oxygen that we have. So that's why it's going to do the same thing as well. Dilate, dilate, constrict, constrict, dilate, dilate. When CO2 decreases, oxygen is most likely going to increase. Well, we hope so, right? And so with that, this is why these are also going to have the same actions. The bronchioles are going to constrict, the pulmonary arteries are going to dilate, and the systemic arteries are going to constrict. So again, it's just repetition, knowing what is where, basically. So as CO2 increases, the bronchioles will dilate. As CO2 decreases, it's going to constrict, and pretty much knowing the table. So the regulation of ventilation. So contraction of the diaphragm and other muscles initiated by spontaneous firing in the brainstem. Rhythmic cycles of inspiration and expiration influenced by sensory input. So we have our chemoreceptors that are going to help with this rhythmic cycle of inspiration and expiration. So we have our carbon dioxide, our oxygen, and our hydrogen. Respiratory muscles in the medulla control the inspiratory and expiratory muscles that we were talking about earlier. Like remember our intercostals, the internal and external, as well as our diaphragm, the scalenes, and the sternocleidomastoid mastoid. So neurons in the pons, so this is a part of our brain, the medulla. Is it... Maybe it's best to grab a picture for this one too, because sometimes the brain hacks me up a little bit. And it's not because it's like, ooh, your brain seeing the brain. It's just like, oh wait, what part is what again? Huh? Tips? How much do I have to pay to get a peace cam? You don't have to pay anything at all. It's just peace doesn't stay still. But I could probably get a little camera set up. Again, like I told you earlier, I have her bed right next to my desk. So if I set that up, maybe we'll be good, okay? Huh? Hi, Goose. Your mama? Oh no. Your mama! Anyway, hi, welcome. But yeah, I don't know. I'll have to figure out like the camp setup and everything like that. I know Rip has like a bunny camp setup, but her bunnies are also like set into like this certain area that's fenced off. Peace is a free spirit. But yeah, we can figure it out. That's not an issue. Alright, so here we have the... Okay, I guess. Whatever. That's fine. So, the respiratory muscle in the medulla... Respiratory muscles in the medulla are respiratory muscles are controlled by the medulla, and the medulla we see is going to be this green feature right here. The pons here, though, in the blue, are going to integrate sensory information and interact with the medullary neuron to influence ventilation. So, hey, it might be something like, again, the exercise we were mentioning. And then rhythmic pattern or breathing is going to arise from the brainstem, so right down here. Yeah, she used that bunny cam one time on stream? No! No. She used it more than once. She used it at least 3 times. Yeah. Again, mine would be a little wacky just because, you know, I have a cat. Who basically she has 3 favorite spots. Oh my gosh, I love these. She either has her bed, she has my bed by the window, or she has like the window to like the little porch area. She's so cute. And I guess the 4th, she has like top of the mattress. But anyway, we'll see, I promise. But she's very cute. I'll send more pictures in the chat or something. Okay. So this is our brainstem. This is the medullary. To be honest, actually, Cubs, I know I said I was going to study it a long time. I am I see a few of my classmates studying for this current exam coming up, and so I think I'm just going to go over the kidney really quick, and we won't do the Quizlet together. Sorry. I'll do the Quizlet in my own time, and I'll try to like sneak it in during work. But anyway, excuse me. So Unit 13 is the renal system, because now we moved on from that. As I recall for my own self, the medulla is going to control the muscles. The pons is going to kind of talk with the medulla to make sure how we're ventilating. And the pattern of how we breathe is going to be from the brainstem. So for the renal system, anytime we refer to the renal, we're referring to the kidneys. The kidneys have so many crazy functions. It's actually kind of crazy to be like, it just doesn't do this. No, it does so many other stuff. So it's going to help regulate extracellular fluid volume and blood pressure. So what happens is that extracellular fluid will decrease blood pressure as well. If the pressure is too low, we can't maintain blood flow to vital organs such as our brain. So the kidney is very important. So make sure we don't have too much of a decrease in extracellular fluid. That's why the kidney is going to be responsible for regulating that, so that doesn't happen. It's going to regulate osmolarity, which is in relation to the water in our body. The kidney basically helps us become thirsty. Like, hey, you're a little dehydrated, my cub. You gotta drink some water. We also have ion balance, so you know our electrons, or yeah. So we have balanced dietary intake with urinary loss, and what is this in reference to? Major ion? What's Na? Heck. We have potassium and calcium. Oh, do they mean sodium? I wanna say they meant sodium, but they definitely did not abbreviate the typical chemistry way. Heck them. So yeah, sodium's a major ion, and potassium and calcium are also going to be regulated. Yeah, Ca for sure is going to be calcium. Na, I'm like, huh. Kidneys are gonna also help regulate your pH, so you know on the pH scale of like, hey, are you acid? Are you acid? Is this thing acidic? Is it basic? Or is it within normal pH? So what happens is that the kidney fails to regulate, and for whatever reason your pH becomes too acidic, the kidneys will remove hydrogen and conserve bicarbonate, and the bicarbonate will make it more alkaline, which is going to be like basic. But if it's too basic or too alkaline, the kidney will remove the bicarbonate and conserve hydrogen. So it's like a vice versa. If you hold your breath, your blood becomes more acidic. Okay, so if I hold my breath, my blood will... No, I'm just kidding. I'm thinking like regular acid, and that's too gruesome. So, let's see. Na is nitro, the German name for sodium. Let's go! I mean, I don't know if they meant that, but I'm 100% sure they mean like sodium. I hope. I'll definitely also look it over because these notes are from the study review session that's already pre-recorded. So instead of me watching the video again, being able to see this is like really nice. Anyway, it can also help excrete waste. The waste is going to be xenobiotics. It can also excrete metabolic waste such as creatine, which is for muscle metabolism. And then we have nitrogen waste, urea, and uric acid, which is going to be in our urine. And then the urobilinogen, sure, is going to help give our urine that yellow color. You know, it was crazy the other day. I can't like say anything too much, but they were saying that our blood is urine basically, and I was just like, what? But it's like, oh, it's what you excrete and something, and then the water, and then it goes to the bladder, and then I have to look at the TikTok again and see if it's true. But I was just like, whoa, that's so weird. But it was also in relationship to water and all that, so I'm just like, okay, whatever. Anyway, sorry, tangent. Anyway, so also the kidney's gonna help produce hormones. These the kidney will synthesize erythropoietin, basically red blood cell production. So it's gonna regulate red blood cell synthesis. This is also gonna release renin, the production of a hormone, and the... I really would have to ask about this NA balance, sodium balance, and it's gonna regulate the blood pressure. While it produces hormones, it's gonna also help convert D3 into a hormone that can regulate the calcium. So for our nephron, which is going to be really important in our kidney, it's going to help with filtration, reabsorption, and secretion. For filtration, this is going to help move the fluid from the blood into the lumen of the nephron. Heck this, we're getting a picture. Heck this. Maybe here? Na is is sodium on the periodic table? Okay, thank you. I'm just like not here today. I was talking about my dislike for chemistry earlier. Alright, did I grab the right picture though? I'm so sorry. Apparently I don't know what a kid or the nephron looks like. I just took a test on this too, which makes me even more embarrassed. Oh, is the nephron just the portion? Oh, heck. Yeah. So, this is a huge picture. But just to reiterate, it is actually just going to be the small section right here within the renal pyramids. And this is going to be the nephrons, and that's going to have all this for the filtered blood, unfiltered blood, collection duct. Oh, look, it is true! The TikTok was right! Look, unfiltered blood, filtered blood, and the filtered blood goes back, and the unfiltered is going to go through the tubercle, which is going to go to the urine, the collection duct, which is going to be where the urine exits. Yeah! Okay. Anyway, so filtration is going to move fluid from the blood into the lumen of the nephron, and it's going to help with the excretion or the removal of urine. It's going to help with reabsorption, which is going to be moving substances into the filtrate from the lumen and puts back into the blood. So we saw that with the other. I like the other picture better. sorry. I'm gonna keep it for my own reference. I think this was a nice picture. So we saw that here, especially because we saw the filtered blood going back. Ta-da! And then secretion selectively removes molecules from the blood into the lumen and adds to filtrate in the tubercles. And the tubercles being here. Big thumbs up. So when you see the word micturition, it's going to be another fancy medical word for urination. Apparently there's a side note we need to know about. So a sympathetic response is the detrusor muscle, which I'm not familiar, I guess somewhere in the bladder. Here will relax and sphincter will contract. So sympathetic again is going to be in relationship to our fight or flight, and the sympathetic is our rest and digest. So this will relax and the sphincter will contract. But in parasympathetic, when we're ready to relax, the detrusor muscle will contract and the sphincter will relax. So to sum up this muscle right here, when the muscle relaxes and the sphincter is going to contract, the pelvic floor will also contract when the bladder fills. Then it's going to first sensation to void. Heck this. Bam. Bladder half full, urination voluntary inhibited until appropriate time, normal desire to void, the muscles contract. Okay, when you're ready to rest and relax and you're not ready to fight for your life, you won't pee during your parasympathetic response and when you have a normal desire to void. For urination, the neck of the bladder is continuous with the urethra and the urine passes to reach external environment. Opening between bladder and the urethra closes two rings of muscles called sphincters. So, sorry, I should probably read this with more passion. So you have an internal sphincter and an external sphincter. So the internal sphincter is going to be that continuation of the bladder and the smooth muscle, while the external sphincter is going to be the skeletal muscle that's controlled by your somatic motor neurons. Somatic, again, having the prefix of like soma, it's just body motor neurons. 3. The stimulation from the central nervous system is going to have the contraction of the external sphincter, and that's going to allow us to urinate. Oh, we got the GI and reproductive system. Oh, please don't tell me there's... Hold on. Oh, okay. No genitalia. But is that a... No, that's a... no, I can't do it. It's a female nipple. I can't do it if it's a female nipple. Alright. So, who are the key players in the GI tract? So, our GI tract, again, GI is short for gastrointestinal, and that's basically what we digest. So, when we eat, like when I had my yummy lunch, it went down my esophagus because I had my salivary glands go on. I ate it, I chewed it up, went to my esophagus, which is going to go straight into my stomach, then my duodenum, which is going to be part of my small intestine, then through the jejunum and ileum, and then go through my big intestines, which are the colons right here, and ta-da! I will eventually get it out. So, what are the key players of the GI tract? It's going to be your esophagus, your stomach, which is going to be divided into multiple parts. You have your fundus, your body, your antrum, and your pylorus, which is going to be the gatekeeper right up here. You're going to have your small intestine, like we said, that's going to be the duodenum. Sorry, it's the very start of your small intestine right down here. Once it's done with your stomach, then your jejunum, and then your ileum. Then for the large intestine, we're going to have our ascending, transverse, and descending colon. We're going to have, again, all our colons, and then we're going to have our rectum right here. What are the accessory glandular organs of the GI system? So some accessory that we don't necessarily need but definitely do help is our salivary glands. Imagine if we didn't have saliva when chewing. Imagine how dry that Popeye's biscuit is without any like sort of liquid, you know? That's kind of the idea of why we need our salivary glands. We have our gallbladder, which is going to be right here in green. It's very crazy because even cadavers it's green too. We have our pancreas right here, And then we also have our liver, which is going to be right here as well. Liver's a big hacking thing. So what are these soupy mixtures of food and secretion known as? So that's going to be this vocab right now, and it's going to be chyme. So when we chew up things, and basically it's a mixture of our saliva and all the food that we ate and going through our system, we call that chyme. And what portion of the GI tract runs from the stomach to the anus? And I guess you can refer to this as your guts. So super, super easy, you know? What are the 4 layers of the GI tract? So we're going to have our mucosa, which is going to be the inner lining containing gults. Gults is going to be a gut-associated lymphoid tissue. We have the submucosa, which is going to be connective tissue with large blood and lymph vessels, and contains submucosal plexus, which is going to be part of the enteric nervous system. So we have mucosa, submucosa, so mucosa and submucosa being sub meaning below that. Then we have the muscularis externa, which is going to be the outer wall, hence the word externa, and that's going to consist primarily of 2 layers of smooth muscles. This is going to contain the myenteric plexus, which is going to be part of the enteric nervous system, which I believe we'll talk about in a little bit later. The enteric is actually known as your little brain. And then you have the serosa, which is going to be the outer covering connective tissue membrane. So these are going to be our layers of the GI tract, okay? So we have to know the varieties between the walls of the stomach and the walls of the intestine. So this is just going to be a picture. Definitely intestines are wiggly wiggly woo kind of fellows, where our stomach is kind of set and stuff. Let's see. Definitely different outer wall muscles, the muscularis interna, as you see oblique muscles, circular muscles, and longitudinal muscles, while we only see circular muscles and longitudinal muscles right here. We still have a mucosa, very thin layer. It all looks pretty wiggly wiggly woo to me. No, this is what the intestines especially, which makes sense because it wiggly wiggly woos food down to the rectum, you know? Yeah. So let's see. You have epithelium here, while you don't have epithelium here. I don't know, kind of weird. Anyway, so what's the role of the digestive system? Well, it's kind of self-explanatory, but it's to digest. It's to help move nutrients, water, and electrolytes from the external environment to the internal environment. And what process does the system require to accomplish this? So really, to help move nutrients, water, and electrolytes from the external to internal, we're going to need secretion, digestion, absorption, and motility. Motility is just another word for like mobility and having that move through our system. Professional medical talk, your wiggly wiggly woo did an oopsie. They call this like, they're calling this villa right now, which I guess that is the correct term. I will not bite a label. Your wiggly wiggly villa. I hope there's nothing. I hope it doesn't do an oopsie. I want my digestive system to be a-okay. So here's the process again, but in a picture. So we have our first one should be secretion, the movement of material from the cells into a lumen. Then we should have our digestion, which is going to be the chemical and mechanical breakdown of food into the absorbable units. So our food breaking down because of the chemicals in our body, maybe like the stomach acid and all that, and the mechanical, it moving down through our intestines. Whatever nutrients that we get from this food, like, oh, our protein, or hey, this is high in calcium, that's going to be absorbed through our GI, gastrointestinal lumen, to the extracellular fluid into our blood. And then we have the motility, which is going to be that all that movement throughout our GI system, and that might result in muscle contraction. It will result in muscle contraction to get that food moving down to the rectum. I'm so sorry. Alright, let me check something. Man, what part of the GI does the most absorption occur? And so this is going to be really important for a test. So we talked about the absorption right here. Again, all that material that we gain from whatever food we eat is going to go to the ECF, the extracellular fluid. So from there, the part of the GI tract that's going to do most of the absorption is going to be our small intestine. So basically, below the stomach, but not the colon. Because remember, our ascending, descending, and transverse colon is going to be our large colon. Gone. Hi. Welcome. Welcome. I think the correct term for anything having to do with the human body is it should do this. It should. And if it doesn't, that's an issue. I think it's funny how our bodies are made very similar. And we all have a similar purpose. If my GI tract doesn't work, at least I don't function. And if your GI tract doesn't work, you shouldn't function either. Wow, the human body sure is amazing. Anyway, welcome. It's been a while. Are you excited about the Dragon Ball Z collab with Fortnite? I want to play, but I have finals today and tomorrow, so I'm trying to study, as you can tell from my 6-hour stream. I've been here for 6 hours studying, but it's okay because it's gonna be worth it. I'm gonna stop crying. So, what are the two purposes of motility of the GI tract? So, like I said, move food from the mouth to the anus, and mechanical move food to break in uniformly into small particles. Sure. New streaming record? It is! I don't think I've streamed the song ever. Maybe I streamed like 6 hours, maybe once a very, very long time ago, but I can't actually think about it. I feel like 6 might have been my super max, or maybe 5. I definitely think I've done a 5-hour stream. 6 might be cutting it. In 5 minutes, we have a world record. Let's go! But it had to be something as lame as studying. Boo. The skins look jank? Oh no! I also saw you about female presenting nipple. I know, I can't show female presenting nipple. I'm gonna get banned. Imagine talking for 6 hours just to get banned at the very end because you didn't make this dummy study guide and you're like, oh, if I'm gonna show this on stream, I can't show it. A nip nop. Anyway, I'm so sorry. But still, you've been here for a bit, huh? Anyway, what type of muscle is responsible for facilitating this mobility? And that's gonna be the smooth muscle. So it's gonna smooth its way down and help you with the mobility. Or I think they really meant to write motility. So what are gonna be the two types of contraction that we're gonna have in the GI system? So we're gonna have a tonic and a phasic contraction. The tonic is going to be sustained for minutes to hours, while the phasic is going to contract and relax, like phasic coming into those phases, and it's going to have the slow wave potential, whatever the heck that means. You've been lurking? No problem. Thanks for coming on the look to say hi. I appreciate ya. So, what are the 3 patterns of contraction of GI smooth muscle? So, the 3 patterns of contraction of GI muscle is going to be migrating motor complex, prostalis, which is going to be a wake-like short distance, and it's going to be responsible for having the contraction with that forwarding movement. And we're going to have the segmental, which is a contract and relax sort of motion. Maybe they meant wave-like. I'm so sorry. I'm like, huh? Segmental, which is going to contract and relax, which is going to be responsible for mixing. Which contraction makes you feel like you're fighting for your life? Oh, let me see if I have the image. Well, what? I don't know. Will it show my things? No, it won't. Cool. I think I have it's a lane that I have a reaction folder. I reset my computer like many months ago to do something. I'm like, you know what I want to bring back? My reaction pick folder. I'm gonna find it. And when I do... I love that dumb meme, even though I don't number any of my memes. Unless I don't have it and it was just a figment of my imagination. Oh no. Oh no. Oh no. Did you have a messy computer? No. Okay, so you know what happened? Sorry. This calls for a anyway. What had happened is that I had like this M2 drive and I just didn't set it up appropriate basically. Are you referring to the picture of why do you call it a restroom when I'm fighting for my life? Yes! And I had, I think her name's Reimu from Idolmaster. I'm like, oh, this picture's so good, but I guess I didn't save it. I guess it's my imagination, my bad. Anyway. No, the female nipple! But I need to know the chart! Okay, Cubs. Oh, wait, you know what I could do actually? Hold on. Where am I? Hold on. I can just crop her. So easy. It's just a pimple? No, I can't get away with that. I don't trust Switch. I don't trust them. Oh, but I won't know what's happening. Oh, no, it does tell me. It's nice. So basically, I have to know what's being absorbed and what is being digested in each of the following. Stickers make it a bit more... I put a little band-aid over it. You know. Anyway, so for the oral cavity and esophagus, what's going to be secreted is the saliva. You know, again, we were just talking about the tree and how important saliva is. And it's going to digest carbohydrates, so any of our breads, or anything that's carbohydrates, really. In the oral cavity, you're not really absorbing anything, but your motility is going to be used for chewing and swallowing, so Your stomach, on the other hand, is going to secrete HCl or parietal cells, pepsogen, and gastric lipase, which is also going to be known as your chief cells, mucus and bicarbonates, which is going to be the surface mucosal cells, gastrin, which is our G cells, and histamine, which is our ECL cells. That's going to help with the digestion of proteins and fats, but it's very minimal fats, okay? And what that means is that, how do you call it? It doesn't do a lot. That is what minimal means in general, I guess. The absorption for this in particular is going to be the lipid soluble substances such as alcohol and aspirin. So it's that whole idea like, hey, you know, oh, that's fun and applicable, yes, whatever I said the second time, I was just trying to be cool and say it the third time. Applicable. Anyway, so you know when you drink, which you shouldn't, but in case you do, when you drink on an empty stomach, which you shouldn't do, the reason why that affects you so fast is because when you're on an empty stomach, your stomach doesn't have to worry about anything else to digest, and it's gonna easily absorb alcohol. So applicable, applicable, yay! If I said I had a speech problem when I was younger with you Cubs, they still accept me. Anyway, I'm gonna go into my sob story, okay? When I was young, I didn't talk. I didn't talk when I was young, and so that hecked me up. That hecked me up really bad, speaking in general. So make sure if you have young ones, or if you have young family members, make sure to talk to them so they don't end up like me. Hang in there, I'm trying. So I was about to say, wait, you can't drink water on an empty stomach? That water is gonna absorb so quick. No, I'm just kidding. You can definitely drink water and everything, but I'm sure you kind of upset your stomach with that. Or in my experience, I've upset my stomach by just only drinking water and being like, man, Tipa, you gotta eat. But no. Oh, hold on. Wait, you believe it's getting slightly dark in Bearcat Mountain? Oh no. Oh no. Sorry, my classmates sent the message and they're just like, hey, the professor's writing more into the document. I'm like, no, tell this man to stop. We might have to go over the document again just to see any changes. Man, I do feel like the water slops around too much if I just drink water. Exactly. Like, my grandma used to say, like, you have the little fishies in your belly. But yeah, so yeah, don't drink alcohol on an empty stomach because your stomach is really, really potent for absorbing alcohol and aspirin and all that kind. So basically, again, if you're on an empty stomach, that's why the effects hit a little bit more. Writing into the document hours before the test, they have the screenshot. My classmate responded with a stupid reaction gift with binoculars, and it's just the tongue going, ah. Oh my goodness. Why is he adding more? No! Anyway, the small intestine. So the small intestine, so we saw that again, it's going to be right below our stomach, or the inferior portion of it. It's going to secrete enzymes, mucus, hormones, CCK, secretion, GIP, and other endocrine cells. The enzymes enzymes and bicarbonate and bile are going to be secreted in the small intestine, and the small intestine is going to digest polypeptides, carbohydrates, fats, not minimal, and nucleic acids. Rip anyone that wanted to sleep before the test? Well, if it helps, the test is like in 2 hours, so if anyone's sleeping, good luck. I don't know about that one, Chief, basically. And anyway, for our large intestines, oh wait, I didn't finish. Small intestines are going to absorb amino acids, small peptides, monosaccharides, fatty acids, monoglycerides, cholesterol, nitrogen bases, water, ions, minerals, and vitamins. So look, guess what? Even though we have that sloshing feeling in our stomach, excuse me, it's the small intestines are going to absorb the water that we drink. I feel like burping again. Sorry, hold on. But the motility for the small intestines is going to be the mixing, propulsion, primarily by the segmentation, and maybe some peristalsis. So you know, in our, you know how to draw intestines. You don't need to know how to draw, but you have a vague idea of how it's like sectioned off a little bit like that. That segmentation is going to help prop it up to the next one, and then next one, and then the next one, and then the next one until it's out of your small intestines. For the large intestine, the only secretion is going to be mucus or goblet cells, and the large intestine is not going to digest everything except bacteria. The absorption, on the other hand, is going to absorb ions, minerals, vitamins, water, small organic molecules made by the gut bacteria. And the motility for this is the segmental mixing and the mass movement propulsion. We saw how big the intestines are, hence the name large intestine, and so we could see it kind of moving through that. It's all squiggly spaghetti? It is! It really is! Look at that, squiggly spaghetti. Wow. So, name 3 challenges the digestive system faces. So, it's to avoid autodigestion, whatever that means, mass balance maintenance, whatever that means, and the fence. So the mass balance maintenance is going to maintain homeostasis. The volume of fluid entering the GI tract by intake or secretion must equal the amount leaving the lumen. So what goes in must come out in equal portions. I guess. Aside from the central nervous system, what other neural systems aid in regulating GI function? So enteric nervous system, autodigestion means digesting itself? Are you telling me my intestines are gonna digest themselves? Is this what this is referring to? It's like the Sonic Heroes intro song? Like, where the heck is SG? Oh my goodness. SG, what does this mean? Oh, what goes up must come down. So cute. Oh my goodness. Anyway, look, so enteric nervous system, aka the little brain, is going to integrate short reflexes that are localized to the GI tract. Is that a hecking Sonic reference? It is. I need the Sonic guy to be here to be like, whoa, did someone say Sonic? This poor man might be working. Oh no! My classmates left. Oh heck. Heck. No! They're done studying, which doesn't matter because they were definitely just going over the same study guide we went over. But I will briefly look to see if there's been any changes or whatever into that, and then I can rest in pieces. Z. I can't rest. I have to yeah. Anyway. So, the CNS system also exhibits control over the GI system and can communicate with the ENS, which again is going to be our enteric nervous system, via the autonomic neurons. So this is going to occur via long reflexes or the cephalic reflexes. Am I good? Oh, I'm good. Sorry. Sometimes I just have to let it out by like screeching. I'm just not meant to, like, how to explain it? I'm mentally, I don't know where I am. Mentally, I know I'm studying and I'm doing the right thing by studying and all that jazz. But I'm a little stressed because it's this particular professor is a little unorganized. So even though he gives a study guide, none of that has to be on there, first of all. Second of all, I think I'm stressed because I'm borderline, like I have a borderline grade in this class and I just want to do well. Like I really just want to do okay. But I'm also done with the semester mentally and I just want to sleep in and, I don't know, love life. Ain't no rest for the wicked, but I'm not wicked. No resting, more revising? Revising? Yes, yes. Yes, honey, I have to revise and look at what he wrote and all that jazz and why the heck would he do that to us? You can say you're not doing No, I'm doing okay. Don't let the right eye twitch get you. Sorry, actually the tracking sometimes forgets that my right eye exists, so I'm so sorry if there's any like scuff with that. Oops, one moment. I fixed myself. Is it the same professor that just admits all organs? No. So this one's different. I have these classes that I've been talking about are like taught by 3 different professors and all that. The first one, he's nice. He's very sweet. It's just, it was kind of like, wait, why did I study all that? If you're gonna just test me on the leg, you hacker. Or is it the tracking? Oh, the right eye was... My right eye kind of goes out for whatever reason sometimes. Like sometimes you see me like smile and I'll just do that. So I feel bad. I promise my eye doesn't do that. But... Anyway, I'm sorry. Anyway. So yeah, so it occurs via long reflexes. So it's going to be this feed forward and emotional reflex. And the reason why it's long is because your head, in reference to that's what cephalic refers to, your head, it's pretty far away from your GI tract, right? That's why it needs to be these long reflexes. But the enteric nervous system is going to integrate short reflexes that are going to be localized to the GI tract, while the long, again, is going to go from the head to the GI tract. So, like, when you're hungry, or like when you smell something super yummy, or you're salivating, you're like, that sounds so good right now. That's what's happening. Also, your rest and digest, which we talked about earlier in relationship to your parasympathetic system, and your parasympathetic is going to control primarily via the vagus nerve, which makes sense because when we talked about cranial nerves the other day, we talked about the vagus nerve being the only one that goes and controls your motor innervation to your organs. You don't know me, Tippy. I might be built different. Oh, I'm sorry. You might be. He's just built different, you know? Anyway. So there's this chart about long reflexes, short reflexes. The cat is back. Let's go, Mac. Welcome back. I'm sorry, I'm still streaming after like 6 hours. I feel like you're here for the first hour, and I'm like, hi, and I'm like, I'm still here. Yeah. So this is just saying what's long and what's short. We know short, again, it's going to be in reference to the how do you call it? The enteric nervous system, while the longer ones are going to be from the cephalic phase or towards our head. See, the sight, the smell, etc. is going to like kind of be like, I'm hungry, you know? Or I smell something like warm bread, I'm like, I didn't eat anything, my stomach's rumbling. That is that long reflex. I'm on about the count on the top of your head. Oh, my cat? Yeah. I'm like, yes. Thank you. I'm like, huh? Alright, we're on 11 out of 15, let's go. So we want to know the gastrin, secretion, and motilin are the 3 families that aid in GI digestion. Thank you. Anyway, as with most systems, there are a degree of hormonal control as well. So this is our GI hormones divided into 3 families. We love peas around it, we do. Oh gosh, I wanna show you guys pictures, but it's very hard if it's just on my phone, you know. Let's see. There's a really cute one. I always send a picture of of peas to someone, whether it's like rib or new. So I have like a accumulation. Oh, Crown Force, thank you so very much for the follow. Welcome to the Cup Club. Welcome. yeah, I'll be sure to post them. I think I said that last time and then I completely alley-ooped. So I promise this time we'll get a few peace pictures. She's just so dumb. I'm like pointing the phone like you guys can see it. She's just so dumb. She's so cute. Anyway, back to studying. So the GI hormones are going to be divided into the 3 families that we see are going to aid in the GI or the gastrointestinal digestion. So we have gastrin, secretin, and motilin. And so I have to refer to my textbook, so I guess that's a later thing. But gastrin, sure, the stomach. Secretion, secreting. Motilin, motility. Alright, bam, easy. So what are going to be the 3 phases of digestion? So we have a cephalic phase, which is going to be mastication, which is the chewing, nom 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 nom, which is going to be the mechanical digestion because we're actively moving it like that. The salivary secretion, which is going to be chemical digestion because our saliva is chemicals. And the deglutition, which is going to be the swallowing, which is going to be under neural control. You have to be really careful because I think something about your nervous system or something like that, if you hit one of the nerves, I'm pretty sure like one of the cranial nerves especially, you may have difficulties with swallowing, and that's why people with these kind of disorders may end up at a high risk of choking because they're not able to swallow, which is scary to think about. As I swallow, hopefully not choking myself. During the cephalic phase, the anticipatory stimuli and the stimulus of food in the oral cavity activate neurons in which structure of the nervous system. What does this mean? So we have the medulla oblongata, which is going to be in our brain. Medulla is going to send efferent. Efferent is going to be relating to motor cells via the autonomic system to the salivary glands, so I guess to start the ball rolling, start producing saliva. And the medulla through the vagus nerve is going to go to the enteric nervous system to do those short reflexes that we're talking about. Huh? Is there more to this? Hold on one moment. No. Alright. So the gastric defense, GOLT, I think the GOLT is what we were referring to earlier with the mucosa layer, but we'll double check with that. So for the gastric defense, the gastric phase is going to start once the food enters the stomach. Anytime you see the word gastric or gastro, not like gastrocnemius, or gastrocnemius, gastric or gastro, that's going to relate to stomach. So once the food enters the stomach, we're entering the gastric phase, which is going to have 3 functions. The food is going to, gastric phase is going to do a storage function, digestion. This is where chyme is first made, and remember, chyme is that accumulation of the fluid and the saliva and the food that we chewed up, and it's in our body now. We also have defense here, and many other secretions will start occurring here. So again, we went from this cephalic phase, from the head, the chewing to the mouth, the gastric, so we're getting the food to the stomach, and now let's go into the intestines. The intestines phase is where most of the absorption is going to occur, and it's going to mostly occur into the small intestine. So the intestine phase is going to be slow control entry to small intestine because little chemical digestion has taken place. Additional secretions from liver, pancreas, and gallbladder. Small intestine is where most digestion occurs. Protein digestion stops when pepsin is inactivated at higher intestinal pH. Pancreatic and brush border enzymes finish digestion of peptides, carbs, fat, and smaller molecules. This is a lot. This is a lot. But basically, once it's into the intestines, little chemical digestion is going to be taking place, so it's going to be slow and controlled entry to get into there. We're going to have additional secretions from our other organs, and most of the digestion again is going to occur in the small intestine, where we're going to have this hormone of pepsin that's going to be inactivated at higher intestinal pH, and then we have all these cool things that are going to be into smaller molecules. The pancreas has endocrine and exocrine secretions. What are some examples? So endo meaning in, exo meaning out. So some pancreas, our pancreas, is some of the secretions we'll have for the endocrine system is going to be our insulin and glycogen, which is going to be very important when we talk about like our health and overall being and like diabetes and etc, etc. The exocrine is going to be enzymes such as entropeptidase, whatever that is, and bicarbonate, which we were talking about earlier, and the kidney, because remember it's going to help regulate that pH. I believe that is the section I was talking about, right? Gosh, I hope. So what does the liver secrete? That liver is going to be that big boy that we have right in the top, right above our stomach, and it's going to secrete bile, and this bile is going to be composed of bile salts, pigments, and acids, and this bile is actually going to aid and facilitate fat digestion. Any excess bile that we have is going to be stored into the gallbladder. So, okay, if most of the intestines, or most of the digestion is happening in the small intestine, what is the large intestine doing then? So, our small... Oh, heck. So the role of the large intestine is going to concentrate the waste and absorb the water. So the gastrointestinal system is going to have that immune system, it's going to have that gut, which again is going to be a part of our mucosa surface, and it's going to be dealing also with diarrhea and vomiting. So concentrate the waste and absorb the water. So what are some pathologies we can see with our GI tract? We talked all about it and how it works, so what's happening? So, for pathology, which condition causes outpouching of the GI wall and typically occurs in the colon? So that's going to be diverticulosis, because for whatever reason I could say that word but not whatever other word I was struggling with. What's a picture that isn't gross? None of them. Cool! So, what's going to happen with diverticulosis is that there's going to be this outward pouching, especially in the colon, which is going to be, again, referring to our large intestine. And these things are going to happen. Wow, they look so gross and they make my brain tingle. I understand it's 50-50 and some of it goes over my head. No worries. I'm also understanding it 50-50 if it helps. Alright, which condition is classified as inflammatory of the structure after obstruction and can result in ischemia, neurosis, and perforation of structures will result in pain in the lower right quadrant. So this is the appendicitis. Oh, am I allowed to show this photo? One moment. I could probably show this one. So we talked about this earlier. Oh, you're a huge photo, my dude. Alright, we talked about this earlier with the psoas sign, about the inflammation, about the appendix, of why they have to lay on their the side and test this out and yada yada. Yeah, so basically if you were having some pain in the lower right quadrant, it's most likely going to be in relation to your appendix, which is going to be inflamed due to some kind of obstruction. So please be careful with your health for any pain at the lower right quadrant. This condition is associated with erosion of the stomach or duodenum, which again is going to be the start of our small intestine. So what happens is that you might get holes in your stomach, which is actually horrifying to think about. See, this is a healthy stomach. This is a not so healthy stomach. Got holes in there, my dude. Be careful. The difference between diverticulosis and diverticulitis is that diverticulosis is normal and doesn't usually cause symptoms. Oh. Yeah, I was gonna say, I'm like, okay, if you have the itis, you're sick. That's it. But you may have some outward pouching that might be normal for the cysts. Thank you, Blue. I appreciate that. Huh? The holes make me go... Huh? The airs make me more aerodynamic? I'm a speedrunner? I must go fast? Huh? No, that's just in your body, though. Not on the outside. You won't be that aerodynamic if you have a whole skin covering it, you know? Gotta be super careful. I got this. Diverticulitis. Do you have a test in 2 hours? I do! I do. No, but seriously, I do have a test in 2 hours, so I should probably speed it up. Because my test is not about this. This is tomorrow's test, what I'm studying about, pathophysiology. But I need to look it over because I only had, I'll probably get home around 3, if not 4, so I'd only have like 2 hours to study. And I really didn't want that to be a situation. I want to make sure I'm able to look at it before anything, so even if I like don't know it, at least I have a vague idea. Excuse me. Next condition. This condition is associated with the lower esophageal sphincter becoming enlarged, allowing the stomach to pass through the diaphragm. Oh, that... Body, stop digesting. I get it. You're looking at the stomach and you're like, oh, I must digest, but still. Alright, so this is actually... I meant to go like bleh, just because of the stomach going into your diaphragm. That's so crazy. But if it does, that's gonna be in reference to your hernia. We could hear. I know, that's so embarrassing. Like you can hear me like drink water. So any noise that comes from like my body, I'm like so embarrassed. I'm like, stop. Be normal. Why can't you be normal? It's really not that big of a deal, but I'm still just like, it's dummy that my mic picks that up. I changed the setting to this so many times, and every time I do like noise suppression in a certain way, you just can't hear me if I speak like a certain tone or if I scream, so I'm just like, dumb. Anyway, so this is normal stomach, this is sliding hiatal hernia, and this is paraesophageal hiatal hernia. So as you see, these bumps are not supposed to be here. Stomach ASMR? No, that was not my stomach, just want to let you know. Anyway, so we have to review reproductive anatomy, so just making sure there's no dingo-dongers. Alright. I don't want to look at this picture. I don't. But this is the brain, by the way. Mongolian throat singing. I can. That's my secret talent. I can do this. I guess. And this is Mongolian throat singing. I don't know how I do that. I just a neat trick I got as a kid. Seeing stomachs remind me that a couple of months I had a What? Yeah, I'm glad you're okay. I'm glad you're okay. What the actual heck? How did you find that out? Did you just have pain and you're like, yep, time to go see a doctor? Holy heck. That's just a grudge noise? Oh, really? Nice. Voice reveal? No. So my voice reveal was the other day. So I actually sound like this, but when I plug in my nose, I actually sound like this. So I'm so sorry all this time I've been lying to you cubs about my real voice. It's really unfortunate. I just really wanted to sound like a cute anime girl, but sometimes I can't do it. I can't do it anymore. I'm really bad at like lying. Stay on topic. We got a speedrun. We too got a speedrun. Wait, Bagan, his life was in danger. Hold on. Oh no, I had a fever, got worse and worse, and apparently at some point it passed down and seized for a bit. Oh God, that's so scary. Not off topic, but there was a class yesterday I had to handle what happens if someone does have a seizure. What do you do, basically? And I was like, I've only experienced someone having a seizure in front of me once, and it was actually really horrifying, to be honest. I'm glad you're okay. But oh my gosh, it just happens out of nowhere, to be honest. And your stomach has been all sorts of messed up, so you might as well get it like you got like your 2-for-1. But hopefully, what do you call it? It was just all your stomach and nothing else. Bam. Anyway. yeah, so this is your brain, this is your pituitary gland and all that stuff, and cool hormones go through it, and we have to find out about like the sexual organs and the reproductive system. And there's certain things that go through, like the luteinizing hormone is going to be for females only, and the gonads are going to refer to the ovaries and testes. And this is going to be, what is it again? What is FFFHS? I don't remember. Stimulate follicle stimulating hormone. Yay! And that's gonna help with gamete production, whatever that is. I'm so sorry. I'm really bad with reproductive organs. For whatever reason, for my many years, I'm sorry, now this is me ranting. For my hecky many years of anatomy and physiology, all my professors wanted to skip out on reproductive organs. And of course, Bearcat Mountain, by the way, is a backwards place, just a heads up. And they never taught me anything about like the reproductive system or anything like that. So now that I feel like I was in like undergrad and graduate level, I'm like, oh, finally, I'm gonna learn what this is formally and not through like some guy online post. That's a story. I'm so sorry. Anyway, sorry, slightly on topic. Basically, I was hoping they'll teach me, but no, they don't really teach you. They just like vaguely go through it. The guy online posting was my first time being experienced or exposed to male genitalia because there's some bot or guy spamming or trying to get banned. And I was like, is that what that looks like? And then I was ruined as a middle schooler. Anyway, so yeah, it just doesn't get better. Even in grad school, they don't really teach you anything of it. No, Matt, don't worry. My original voice is whatever voice you want to believe. My Billy Rubin was the only thing that came up weird on my blood test. Some guy online is the most informative thing you could have. Yeah, but why did it have to write a smiley face? It's like scarred into my head, which is the worst part. Anyway, you guys didn't go over it whatsoever. I think in 5th grade we had like a sex ed course, but it was very vague because it was for elementary kids. So I don't know. America's really bad with like anything, and Bearcat Mountain, as much as I love my home mountain, the people in there are kind of Huh? There's an urban myth that you need to put something in the mouth if someone's having a seizure or someone. Wait, no. Never put anything to someone's mouth when they're having a seizure. What you're supposed to be doing is that if they're sitting, you lay them on the ground, make sure they have good airway clearance, and maybe place like a blanket over them because they may have like urinary incontinence or something. But if you put something in their mouth, they may choke, so don't do it. Huh? I'm really confused. Oh, I'm sorry. We're talking about the reproductive system now. That's where we're on. Sorry, Matt. Education systems all over the place. It is. I was banned from Matt. I can't. I'm like, Matt, how did you get banned? And I'm like, hold on. Alright, so in males, they have the luteinizing hormone, which is going to stimulate interstellar cells to release testosterone, and the follicle stimulating hormone, which is going to stimulate serotonin cells to produce that. Females, be mindful what happens in the chart. What do you mean? Why is this so vague? Why do I have to go look at a chart and be like, hey gals, remember how this is like summarized for males by 2? Yeah, you have a whole hecking chart, you female. I'm not gonna read this now. The ovarian cycle? What? I'm not reading this now. This is not my test today. I could say the advice you gave about seizures is 100% correct. Exactly. Hi, Riz. Hey, welcome. Yeah, don't hold them down. Don't give CPR. Hope that it passes. Grab medical attention. Don't. No. The female chart. Now, holding us accountable per uterine flag. What is that? Okay. Additional points for the review for pathology and manifestations of benign prostate hyperplasia, prostatitis, testicular cancer, ovarian cancer, endometriosis, ectopic. I'm so sorry. I feel like I see the word and I can pronounce it, but my brain is not saying it right. Ectopic pregnancies and uterine fibroids. Okay, and the final exam is gonna be 56 questions. Yay! With 8 of them being the reproductive system. Yay! Alright, good thing we put all our focus on the renal system. Let's figure out what the heck my professor added. Short answer, basically, I said exactly what the female reproductive system is for and what the male is for, and basically explained the whole year of education when it came to male or female sex ed in 15 minutes, because I was in a class of all females and the teacher used me as an example and I was sick of it. That's kind of gross. I'm not gonna lie to you. That's kind of gross to be like, yeah, this is the only male. And it's like, huh? Sir? Anyway. Sneaking in some extra stuff in the document 2 hours of the test is just, yeah! That's how I'm feeling. I'm feeling shook. Everyone's pretty upset. We still have to do like course evaluations for our professors, so everyone's not happy. Okay, so hold on one moment. Is this man still here? No, we're all animals. Okay, let's see what he put in. So this was our original study guide. And so that's why I reformatted it the way I did, because I don't like reading this. And I was just like, hey guys, look what I wrote. But of course he didn't read through this because this is on the later half. Oh, but my friend, my classmate, definitely put extra things here, so I will definitely check that out in a little bit. Let me just see what he was. Like, for instance, one of the sentences came out. I'm so sorry, Matt. Go fight your professor. Today is a fight professors or teachers kind of day. I think that's a little weird and gross to put people on the spot like that. Like, obviously, yes, I know you're trying to explain this simple concept, but you don't have to isolate one person regardless of gender to explain that point. It's a little hecked up. By the way, the CDC says for generalized tonic-clonic, the grand mal seizures, you should time the seizure and call 911 if it lasts for 5 minutes. Yeah, I'm not gonna lie to you. Any seizure I see, I'm calling medical services. I'm calling 911. I'm being like, they're on the floor. I've covered them up. Their airway's cleared. There's nothing in their mouth. Help. Anyway, sorry. I'm gonna skim through this. That doesn't look new. Why is this highlighted in pink? Oh, it's because someone's here. The ambulance took an hour to get to your house, so good thing I was okay. I'm sorry. Oh my gosh. The patient, okay, so this is new. So the patient has pain in their posterior buttocks. List of structures that you would palpate. So we talked about this earlier with the butt onion. So the glute max, mid, mean, piriformis. So he wrote, eventually you will learn that pain in the posterior buttocks can be referred from the lumbar spinal sacral regions. Remember dermatones? Yes, I guess I do remember that. What dermatome did we say was the butt though? None, because, well, I hate it here. Hold on. Dermatomes, and we can find an image really quick. The good side is I didn't have to go to science course. Yeah, I think my science course was very interesting in the fact that, how do you call it? Well, not sex ed. Yeah, I think I only had it in 5th grade. Imagine teaching a 5th grader that, holy heck. Alright, for buttocks, it's gonna be like S1, S2. Okay, cool. I think there was like a human sexuality course or something like that in my senior year, because in your senior year, after you take in like biology, chemistry, and some other science, for your 4th year you get to decide on what science you want to do. So there was like marine biology, anatomy, the other course, actually wait, I don't think that was it. I don't think in high school, never mind, I'm sorry. In undergrad there was a class like that that counted as a biology a course. Of course, I didn't take it because that wasn't necessary for my degree, but I knew a classmate. I knew a friend who did it, and he was like, it was rad. And I'm like, I hate you. I hate this. Are you gonna end the stream to study for the test? Oh, I am studying for the test. I'm sorry. If it doesn't look like it, I'm just going down memory lane. So, this is the newest information we put about the sacral regions and knowing about the dermatones. I hope he's not saying, hey, know the dermatones, because I'm going to kick his booty. Because that's definitely something he just listed 2 hours before the exam. I'm gonna kick his, oh my god, oh my goodness, oh my goodness, oh my goodness. These are all correct, so he put more corrects in there. Other than that, it doesn't... The answers that I did not write a comment or correct is because the information just needed to be cut and pasted from the online content or copied from your book. Huh? It's if you're allowed one true curse word. Get it out of your system. Fuck. What the? What is this? Anyway, I'm sorry. I'm screaming and I probably don't have my limiters and everyone's here for a nice like calm experience and I am here just for fun. I'm here to meme around. After 6 hours and 39 minutes, I met my breaking point. Huh? I keep mishearing dermatones for germatones. Ah yes, the dermatones clips. That's fine. I feel bad for anyone who has like the clip gotcha and they're just gonna hear. Anyway, thank you, Gon. I appreciate. Yeah. All right, I'm gonna look at what my classmate put. I'm here struggling with my fellow anonymous dragons, elephants, penguin, and all that. Anyway, I was looking, studying Japanese. Hi Astra, hi. I'm sorry if you heard me scream. I apologize. I'm now speaking in a room friendly. My inside voice. Oh, okay. Oh, you did hear that. I'm sorry. Is there no way to see the document to see what's added? Let me double check something really quick then. Hold on. Tipa's still going strong? I am! I don't know if I'm going strong. But I am going. I honestly didn't expect you to drop the F-bomb. I thought you were gonna say the other sentence for kicking his booty. No, I'm sorry. So there's a total of 15 edits from him. No, but this was referencing yesterday. I don't know. I'm sorry. This is how do you call it? Joking around stress? I'm not actually stressed in a sense of like, oh my god, this is how I'm really feeling or anything like that. If that helps, I'm so sorry. Sorry to cause any panic, worry, or confusion. I am pretty okay. This is just for fun. Alright, someone color-coded my notes, and I can appreciate that. So, I guess I'm gonna look at the new content. We'll go over again very briefly of the new content that my classmate had put down, and then life will be good. So this is a documenting range of motion and the normal values and measuring range of motion. So I was here for this. I was here. That's not any of my reflections though. So anyway, so this is talking about the latest stuff we had to do for our latest AA practical. So we needed to learn about the knee flexion and extension and knowing the normal range of motion. So I don't think we really talked about this, but let's go through it really briefly. Excuse me. I'm not going to go over where we're going to put the fulcrum because that's going to be something that I will just do during the test. That's not too bad. Range of motion kind of stinky though. So for knee flexion, again, this is if the patient was laying supine, laying on their back and their knee is bent. That's going to be a 0 to 135 is going to be the normal knee flexion, while for knee extension, it's going to be 0 degrees. Sometimes the patient's knee can go negative, which sounds really weird, like bending backwards, and this is, or like bending, flexing the opposite way, which sounds weird, but it's true. Have you heard of people who are like very flexible or hyperextending? Some people's knees hyperextend by a few degrees, and so yeah, that's sometimes why we have to go, okay, the normal range of motion, let's say if we had recorded the extension and the flexion, you would say, hey, they have 3 degrees of hyperextension to 135 degrees of knee flexion. So it'd be like 3, 0, 135. It's a weird kind of documentation system, but it is what it is. Knee inversion and eversion and inversion. Again, this is the sole of the foot going in and out. And this is going to be 0 to 15 for eversion and 0 to 35 for inversion. Remember, when you're putting the sole of your foot out to the side, right? Not to the midline of the body, the out of the side. It's a little difficult of a motion to do, and that's normal. The normal range for that's going to be about 15 degrees. Inversion is much easier to do. It's much easier to curl your foot in the sole of the foot, so that's going to be 35 degrees. So remember, our 35 plus 15, that's going to be 50 degrees. And the other 50%, you do your best. Alright, for dorsiflexion and plantar flexion, dorsi again is the toes pointing up towards you, and that's going to be about 20 degrees of flexion, while plantar flexion is actually a whopping 50. So that's crazy. Plantar flexion again is like on your tippy toes. Think about like the ballerinas and whatnot. We have subtalar inversion and eversion similar to our ankle, but this one's a little more discreet. Subtalar is going to refer to sub, so below, the talus, or the talar. Well, talus is the bone in our foot, and that is what it's referring to. These don't really have a normal range of motion. This is going to be more of a ratio. So let's say someone were to measure your subtalar inversion, and let's say you get like, I don't know, 5, then the ratio is going to be 2 to 1. You should have more inversion than eversion. So if your inversion, which is going to be the bigger number of 2, is a 5, then your eversion should be like a 2.5 degree. But yeah, great toe flexion and extensions, crazy, because we have to bend the toe forward and back. Did you know you have bringing your toe back, apparently you have 70 degrees worth of flexion? Or extension, which I think is absolutely crazy, because I'm like, I do that to myself and I'm just like, ooh, that's not possible. I don't have 70 degrees. What flexible people are you putting your toes back for? Well, the great toe flexion is going to be bending the knees 30 degrees. When I refer to great toe, by the way, this is referring to your big toe, the great toe, your first toe, the first metatarsal. I don't understand what you're saying. I'm sorry. This is normal range of motion when we do the goni stuff. For that ruler tool that I brought up, who's editing the document? Where am I? Hold on. I don't want to explore. I want to be happy. Let's see. At least I was done with that at least. So the bones of the foot is just something we have to know as well. So remember the talus or the subtalar in movement I was talking about. This is it right here. We have your calcaneus right here. Your navicular is going to be this wide bone right here, with the cuboid being more of this like cuboid. No, you're not dumb. You just have needs more particular than others. You are fine. Do not worry. I am explaining this as if you were my classmates, unfortunately, because I'm on speedrun mode. I'm so sorry. Normally I'm like, oh, look at your bones. Hey, look, this is your right foot. Like, normally I would take my time, but now that I know it is almost 6 o'clock, I am speedrunning. Hold on. Do people with a bigger range of motion get less hurt with these movements as well? Or do these tendons hurt as well? That depends. I feel like if you have a bigger range of motion, that's definitely going to help you out in the long run, and you're going to be able to do certain motions that wouldn't be so limiting. I feel like it really depends on the person, unfortunately, but having within range of motion wouldn't be too bad. If you have excess or you're like hyper flexible or whatnot, you're still going to be prone for injury because you're going beyond your means and all that, but blah 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 blah. But yeah, these feet pics looking a little bit different than usual. I know, we got it down to the bone. But yeah, so we have our cuneiforms right here, which is going to be above the navicular. So we're going to have our medial cuneiform. our intermediate cuneiform, inter being in between, and then we have our lateral cuneiform, which is going to be right here. Do I have a hyperextension? I can rotate my feet all the way backwards, or is that flexibility or double jointed? Could be both. Could be. When you say rotate, I don't... are you referring to like dorsiflexion? Because then... Having a bigger range of motion with stuff like EDS really just means that you'll just end up having a lot of joint pain and dislocations. I got EDS, Pog! Cups! Oh my goodness. I thought this was rare. Is it not rare? EDS is rare! Don't tell me. Do both Disco, do you and Gon have EDS? It's less rare than you think? Apparently. Hi. Oh my gosh. Okay, sorry. Yeah, so these are that's like basically your foot. Now we're gonna get to your toesies, okay? From your toesies, we're gonna have the metatarsals, which is gonna be right here. Then from the metatarsals, we're gonna have your phalanges. So basically think of these are going to be your toes now. Your phalanges are going to be divided as so. We're going to have our proximal, because proximal is going to be closer to your body. The middle and distal, distal being the furthest away from your body. And what's going to happen here is that if you notice, the first metatarsal is not going to have a middle. It's only going to have a distal or proximal phalange, no middle. Because think of like your big toe. Alright, moving on. One moment. Sorry about that. So that's your foot bones. They get slight dislocations pretty often. Oh, that's so horrifying. They're doing exercises now that have stronger muscles to help with that, like the shoulders. Oh yes, the shoulders are especially important. Man, this guy just copy and pasted my study guide, which don't get me wrong. Thanks, Alex, if you're hearing this. But this is just my study guide. No, that's a ding dong. I can't delete the ding dong because it's not my study guide. My toesies? I didn't know we're talking about cells again. My toesies. I like that one. Anyway, yeah, your footsies. But now we're not talking about the footsies anymore. We're talking about the valgus and varus forces on the thing. No. My classmates are hecking up. Sorry, they are sending messages and they're like, yeah, there's gonna be 3 written response questions, right? And my classmate's like, shut the heck up. No way. It's like, haha, JK. And everyone's just so mad. Everyone's really on high stress for this exam. I feel bad. And I also feel bad. But it's okay. We're gonna get through this. Together. Rainbow emoji. They won't be able to hear me, but my words are going out for them. Anyway, so the valgus and varus force implications about the ACL, MCL, and LCL. So, I don't know if it's actually here. Yeah. Whoever's writing this, good luck, my friends. So, we don't really need to know about the coxa valga or varus anyway, but we can briefly do that. I would be stressed too if my professor did that. I would not be surprised if there was written portions, but he's never put a written portion, so it's kind of like, ah. So coxa valga is going to refer to this. So when the hip is in less than 125 degrees, or wait, is it? Can I not read? Oh, greater than 125 degrees. I'm so sorry. And then we can remember that valga has more letters than varus, so valga is going to be greater in the angle of inclination. The angle is going to refer to this. You see the red line on top, and then we have the right line here, and that's going to be coxa vara, where it's going to be less than 125 degrees. And this is how your hip's going to look. The issue is just, if your hip is like this, your knees are going to be affected as well. So let's talk about coxa vara a little bit, because I think that's a little bit more fun. Coxa vara, as you see, it's going to be less than 125 degrees, and then you're going to end up with these knock knees. So you know the uwu anime girls, or are my knees like this right now? Yeah, my knees are knock knee. Let me not lie to you cubs right now. For whatever reason, my knees are knocked. I have coxa vara. What the heck? But if I didn't have coxa vara and I wasn't necessarily normal either, I how do you call it? I would have coxavalga, and with that, because the angle of inclination is going to be greater than 125, we're going to end up with legs that are bow-leggedness. So instead of the knees knocking in at an angle, they're going to actually curl a little bit out, which is a little bit crazy. I wonder if the professor could have even just delayed the test if he was going to add things last minute. I quite. Those are some serious knock knees. I promise they're not normally like this. I think it's the tracking. Is this the same thing as being pigeon-toed? Pigeon-toe refers to the feet going out, right? No, they're going in. So yeah, it would be knock knees. Yeah. Sorry, when I think of any kind of bird toe, I think of like penguins and they're waddling outwards like that. So yeah. So you don't want them to be straight up vertical. No, this is not normal. This is greater than 125, which is why you're gonna have this bow-leggedness. Let me show you a picture really quick of bow-leggedness and all that jazz. Bow-legged. Is this a good picture? Man, I'm definitely messing up someone's study guide. Hey, whoever's here, sorry. Alright, so this is normal, right? This is bow-leggedness right here. You see how it kind of goes outwards? And knock knees, I'm so sorry. They're not really showing the feet in, but this is what it would be normally. So knock knees, bow leg. Knock knees, bow leg. Thumbs up. The Thomas test, we talked about this a little already. No. My ex-friend had that. I will now pass out. Rip, no, don't pass out. Just go to sleep. Please have a good one though. Thank you for stopping by. I appreciate you. Thank you for being here as well. I'm so sorry. I've just been studying for almost 7 hours. I'm sorry we couldn't play more Dragon Ball, but I promise on Friday we play all the Dragon Ball. But good night and the sweetest of dreams and all that good stuff and yada 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 yada. No. Make sure to not have X legs. I will hang in there. But good night, sweet dreams. Kiss the hammy. Pathology. If the hip appears flexed and the knee extended at climbs neutral. I should read that. So this is some pathologies that someone had wrote up. So if the hip appears flexed and the knee extended at declines neutral, it's indicative of shortness of the rectum or the iliopsoas and the vastus in the knee. Okay. So if the hip appears to be flexed and the knee extended at the neutral, if the hip appears to be flexed without an extended knee, it could be iliopsoas or short. A passive extension of the knee. This is all Thomas test, which I do not want to necessarily look at because it's not that I don't think he's gonna test us. Oh my gosh, that he's gonna test us on that or anything, but I think he's gonna test us on this. Oh my gosh. So mild tones, we already talked about that. We talked about L1, L2, and these are going to be the mild tones of L1, L2 is going to do hip flexion, L3 knee extension, ankle dorsiflexion at L4, L5 is the hallux extension or ankle eversion plantar flexion is S1, and knee flexion S2. We talked about TP tendon reflexes. We didn't talk about that. This is just anatomy and palpations. Alright. Do I really want to go over this again? It's 6 o'clock. If I can go over it in like 15 minutes, we're good. Let's go! So during the first repetition of Goni measurements, what's the purpose of determining end field? So we talked about the quality and quantity and how the quality we're going to assess for either soft, firm, or hard, or even empty, but empty is not something that we had talked about previously. For soft, the issue with the quality as well is that we need to make sure that this is a normal end field. It's one of those things where, hey, well, we have elbow flexion, which I said was soft. If magically it became like a hard end field, that would be something abnormal and something that we'll have to look at about. I think I actually might jump to my study guide. Sorry, I think it's prettier. And also is to make sure that you're moving the joint normally and that they're actively able to move the joint, because it's important when you're assessing active range of motion. Active range of motion refers to, hey, can they do this motion on their own will? And if they're able to do it, can they do it against gravity? Yes, no, maybe so. Alright, what are the characteristics of normal active range of motion? So passively, we should be able to get a better measurement range of motion. So absolutely no worries. Let's see. Less than passive range. Quality and quantity of the motion, so we have to see if there's any deviations. And pretty much we're going to be assessing the I've been watching a lot of Pickle Rick lately. We're gonna be assessing the the muscles and the contractions, the ability to perform the activity, and the willingness to perform. So why do we want to check it? It's because we want to check active range of motion first, because if we assess the end field, we don't really give the patient time to adjust, modify, or even potentially aggravate it. We're gonna be sussy? I hope not. Let's see. In normal range of motion, it allows the therapist to measure the distance and direction of movement around a specific joint or body part. While the normal range of motion varies among different joints in the body, and level of flexibility typically plays an important role in the extended movement around them. Cool. These are our cool actions that we're going to do. Remember, glute max does hip ER and hip extension, while the glute minimus is going to do IR, which is internal rotation, and hip abduction, which is, taking the foot away from the midline. Everything else is pretty self-explanatory, especially the nerves with like nerve 2 obturator internus and da-da-da-da-da-da. Sorry, speed running. Knowing the difference between lumbar flexion and thoracolumbar flexion, knowing that, hey, this is the difference, that you're measuring both spines while you're measuring one spine here and going 15 centimeters up from S2, while this is from C7 to T1 to S2. Bam, easy. What is the purpose for providing stabilization? Is to avoid compensation. How we do hip IR ER? The same, just turn your leg the different way. Have them do the actual motion. The normal range of motion is going to be 45. Bam, easy. Erector spinae and quadratus lumborum, difference in the muscle. Remember, this is going to be two different muscles that are located two different places. That the erector spinae is going to be more medial, and the quadratus lumborum is going to be more lateral. And the actions are different. So for the erector spinae, this is going to be important when extending your back. So when we go back and extend, we can place the finger where we believe the muscle is and feel that contraction. While the quadratus lumborum, we're going to do the same thing but more lateral, and have them do a hip pikey motion to palpate. Alright. Oh, someone added to this. The patient stands and walks with the lumbar spine in a more forward flexed position. What structures of the posterior aspect could be stretched? They said just lumbar flexion is posterior pelvic tilt. You need to be in a lumbar flexion. Just lumbar flexion is posterior pelvic tilt. You need to be in lumbar flexion and back extension for anterior pelvic tilt. Huh? Wait! So I need back extension with this? So lumbar flexion is just posterior pelvic tilt. But why is it posterior? Huh? I'm getting someone to explain me pelvic tilts before this. I'm gonna kick their booties. What the heck? I said I was still lost most of the stream, but the stuff recovering now is pretty important. Working out, so I finally understand. I'm sorry, this is the more applicable stuff, while the other stuff is like, yeah, I guess pathophysiology is cool. Don't have these diseases. Oh my goodness. But someone did format this. Someone did go back and fix this. So maybe I'm still in the right mindset. So think of the cross analogy, because I definitely did not write that. So let's understand this again really quick. So a patient stands and walks with a lumbar spine and a more forward flex. So if they're more flex, what's going to happen? The person says they're posterior pelvic tilt. Is it because they're flex? I'm gonna get these questions wrong. So okay, if they're flexed. What did this hacking guy say about it? He didn't say anything. He said correct on everything else. I hate it here. I'm going back. If they're forward flex position, they're going to be posteriorly pelvic tilting, but why? And they're saying that these are stretched, but they're also saying the erector spinae muscles are stretched, so maybe this is incorrect. What I'm confused about is that the original answer no, don't worry. I will end after this really quick, and we can what do you call it? I'll just reach out to a classmate, be like, yo, can you explain these tilts to me? Because I got two different information here, and I was under the impression this whole time that it was this. I did not study for 7 hours for you to tell me this is different now. So if they're working in a forward flex position, here, actually let me message them now. I need someone to explain posterior pelvic tilts to me in like 20 minutes. Because I thought I knew. Now I went the guide again and saw someone had changed the answer. Oh my goodness. Let me wrap this up. Oh boy, can't wait to learn. 30 minutes before the thing. Anyway, I'm gonna skip all the things. I'm gonna skip all the pelvic stuff until my classmate explains it to me. So this one was really easy to understand. So the patient complains of lateral hip pain. On standing, you know the patient stands with the hip more adducted, so their foot is more towards the midline or the hip. And what muscles could be weak that could be contributing to this position, and how would you strengthen? How would you strengthen it? So we know that the adductors are strong, and so the abductors must be weak because it's so strong that you're pulling the muscle into that direction. Hence the hip adduction we see the patient in. So the hip abductors are weak. And this makes sense as the abductor muscles are going to be our lateral muscles. So this is probably also why this person has experienced lateral hip pain. So we're going to try to lengthen the muscles that are weakened. And from that we can do MLTs, the muscle length testings, on the glute medius and the TFL. And we're going to just put them into its different action and help stretch them. What are possible compensations that would be observed during manual muscle testing with weak gluteal muscles? And what is the psoas sign? So pretty much just see for any arching or lifting off, and their hamstrings may also be used to try to extend the back. Oh, my classmate was so nice. He's like, that was us, I got you. You weren't wrong, the question was just weirdly worded. Let's go, I think I might understand it then. Anyway, yeah, so watch out for any compensations, and psoas sign is going to basically be an indication of an inflamed appendix. Let's go! I'm not wrong! Not because I have to have this complex of being right, but I would like to be right before the exam. These questions that I had, these 5 questions I have about this, I would like to get right. You say winning? Hashtag winning! Let's go! Anyway. Sorry. Yeah, so touch the butt. If the butt's in pain, what will you palpate? Butt muscles. Ober's test, really cool stuff. If their knee hurts, extend the leg. Straight leg raise? Yep, got that. This, got that. What is the effect on the hamstrings if the patient has excessive anterior pelvic tilt? Oh god. It's okay, Tippy. I do have a complex about being right. Why did I read it like that? That's okay too. It's good to have proper knowledge and appropriate stuff and all that good stuff. So, okay, let's think about this again. If this person has excessive anterior pelvic tilting, what's going to happen is that their ASIS is going to move more forward. So if it moves more forward, the anterior muscles should be tight. So the back muscles, such as the hamstrings, should be lengthened, right? Yes! Alright, and then sure, if there's a posterior. Okay, we still got it in us, baby. Alright, how does the ACL resist motion? Remember, we're gonna only work on the tibia to make it make sense. So the ACL is the anterior cruciate ligament that we see right here. ACL is going to be our two fists on top. The top is going to be the femur. The bottom is going to be the tibia. And so right here, what's going to happen is that the ACL is going to restrict anterior translation of the tibia on the femur. While the PCL, the posterior cruciate ligament, is going to resist posterior translation of the tibia on the femur. The tibia? The what? One moment, I'm dying. Dies. So let's focus on the ACL again. ACL restricts anterior translation of the tibia on the femur, tibia being the bottom on the top. And then it's going to do the opposite. It's going to restrict posterior translation of the femur on the tibia. But it's not really opposite, it's more complementary. Because again, if you do that motion again, it will make sense. Well, the posterior is going to resist posterior translation and anterior translation of the femur on the tibia. Yeah. How does the patella contribute to proper motion of the knee? It's going to help take steps, and it's going to extend the lever arm of the quadriceps to produce more force. Let's see. What are the ligaments of the lateral aspect of the foot? We can see the picture right here. We have the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. We related this again to 3, 6, and 9 as our clocks. We could talk about the sprains. Hello? And yeah. What is going to be our most injured one? It's going to be the anterior talofibular ligament. It isn't until grade 3 where all of them plus the posterior is involved. Alright? What are the ligaments of the medial ankle? Deltoid ligament. What are the deltoid ligaments? Tibionavicular, tibiocalcaneal, posterior tibial talar, and anterior tibial talar. What is the most injured ligament in the foot? ATFL. Pes anterinus, we got this. Gradient tubercle, we got it. How do hamstrings restrict tibial motion? Alright. Restricts anterior translation. If ACL is damaged, the hamstrings can compensate. Inversely, if the PCL is damaged, the quadriceps can compensate. So basically the opposite motion can compensate. So if again ACL is going to prevent that anterior translation of the tibia, right? Of the tibia going forward, right? Oh my goodness, how did I forget? Yeah. Of the tibia going forward, the hamstrings, which are going to be the muscles in the back, are going to compensate and try to hold it back as best as it can. While inversely, again, if the PCL is damaged and we can't do that posterior translation anymore, what's going to help try to limit that to the best of its ability is going to be the quadricep, which is going to compensate. And understanding that the opposite muscle will restrict the movement. So like even though semimembranosus and tendinosis we associate with internal rotation, when we do like manual muscle testing of the hamstrings, it will do the opposite when trying to resist motion. Yeah. Oh, this is important. They were really nice and got the numbers. Remember when we were talking about the gastrocnemius, that big buff muscle in the back of your calf? So below the knee and the back of the leg is going to be two muscles, the gastrocnemius and the soleus, the ones that help you go on your tiptoes. So when you're doing a test, which we explained, you have to get to a certain number. If you can get to 1, that means you already got a 3 out of 5 score. It just now depends on your range. So from 1 to 9 it's going to be a 3 because you can go against gravity, while 10 to 24 will give you a score of 4 out of 5, and 25 plus will give you a 5 out of 5. Yeah. Understand the gastroc is going to be a knee flexor and a plantar flexor because of where it originates, and basically if you were to do a muscle length testing, you're just pulling in the opposite direction. Muscles that do dorsiflexion and plantar flexion, really just the anterior part of the foot and the posterior part of the foot, summed up here. Ta-da! Ta-da! How do we find the posterior tibial artery? We talked about it. Wow. And this is the extra. We're done! We're done, I think. I know the document had moved, so let's see. Please, no more. I want to be free. I might have done a kind of a poopy job because I did make my own little study guide onto this, and I feel really bad because we could probably all have one in case this doesn't have the updated information for my classmates, but I thought we were done and I didn't think there was gonna be any editing, so whatever. Let's just go back up or go back down. Yeah, let's just could look at free foot pick. Anyway, so yeah, we're done. We're good. I did it. I acquired the knowledge. I did after 7 hacking hours. I did it. Yeah, I should probably go prepare for my exam now and take a little mini baby break. Cups, thank you for being here, question mark. There's no question mark, question mark, exclamation mark. Like, you did not have to be here for sure. I could have just spoken to the void, but you being here definitely made the experience 100% better and gave me motivation to be like, I'm trying. I really am. So hopefully about this time tomorrow, I'm taking my last final exam for the entire second semester of my bearcat school. I will move on as a third semester, or I guess trimester, they go by trimesters, whatever. Student, I am one semester closer to graduating and getting into my dream career, and life will be good as I die. Nice. But yeah, don't forget tonight we're going to be doing anime night again. I know it's more of a Monday thing, but Big Ham, now that I got your attention, hi Big Ham. Big Ham, do you want to start at 8:30 or 9 p.m. EST? I know you have stuff. Let me know what time works for you. Soldier boy, tell him. So yeah, we're gonna watch only Full Metal Alchemist because we already watched the last 2 things yesterday. Yeah. Hope the test goes well. Thank you guys for being here. Good night. I wish I could sleep, but if you're going to bed, please have a good night in the sweetest of dreams. Best of luck, Tip. You can do it. I'll be squeezing my thumbs for you. Oh yeah, the squeezing. Yes, I remember. Thank you. I will also squeeze my thumbs just as equally. 9 p.m. EST, good? Alright, that's great. That works for me as well. Good luck. I'm drawing all my brain cells at you again. I will politely receive them. I'll politely catch the thumbs. the brain cells. I will. Let's see. Good luck, Tip. You got this. I'm gonna try. I'm gonna do it. Tomorrow. Whoa. Tomorrow, 2 days from now. This exam's gonna be so easy. I'm hoping. Man, there's so many people playing Cult of the Lamb. Don't get me wrong. Cult of the Lamb, good game. But I want to experience the game. Sorry, not to be this person. Let me check what this person's doing. I'll check with this Ultra Kill. That's interesting. This person's also doing art. This person's just chatting. Yakunki Simulator. Oh, that's cute. Sorry, not many raid targets. Do not mind me. Well, everyone just started streaming. Oh, cute. Also cute. I forget that Twitch has involved like these custom tags and everything like that. So someone labeled themselves as evil. Cute. Anyway, let's get the raid message going while I figure out who we're gonna raid. I'm waiting for these ads to pass. Holy heck, these ads have been super aggressive on Twitch lately. But yeah, thank you everyone for joining for the Cup Club. We're just still deciding on who to raid just to see what they're up to right now. So give me one moment to decide. And if I cannot decide for whatever reason, I will. Oh, I raided into this person before. Aw, heck. Oh yeah, Hoshia recently rebranded, so that's cute. I know we had raided into this person, and this person is playing in Ultra Kill, and this person is doing art. Sorry, I don't know who to rate. Let's see. I'm just curious about this Ultra Kill game. But I also want to support a rebranding. No! I hate it here. Da 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 da. It's a speedy game? Do you like it? It does look like a speedy game. Oh, I meant to put art in there too. Oh, whatever. 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 Christ. That's fine. Speedy game, I don't know. What is a recent speedy game that just came out? It's the one that has like the cringe anime dialogue, and it's like a very white game. Very stylized, and I think it has like cards that you decide the skill. I also wanted to play that one. I'm here at the end. Ashley, please! Hi, K-Dog, by the way, as well. Hi. Don't be afraid if you want to say hi. No worries. Neon White, yes! Yay! Yeah. Speaking of CD games, that's also one that I'm like, oh, whoa. Ashley, I'm sorry you made it for the end. I have to go learn pelvic tilts and stress out about the exam I've been talking about for like 7 hours now. Aren't you proud of me? Aren't you proud of me, son? I did it. I'm super ill. Oh, you're super ill? Holy heck. Please feel better. I'm wishing you the best of luck in recovery because being sick is no good. I'm sorry. I hope it's nothing super serious. I hope it's just like only kicking your booty just a little bit. You got COVID? Okay, well then. Never mind. Never mind. I hope, either way, I still hope you're really well and that you have the appropriate stuff in your body to fight this off. Sorry. Anyway. Oh my goodness, what else? But no, please feel better. Anyway, so now I'm wrapping up the stream, my brain is like I think I put myself, let me look at my stream schedule really quick. Yeah, so on Thursday I'm working, so after work I hope we can play more Cult of the Lamb, so I'll see you guys Thursday at 3 p.m. PST, hello? EST, and then on Friday it's gonna be a Cup Club Tuesdays at noon, so basically let's see what we're gonna end up doing. I know I've been playing a lot of Cult of the Lamb. I would not be mad if we played it more again. I probably can't put Persona on that list because I don't want to do the grind on there. And let's see what else. Near Valhalla one day. And all that good stuff. So yeah. Hopefully I get to see you cubs then, okay? For now, the poll's basically ending. It looks like we're going to be raiding into Shady Desu channel. They're getting over this one obstacle that I'm hoping the best for them because I think they've been stuck here for a little bit. And life will be good, okay? See you cubs Thursday at 3 p.m. EST. Sorry. And hopefully I'll let you guys know how this exam goes. If you never hear from me again, I'm sorry. I'm straight up sorry. Alright. Read message again because I just want to copy and paste it for myself. I'm so sorry. Alright. I'll see you guys then. Bye. Thank you for joining me. I appreciate you. But now I just realized it's almost 6:30, so now I have to go rush. Lots of love to you. Thank you for joining. Hopefully this could be the last study stream in a while so that we can always have fun and play video games together. Thank you so much again for your time. Please have a good rest of your Tuesday. Bye. I was a rapper in another life. Not gonna stop.